Imagine what 1 million healthcare professionals could do if they work together to shape the future of our healthcare industry. Introducing the Global Health Impact Network, a clinician-driven collaborative network of communities focused on healthcare innovation. Through intra-organizational, intra-community, and inter-community collaboration, GHIN enables healthcare professionals to become leaders in healthcare innovation at the precipice of the evolving digital healthcare revolution. Clinicians, C-suite administrators, and others can actively participate in all aspects of the healthcare continuum. Healthcare organizations, including hospitals, academic institutions, and nonprofits, can securely and safely share their ideas and innovations on our platform so that healthcare professionals can create a future of improved access to healthcare, improved care delivery efficiency, and safety while decreasing the spiraling healthcare costs. A pediatrician can interact with top experts to access and learn best practices when approaching pediatric oncology or chronic disease management. A doctor can engage with early-stage healthcare technology companies through our partnership with the Global Health Impact Fund. No matter the purpose, every member has a wide variety of opportunities to ensure active involvement. Please contact us if you are interested in joining our growing clinician-driven global healthcare innovation network. Together, we can shape the evolving digital healthcare revolution. The Global Health Impact Network. Imagine the possibilities.
Hey everybody, welcome to the Global Health Impact Network Summit. I'm your host, Martin Eels. First of all, let me thank every single one of you for coming today. We do have some very amazing panels coming up. So what we're going to do today is we will do an introduction to the Global Health Impact Fund and the Global Health Impact Network with Dr. Gary Goldman. This will be followed on by a talk with Dr. Alex Cahana with Blockchain and Health Tech. Then we'll move on to a physician burnout panel with Penny Stempel and Dike Drummond. After that, we'll have Bob Sweeney talking about the education part of Global Health Impact Network, followed by the future of TeleHealth with some very amazing panelists on this discussion. And then we'll talk about Lifescience and MedLabs with Dr. Ellie Lee. And we'll finish today with a couple of startup presentations from some very amazing startups that will be going through the MedLabs Accelerator. So I'm not going to keep you guys waiting. Let's jump into the very first talk. Please, ladies and gentlemen, let me introduce you to Dr. Gary Goldman, the founder of Global Health Impact Network and the founder principal of the Global Health Impact Fund. Gary, it's a pleasure to have you here.
Hello, everybody. And I guess in some places it's morning, some places it's afternoon, some places it's evening, given that this is a virtual as well as a live global conference. I'd like to welcome you all to the GHIN Global Summit for 2021. Global Health Impact Fund and Global Health Impact Network are also sponsors for the InnovatorMD conference, which will follow this conference. My name is Dr. Gary Goldman. I've been in healthcare for about 30 years. I started my career as a dentist, then became a physician and a practicing anesthesiologist. I've been practicing at the same institution for the last 35 years. In the early 90s, I started my first entrepreneurial endeavor. And that was at a time when the tech bubble was growing and the internet was just a new concept. The Yahoo portal had just come out. We were using 56K modem dial-ups, and any business idea that you put a .I in front of, you could raise capital for and develop a business plan. So it was kind of an ideal time to start my career. It was the true beginning of the internet boom. I've since been a serial entrepreneur and a physician informatics lead for an electronic healthcare record across a 27 hospital system in Northern California. All of this has afforded me the opportunity to consult across the country, working at the elbows with my clinical colleagues. Now, a common theme that I ran into as I was traipsing around the country as a consultant working with my colleagues was that the average clinician was disenfranchised. They were discontented in general with the direction in which healthcare was going. They felt that EHRs were making us less efficient and they were directly affecting our clinician-patient encounter in a very negative way. The development of much of the new healthcare technology involved had little input by those same clinicians. All of us that were practicing and taking care of patients, there was very little involvement by us in the active development process of a lot of the technology that was happening. Most clinicians felt that this was also the start of what was the precipice of a digital healthcare revolution. And now if we fast forward to current day, it became quite apparent to myself and the group that I was working with that at this late stage in my clinical and business career, that what we really lacked was a place for clinicians, our colleagues, to safely and securely collaborate, communicate, educate, and have opportunities to actively participate in this evolving digital health revolution. In addition, there were little opportunities for clinicians to invest and leverage. I always say, when was the last time that a large VC in Silicon Valley came to one of us and said, hey, we've got the next Google in healthcare, would you like to invest? It just wasn't happening. We were more in the trenches taking care of patients and having to use these new technologies. So there has to be a way for us to develop an environment where clinicians could invest and leverage their clinical subject matter expertise as advisors, as consultants for the developing healthcare and health tech innovations that were evolving. We needed a place that supported idea generation and provided the environment for healthcare professionals to actually become innovators and entrepreneurs themselves. That was when I realized that at this late stage in my career, I needed to start Global Health Impact Fund and Global Health Impact Network. My vision, our vision as a group, was to create a clinician-founded, funded, and managed network of professional, specialty-specific, and special interest-focused communities that actually promoted active participation and created the appropriate ecosystem necessary to support everything from idea generation through innovation, entrepreneurism, and then acceleration of that innovation, and finally commercialization of those ideas into actual digital health successful exited companies. We never anticipated a global pandemic in the process. We started this about 4 years ago, and as horrible and terrible as the pandemic has been globally and worldwide, it has also provided an acceleration for the need of this technology to facilitate care at a global level. So here we are 30 years later, attending a global hybrid clicks and mortar, as I refer to it, summit supported by those technological advancements. Today, I'd like to welcome all of our clinician colleagues, both live and virtual, doctors, clinicians, health professionals, as the founder and managing partner for Global Health Impact Fund and the founder and chief executive officer of the Global Health Impact Network. It's my pleasure to talk to you about our fund, which is what I'd like to focus on right now, what we do, how we try to inspire you to be a part of the innovation ecosystem. At Global Health Impact Fund, our primary ethos is that innovation happens best and most efficiently when you, the clinicians, are involved in the process. By that, I mean that if you have an idea, a solution that you think can transform medicine, transform healthcare, your best partners early on will be those individuals like myself and our network, and organizations that implement, understand, and work with solutions such as those on a daily basis. As clinicians, we're in the trenches. We're doing the work. We're here taking care of the patients. We are the ones who understand what needs to be developed and what needs to happen. We understand how it happens. Bringing that ideology to the table is something that we've experienced as extremely valuable at Global Health Impact Fund, and soon you'll hear about the network. As GHIF, as we endearingly refer to it, we are democratizing investment opportunities. For the last 3 years, we have invited physicians and other accredited clinicians to be part of our fund through small investments. We've been able to raise almost $10 million in capital, and we've invested in what certainly I and our group believe are 10 amazing market disruptive health tech companies. These companies span the gamut of global digital health solutions that can improve childbirth by monitoring fetal oximetry non-invasively through the abdomen. A point-of-care sleep medicine platform where now a sleep medicine study can be performed at the point of care at the patient's home as opposed to in a sleep medicine clinic. And then the ongoing remote patient monitoring and care of that patient happens at the point of care. A musculoskeletal compliance and remote patient monitoring platform, which now allows physical therapists, orthopedic surgeons to actually track the progress post-operatively as well as post-chronic condition in terms of the progress that they can make with therapy and being able to monitor progress and success at the point of care. We have the telemedicine solution that promotes transparency and specialty-specific clicks and mortar care. We have a CT angiogram artificial intelligence solution, that's a mouthful, helping to predict and promote early stroke and cardiac disease in a non-invasive way. It's a solid distribution of companies that provides a risk-stratified, diversified investment opportunity for our clinical colleagues in a way where our investors also have the opportunity to participate in the due diligence process as subject matter experts, as key opinion leaders, and post-investment to actually not just be a passive investor, but to actively participate as advisors and consultants for our portfolio companies that we've invested in. We are very proud and excited to share our fund portfolio with any potential interested accredited clinician investor. We've leveraged our entire process on our proprietary hands-in platform where our investors promote and act as advisors and consultants with those companies directly on our collaborative platform. And we're very excited about the success and growth that we have by leveraging that with new follow-on funds that we'll be developing. I'd like to invite you at this conference to consider the role that you could play in innovation and the role that you could play in venture capital. We need your help. We want your help, not just as an advisor, but as an active participant in our growing global collaborative network. We encourage you to join us and to be part of the process. As I mentioned, we're going to be raising another fund shortly, and there is still opportunities to invest in our current fund that is closing shortly. There are also opportunities for individuals to advise the fund and just participate without making an investment, become part of our fund network and our Global Health Impact Network. We leverage our Global Health Impact Network and our proprietary secure encrypted GHIN hands-in collaborative platform, and we have been very strategically positioned to support our companies post-investment because of that. Firstly, as we identify companies, part of venture is finding the best companies, what we refer to as getting deal flow. Leveraging the expertise of our clinician investor network, we've been able to do that really well. We also have terrific partner networks, and we're affiliated with many of the major medical institutions and academic institutions throughout the country by leveraging the connections that our investors and advisors have domestically as well as globally. Our experience so far is it helps to have other physicians and other clinicians looking at deals with us. We get practical insider insights that are easy to understand. We have access to our clinician insiders, which is not an easy thing to obtain. That's the value of our network as a strategic investor in many of the companies, because other organizations, it's very difficult for them to obtain those key opinion leader thoughts and input outside of if you're already involved in the medical world, so to speak. As such, we then can see value where other people don't, where other venture entities don't. Once we've decided to make an investment, we found tremendous power coming from the collaboration and feedback from our Global Health Impact Network. This is real value in terms of supporting the companies towards a successful exit. When we mean exit, we mean either an IPO or a merger or an acquisition where now we've made an investment and that company then turns into a liquid event. So, of course, when you invest in venture, you want to obtain an exit, right? So your investment is illiquid when you start. As I mentioned, you own shares or some sort of security, and a company at some point, they either get acquired, as we spoke of, or they do an IPA, And if they do, that illiquid asset then becomes a liquid asset. That's when we get our upside of the investment. So that's the goal in venture capital, to transform a company, to help scale it, make it impactful, but then as an investment to get that liquidity event. We help those companies do that. Throughout our network, we've helped our portfolio companies through the implementation of pilot studies, introductions to hospital systems. We've built focus groups from our clinician network, and we help with recruitment of executive teams post-investment. We can identify chief medical officers that are appropriate, and clinical studies and researchers that can help in helping a company develop their idea and then show how it's clinically effective. We've been able to collect those resources, foster collaboration with our clinicians and our companies, and develop those processes. So I invite you today to consider what your role could be. You could be an innovator as a physician or a clinician innovator. How can you add value to our investment process as an investor, as an advisor, as a consultant? We will allow you to target which companies you could add value to. We allow you to leverage your clinical expertise in a very targeted way, and to then focus on your interest and seek out those experiences that you're looking to have and gain through our network. You all have hugely valuable knowledge and experience that these companies want, and often have a hard time finding or getting access to subject matter experts like yourself. Throughout this conference, you're going to hear a lot about how to be involved. Our charge to you in this introduction is to say that there are really opportunities out there. Find the one that works for you. Look at executing it, and then go for it. Get involved and actively participate in the fund, in the network. Global Health Impact Fund and Network needs you. We want you, and we really appreciate that you're here at this conference and taking an interest in everything that we do. If you're interested in learning more about the Global Health Impact Fund, of course, we'd always love and need more advisors and more investors like you. You can reach out to anyone on our fund team directly. I'd like to now take the opportunity to chat a bit about Global Health Impact Network itself. As we mentioned earlier, a Global Health Impact Network is a gathering of professional, specialty-specific, and special interest communities. We promote collaboration, communication, active participation, and education by clinicians in the evolving digital health revolution. We've developed a proprietary hands-in platform through our partnership and investment in Hands-In, which promotes safe, secure, video encrypted, and asynchronous collaboration and communication by our clinicians. We've grown our clinician and health professional network organically from a global perspective over the last year and a half. We have about 90 communities that we've created across professions and specialties and special interest areas. Examples are physician and clinician burnout, blockchain in healthcare, AR and VR in healthcare, assisted intelligence and machine learning in healthcare. And then we have many innovation-specific specialty communities as well. We currently have close to 1,000 clinician members, and it's our goal over the next 24 months to grow globally, and our target is 1 million members globally. We're in the process of creating Global Health Impact Network in Africa, in Europe, in Israel, and many other global locations. In addition, we're also working on a very large network in India. You'll hear a lot about this at the conference from our clinician and health professional community leaders, and it'll be across topics from our collaborative network. So at this point, I'd like to bring back Martin, and Martin and I would like to have a little conversation just about what we're doing with the network, what our plans are moving forward, how we plan on growing it through developing a finance and investment in healthcare network, an education network, and we're also just beginning our new MedLabs Accelerator program. Martin.
Thanks, Danny. It's good to be back. So, let's kick off first with let's talk about MedLabs and the accelerator we're doing there, because I know it's one of the biggest things we're doing this year. So tell us the story. What's MedLabs?
Great story. So, one of the fund partners, Oren Aloni Charis, who's one of our managing partners of the fund, made an introduction to Ella Lee, who's the CEO of ZGC. ZGC is a global capital organization whose parent company is in Beijing. They have numerous innovation hubs globally, including one in Boston and one in Silicon Valley, which is right down the block from certainly from many of us here in the Bay Area. And when we were introduced to Ella and their Silicon Valley group, they were in many verticals, but they were not in healthcare, and they were very interested in entering into the healthcare vertical from a capital perspective and from an innovation perspective. When they found out about Global Health Impact Network, they were very interested in partnering with us, because what we brought to the table for an accelerator, of course, were all the mentors and advisors and clinicians from a global perspective. So it was kind of a marriage that was made in heaven, so to speak. So we spoke for a couple of months and then decided to build the MedLabs Accelerator, which is an accelerator, a global accelerator focused on promoting innovation in healthcare, everything from early stage seed idea generation through Series A kind of companies.
Great. I know I'll speak with Ella later on, so it's going to be exciting. And then I think what I want to talk about next is something, I'm going to be very close to, the finance and investment community. What's the purpose in your vision for this community?
Great question. And I'll take maybe a little step back and say, the focus and purpose of the network in general is to create an agnostic environment, through the platform that we have. And if, you were to compare it to what's out there already, we've kind of taken the functionality of a LinkedIn, a Slack, a Dropbox, and a Zoom, and put it into a HIPAA compliant, secure, encrypted environment, allowing that kind of collaboration. So the idea being, again, we're not trying to be like Medscape or a clinical Doximity. We're more focused on innovation and acceleration of ideas in healthcare. So we want to be agnostic. Yes, we have a fund, but at the end of the day, when you make an investment, even as a venture fund, it's usually a syndicated collaborative investment. It's never just one VC. It's usually some angel investors and other VCs, and they come together to accelerate and invest in a company. So it's always a collaborative encounter. And the goal of the network is to take not just the clinical side or the clinical innovation side, but to take every aspect of that ecosystem of idea generation through commercialization and foster that kind of collaboration. So where better to start when we started with a fund than to focus in on the investment side of things, the finance and investing. So we're creating a global network community of other venture capitalists, other angel groups, where we can come together and focus in on how do we identify those best technologies? How do we leverage our network of clinicians and subject matter experts and key opinion leaders in a way to make it available, not just for GHIF, but to make it available to these other organizations which may not have easy access to it. So that really is the premise of creating a finance and investment network. And then, of course, hopefully we'll talk a little bit about the education side of it as well, from an innovator as well as an investor perspective.
Yeah, so all right, let's touch on education just a little bit, because I know Bob Sweeney is going to talk about that later in a little bit more detail. How does the education and the network kind of join together?
Great question. Thank you for asking it. Of course, I certainly have a passion for it. I didn't go through my serial entrepreneur experiences, but my first company back in the early 90s was one of the first continuing education platforms, where we took, in a time when we were using 56K modem dial-ups and the Yahoo portal had just come out, we had developed a way to create and then deliver and use continuing education over this new internet idea. And it was an early idea. We developed one of the first internet-based learning management platforms to develop and deliver that content. But there were no talking heads and videos in those days. It was more white papers. I don't even think PDFs even existed at that point. And we started that, and it was very interesting for me because I had never had any business experience prior to that. And I went out and I was able to write a business plan in the middle of that internet boom that we talked about, and went out and was able to recruit numerous clinicians, physicians at the time as investors, as advisors, and we built the CE channel. Now, the CE channel ultimately was acquired by Med Challenger, which is one of now 25 years later, the oldest board certification, recertification, continuing medical education platforms that's out there. And the CEO at the time was Bob Sweeney, as you mentioned, Bob. And Bob is now a partner in our fund, and he is the director of education for Global Health Impact Network, Education Network. And so the concept is, again, not trying to be just a clinical continuing education network. We're bringing in every aspect of, again, the ecosystem of what we talked about. So how does an individual clinician educate themselves about becoming an innovator, becoming an entrepreneur? How do I start a company? How do I invest if I just want to be an investor? What if I'm so busy, but I'd really like to leverage my subject matter expertise as an advisor, as a consultant? We have all of that being built in our educational network. And then we also, again, in the idea of collaboration, have gone out and partnered with larger organizations like Med Challenger, like Med Forums. We're talking to Mocingbird, one of our potential investments in Accelerator cohort companies, to be able to pull all of those ideas together into a more global educational environment that gives access to our individual clinician and health professional members to educate themselves about all of these things. And, even have the opportunity to maybe get some continuing medical education at the same time as they're learning.
Yeah. So we've mentioned collaboration several times. Like, how important is collaboration, not just like among investors, but among physicians and clinicians? And, second part of the question is, if anybody who is interested in collaborating with a network, how do they do that? What should they look for?
Great question. Well, we'll start with the first part. So it's interesting. It's been very educational for me, again, in 35 years of practice, that I've been, we're very big as an anesthesiologist. I'm very focused on there's a term we use in healthcare: keep it simple, stupid. So, the more simple things are, the less chances there are to make mistakes and the better an outcome. So from my perspective, I've reduced everything to a collaborative encounter, whether it's a patient and a provider, whether it's a provider and a provider, whether it's a provider and an organization. No matter what it is, it's all a collaborative encounter. And we're very lucky to live in a time where we have all this technology that promotes that kind of collaboration. So for me, all of those are encompassed in what we're creating within the network. It's providing all of those different parts of the ecosystem to collaborate, but to do it, again, in a way, we're all on the other social networking, platforms that are out there, and they're all great, but they're not exactly very secure. You don't always know who you're talking to. If it's a bunch of clinicians talking together, the last thing you want is a number of non-clinicians sitting in the same room listening to what are probably intended to be very secure conversations. And I'm not going to throw out any names, but we all know what I'm referring to. So there was no good place for us as clinicians to come together to discuss these kind of topics in a secure environment. So that was the idea of creating the network in this collaborative environment. How can individuals get involved? Very easy. Go to www.globalhealthimpactnetwork.net and join. It doesn't cost anything. It's free. All of the resources within the network are essentially free. And again, it spans the ability to collaborate, communicate, actively participate, educate, potentially invest through us or other opportunities. All you got to do is join and actively participate. And we are trying to build it out in a way as we move forward to leverage what's out there: gamification, tokenization. We're trying to reward our members for actively participating and doing the things that they want to do anyway. And that's really the mission and vision of the Global Health Impact Network.
Okay. So a question that's close to my heart is content. We've had so many conversations about this. How can an organization or clinician, join the network and get that content out there?
Right. Well, so again, the network being composed of communities around special interest areas, professions, specialties. So we can get as 10,000 foot as I hate the term AI, but I'll say assisted intelligence and machine learning. I don't believe in artificial intelligence. I don't even know what that means, frankly. But technology that supports our ability or improves our ability to more efficiently and effectively take care of patients, right? It's not intended to replace us. It's intended to make us more efficient, right? So we can get as global, it's a good example, as AI in healthcare, but then we can get as granular as anesthesiology, artificial intelligence in healthcare, okay? So any individual within our network can, first of all, create a community if they have the membership to bring it in, right? Through, and again, it could be supported in other places like LinkedIn and Instagram and all of that. We're not only focused on GHIN, but that's a place for us to securely collaborate. So they can do that. And then they can also join communities. Again, they are secure communities. So again, if a cardiologist is trying to join the anesthesiology community, they could get in, but they'd have to ask. Whereas we have public communities, private communities, and any individual within a community can post on our threads, can present content. Again, we do try to, within the network as we're building it, it's a verified, validated, credentialed environment. So we're trying to really control the content to an extent that's in there, as opposed to just letting all comers in. But any member of any community can post and foster additional collaboration. They can promote educationally content. They'll have the opportunities and the technology to do that as well. It's actually quite easy to do.
Awesome. Well, is there anything else you want to add? Because if not, then I think I'm going to open this up to a Q&A session for the audience to ask questions, because I know they must have.
Great. Not really, other than I'll say is, we really would love to talk to you as a potential member for our network. We would love to engage you as an active participant in our fund, in our network, in any way, shape, or form. We're all your colleagues and your clinician colleagues, and we're very respectful of how busy we all are, especially in the middle of this pandemic, which hopefully is starting to wind down a bit. But it's a way to really expand your practice experience in many ways outside of just the clinical aspect of it. And we all find it very rewarding and love the collaborative aspect of being able to work with you as a member and address your desires and your ability to participate in the evolving digital health revolution. You can reach me at either one of my emails. It's Gary@globalhealthimpactfund.com or Gary@globalhealthimpactnetwork.net. You can reach us on our websites, which will be all over this conference. And we just thank you for attending the conference. I hope you enjoy the conference, and we hope to hear from you soon.
Awesome. So yeah, let's jump into the Q&A session.
Okay, great. Okay, that should be better. Okay, I'd like to again welcome everybody to the conference. Thank you for taking the time to listen to my long-winded description of the fund and the network. It's been a great trip getting here, and I'd also like to thank Uli Chetapalli and the InnovatorMD conference for us as a sponsor, giving us this whole day to promote Global Health Impact Fund and Global Health Impact Network. I'm going to look through some of the questions that I have. Apparently, I have two microphones on. I don't know how that is, but let me close all my microphones. Just give me a second here. No, shouldn't be here. I only have one microphone on, but I will close everything else. So I'm just going to bring up some of the questions that I had. I apologize for this little delay. Okay, so questions. So there were questions, first of all, is how does one become an advisor or a mentor in the network or in the fund? Just feel free. We posted it inside the chat. You can reach out to me at my email at gary@globalhealthimpactfund.com or globalhealthimpactnetwork.net. And feel free to reach out to us. We're happy to share information about both the fund and the network in response to that. You can also go to our websites, which would be for the fund, www.globalhealthimpactfund.com, and for the network, www.globalhealthimpactnetwork.net, not .com, for the network. The network is expanding globally as we speak. We're looking at having partner organizations in India and Africa we're exploring, and Europe and Israel. So there's lots of opportunities to expand the network. So that's how you would become an investor and advisor. Let's see. So Joyce says, I'm working with a few early stage startup teams for RPM, blockchain, home care, provider engagement, antiviral treatment, focusing on COVID. I would love to share what we have. So that brings up another point. So our network is not just a network of only clinicians, but we are creating an ecosystem around innovation. So we do support everything from idea generation all the way through commercialization on the startup side. We support clinician innovators, clinician entrepreneurs. So any organization that we just started, as we mentioned, the MedLabs Accelerator, we're building an innovation hub. As a matter of fact, Uli and I have been talking about that. So the idea is that at any stage of a company, you can step into the network and leverage the communities around specialties, professions, and special interest areas, as well as the communities that we're building around the entire ecosystem of taking a company from idea generation through commercialization. And we will work with you. We will help you. We're creating a finance and investment network, which is partnerships with other venture capital funds, other angel investment groups. We're looking at democratizing the investment process for clinicians. So no matter whether you're an EKG tech or whether you're a cardiac surgeon, there will be opportunities to participate as an active advisor or mentor and to participate as an investor in the process. And when it comes to the companies, they're welcome to come and participate in our accelerator or just to participate as a supported company. If we're going to accelerate you, you will go through the due diligence process just as if our fund was going to invest in you, because we are trying to become the good housekeeping seal of approval for healthcare innovation and startups. So we will work with you to refine your idea, your management team, and your presentations. So startups are welcome. Reach out to me the same way. How do we spell the other network that I mentioned? And that was to Ella. So there's the ZGC Capital group, which is our partner in the MedLabs Accelerator with Global Health Impact Network and Global Health Impact Fund. And that all could be found if you do a search for MedLabs Accelerator. You'll be able to find the website and information for that as well. Joyce asked another question: do you support, invest healthcare-related products, techs, and companies? Our initial fund, which I mentioned, was focused mostly on digital health and digital innovation, but our subsequent funds that we're starting are going to be more focused more globally on health tech, Bell Tech innovations in healthcare. So we are open to looking at any healthcare innovation companies. So the answer would be yes, and you can reach out to us that way as well. Does GHIN make profit, and how does it do so? Great question. As a matter of fact, we're evolving right now. We're looking at creating a non-for-profit arm and a potentially looking at a foundation fund for very early investments in early stage idea generation companies. And there are also many health tech companies that need clinical validation studies that need to be done. So we're looking at having a non-for-profit vehicle for investment early on, which then would be followed on by the network support, the accelerator support, and a for-profit model for investment. So the network itself makes most of its profit, and we're in the very early stages of this, by the way, through our relationships with the startup companies, through education opportunities that we provide. We're building the network in a way where the members are also investors in the network and have the opportunity to invest directly in the network. So as the network grows by working with startups and its valuation increases, the members themselves benefit as well. So that's another way. Of course, sponsorships, but in a very agnostic way. So the network is built on a credentialed, verified environment. So unlike some of the other social media, when you're a clinician in our network working with companies, it's in a very secure environment, our hands-in platform. And everyone that you're speaking with, you know who they are on the other side of it. This is not an all-comer network like a Clubhouse or like a LinkedIn. So we do bring in sponsorships in a way that is somewhat agnostic, where it's those organizations, healthcare organizations, that want to get exposure to our large clinician network. Okay, so that's that question. Let's see, one says voice, not able to hear. Well, hopefully that's fixed. Am I the only one? Okay, so no, it sounds like we've got the video component fixed here, and I'm checking my text. Let's see, everything's working great now. The United States is the epicenter of COVID-19 pandemic due to the tens of millions of illegal immigrants. If we couldn't count these people, how could we control COVID-19? Well, that's a great question. Not really related to what we're discussing today, although we are looking at many health tech and companies that are addressing the problems related to COVID-19. I think, as I said earlier, health tech has been accelerated probably close to 5 years in 1 year because we've shown the gaps in the healthcare technology system because of the stresses and requirements that's been imposed on us by COVID-19, and we are far from out of this. So I think it's imperative that what we're trying to do, again, is the whole premise in which I founded this fund and network was the idea of promoting active participation by clinicians in this process. One of the biggest complaints that we've had and concerns by healthcare providers is that we've let healthcare get somewhat out of our control. So this is the purpose of this network and fund is to improve and empower clinicians to be active participants in these solutions with a goal of one thing, improving the patient-provider interface or collaboration. So how do we leverage technology to improve our workflow as opposed to make it more complicated like electronic healthcare records have done? That's just one example of the direction in which this evolving digital health revolution has gone, and we're working to change that. Let's see, what else do we have? Any integration, cooperation between healthcare startups? Absolutely. Great question. Hanan, I love that question because the whole focus of our fund and our network was to foster collaboration with synergistic investments and synergistic portfolio companies. If anyone's ever been to the HIMSS meeting, which is coming up again very shortly, it's 2 football fields worth of hundreds of companies that don't talk to each other. And it's one of the reasons that we are where we are with electronic healthcare records and developed a system without interoperability. So it's our goal to invest in companies and to work with companies in our network to foster that collaboration in a way where we can together as a network bring solutions to the table that can speak to each other and can work synergistically. So thank you for that question. June, it sounds like you help people match for innovations, organization, and individual expertise and fund investment. I'm not exactly clear how people get paid per individual negations. Well, again, so I guess the question is how if I act as an advisor or a consultant in the process with companies, how am I compensated for that? So from the very start, it's been about 2 years now, the very start of our growing our network and our fund, those clinicians that actively participate in everything from due diligence through the commercialization process as advisors and consultants have relationships with the companies that they work with. So they're not being compensated for by the fund or the network, they're being compensated by the portfolio companies that they work with. On the network side, what we're building right now is with some blockchain technology, and you're about to hear from Alex Cahana shortly, who's helping us with this, who's a global expert in blockchain and healthcare. We're building into the network an idea of tokenization and gamification so that when our members are actively participating in events, in educational endeavors, in just collaboration across our different communities, they will be rewarded with a set of points that can be used for other services within our network, for CME, for credentialing services, and other partner services that we have. So that's on the individual member side. And on the startup side, the startups benefit by having access to our Accelerator services, our financial and investment network services and matching, so that we're not just interested in getting funding for just Global Health Impact Fund, but also our partner funds. Because in the venture capital world, which was educational for me when I first started this, it's really less competitive and more collaborative and syndicated. So it's very rare that just one VC or one angel investor invests in the company. It's usually a syndication of a number of different types of investors. And we have other partner networks that are out there. We have Startup Health. There's Angel MD. There's a lot of other organizations which we're looking to be agnostic with and work with to help improve and foster the digital health revolution and health tech. So that's that. And I don't see any other questions. Maybe what we can do now is show a little video about, so we do have our platform. Oh, wait, there's another question that popped up. Any use for newly graduated outpatient primary care perspectives for consultation at GHIN? How do you recommend to start outside of building connections and joining networks such as GHIN, SOAP, Innovations, MD, etc.? How do you recommend to start outside of? Well, I guess if this was a question of here I am at 64, I've been doing this for 35 years in healthcare, serial entrepreneur. If I were starting over with all of the opportunities that young people have now, young clinicians or even pre-medical school and want to get involved, there are lots of social networking and organizations like what are mentioned here. SOAP is great, Arlen Meyer's organization, which is a non-for-profit, and then Uli's InnovatorMD. We're all collaborating together with the same goal of improving healthcare through leveraging of the clinicians and clinician entrepreneurs. So I would say just join the network. It doesn't cost anything to join the network, no matter what stage you are. We're out actually now starting to develop out different sectors within the network. So there'll be students, there'll be residents and interns. There are nursing network communities that we're building. So all the specialties, all the professions and the different levels will be represented as we grow out the network. How significant is your collaboration with the medical startup companies in Israel? Well, our second investment was a company here who is now in Cupertino that came out of Israel. It's a market disruptive technology. It's called SensorFree. And SensorFree has developed a non-invasive way of monitoring blood pressure in a B2B way in a medical grade perspective. It's being studied in operating rooms and ICUs. So now, theoretically, at some point, a watch will be able to give you B2B blood pressures in the consumer sector, but in the hospital sector, what would have previously been an invasive procedure by putting an IV into an artery can now be accomplished by just slapping a EKG patch type of monitor over your radial artery or some other artery in your body. And as an anesthesiologist, we can use this in the OR. And before, we would only use this for medically complicated patients. We could use this in virtually every patient moving forward once this is FDA approved, and they just submitted to the FDA. So we work closely with Israel. We have a relationship. As a matter of fact, my partner, Bob Sweeney, and I are attending a conference in Israel in December, which is a health technology conference. Our partner there, Dr. Benny Zevi, who's a cardiologist, is working with us, and we're looking to build Global Health Impact Network Israel with their clinicians. So we absolutely do work with startup companies globally, including Israel. Is there any traction to fund for CRISPR startups and biomedical research companies that is resource intensive? Yes, as a matter of fact, as I mentioned earlier, we are building out the network for very earlier stage companies in those areas from a foundation perspective with one of our new strategic partners that we're working with. And yes, absolutely, we would entertain those kind of investments. And then let's see, at Manoush second this question. Okay, so great. So you've got an answer to that. I think that's all we have here, unless anything else pops up. So again, I think we'll stop here, and I'll take the opportunity to thank everybody for attending this conference, for being here in the middle of the week, listening to what GHIN and GHIF have to offer. We've got a full day packed of interesting talks. In about 10 minutes, we have, as I said, Dr. Alex Cahana, who is an anesthesiologist and global blockchain expert, who Alex is a good friend, and I've known him for quite a while now, and he's going to educate us and enlighten us about blockchain and distributed ledger technology and how it could be leveraged in healthcare. You know, I think many of us, when we hear blockchain, the first thing we think of is Bitcoin, but blockchain technology is much, much more than that and can affect many areas within healthcare, both on the patient and the provider side and the data integration side. So with that, I'll stop. And blockchain and credentialing, absolutely, and we can, he'll be addressing that. That just popped up another question. So yeah, so I think maybe Nicholas, if we can show, we have our hands-in platform, which has gone through MVP and version 1. We're about to release version 2, which we're very proud of, with its improved UI, UX, and functionality. And we've got a little short video that hopefully that we can show everybody. Let's see, this is in YouTube.
Today, most social media and communication apps can feel like a trap. Click by click, you navigate their maze of countless windows and hidden ads, and in the shadows, they secretly mine your personal data to sell for a profit. We have a better solution. Hands-In is a platform created for people to connect in private, secure spaces. Your data belongs to you, not us, and we'll help you to use it efficiently to make the right decisions. Within a single window, you can collaborate with teams or individuals, host and broadcast video chat meetings, seamlessly manage files, post social media links, and stay up to date with all your content on the dashboard. Even more, Hands-In allows you to build beautiful, customized workspaces to serve your community. Creating and sharing content has never been easier, whether you're video chatting with one person, conferencing with a dozen, or broadcasting to millions across the globe. Organizations like the Global Health Impact Network have transformed digital health by sharing their innovative discoveries across vast communities, all without ever leaving the platform. At Hansen, your data is not our product. Instead, we provide a simplified, seamless, and secure work environment for you and your mission. Hansen, building communities of the future.
I'm Chris Kager, the Chief Medical Officer of the Global Health Impact Fund and leader of the neurosurgery community on the Global Health Impact Network. One reason that I was drawn to the Global Health Impact Fund was the emphasis on physician-driven innovation. By integrating expertise from all corners of the healthcare world to build a system
Hey everybody, up next we have Dr. Alex Cahana, who's going to be talking about the future of decentralized health. Alex, it's a pleasure to have you here.
Well, thank you. Thanks for having me, and it's always a pleasure to be at the GHIN, the Global Health Impact Network conferences. This is wonderful. Thank you. My name is Dr. Alex Cahana, and I'll be talking to you about decentralized health. And hopefully by the end of the conversation, we will understand how we can change healthcare by changing our behaviors using behavioral economics. I wear many hats, as you can tell, but for this conversation, really think of me as someone who is interested in decentralized economies and on a mission to blockchainize healthcare and healthify the crypto space. So my background is I'm an anesthesiologist and I've been in pain medicine for way too long. I've been involved in the integration of technology and digital health before it was even called digital health for almost 2 decades now. I've been really intrigued and interested in decentralization and distributed technologies, mostly distributed ledger technology and cryptocurrencies, I would say since 2014. And for that work, you see here that I co-edited the HIMSS textbook on blockchain in healthcare. I have been working closely with the United Nations Commission on Distributed Ledger Technology Advisory and the European and African unions in regard to data sovereignty, data privacy, and data liquidity. To start the conversation, I think the most important is to what is digital health, and we've been living in this world of digital health for well into at least 15 years, if not 2 decades. But the data arrangement of it is centralized. We're used to thinking of large clouds and large data pools, and that's where all the information is hosted. For many of us, the interaction or interface with digital health has been a mixed blessing of, on one hand, introducing some efficiencies within the system, but also some feel that it has been onerous and perhaps distracts from the quality of, I would say, our clinical interaction with our patients. The official, I would say, definition of digital health is really this convergent of what we've seen in genomics and in computer sciences with health, but also with healthcare living in society. So the idea basically is to translate data that is accrued, be it in a clinical trial context or in real world data, and allow to develop actionable information where people can get better insights into their health and into their family's health and live better and more productive lives. And the idea behind it is that with that, healthcare will be not only better, but also cheaper and have a better satisfying experience for patients and also for the providers themselves, knowing the challenges and burnout that a lot of the healthcare community is experiencing. And we can see here these 170 exabytes of data that is enveloping our world, anywhere from the wireless sensors and devices that we're seeing, the mobile connectivity and the social networking, the whole universe, and some calls it the metaverse of creating avatars and creating our own digital twins, is really with the idea that instead of just tertiary prevention where we're treating diseases, is to actually engage into primary prevention and even in prediction and keep us as healthy and maximize our longevity as our genetics allow us. There are multiple technologies that are out there, and first thing you'll notice is that blockchain is not one of them, because I will try to argue and convince you that blockchain is less of a technology and more of a school of thought, or more of a governance mechanism of all these data that are generated by these core technologies. But the core technologies that we are aware of as physicians in our daily life is, of course, the remote care monitoring and telemedicine that has developed exponentially since the COVID pandemic started. There's now a little bit of reversal in terms of our willingness to continue and pay for it, but I think that nobody will argue the utility of the technology and the things that we can do now, thanks to our ability to see, monitor, and follow on patients from afar. The Internet of Things is more of a invisible or back-end technology that we take for granted. We don't realize the robustness of the machines that we use. Many of us think of the iPhone from our generation as a communication similar to the telephone, and very few actually think about it as a computer that is in the tip of our fingers. And really, the Internet of Things is that idea of bringing in these machines, be it in the hospital medical devices or at home in the smart home, computing power at the edge, that changes the whole data structure, anywhere from clouds to cloudlets, and their ability to communicate between themselves. And so some call it the Internet of Medical Things or the Internet of Health Things. And most, of course, familiar with us are our Fitbits and our Oura Rings and the whole wellness landscape that has embraced our ability to biohack the way we live. And artificial intelligence, which is a host of multiple things, is kind of like the overall title for different types of learning abilities that machines have that make them seem that they're intelligent. The whole discussion of either machine learning or deep learning or reinforcement learning or deep reinforcement learning can be a whole conversation on its own. But the idea, again, behind it is to create this seamless connection between data, information, actionable insights, knowledge, and eventually wisdom. And whether that wisdom will ever reach to human levels or better it by its ability to recognize things that perhaps we can't, or whether it can emerge with its own consciousness is a separate discussion, but it is clear that AI is a main contributor and disruptive driving force in healthcare. And it's not surprising that already there are reports from the first half of this year where private investment in digital health has surged, and in the first 6 months of 2021, it has already overpassed all 2020. And so there is a huge interest from the investment community to continue and develop these type of core technologies. And I specifically work in emerging markets because I believe that there is a real opportunity here to leapfrog these systems that in many places are paper-based and analog, and move into these new digital architectures that I believe should be decentralized and use, for example, blockchain technology, and not almost like obviate all the side effects and all the problems that we see in the current digital health system, not only in terms of cost, but also in terms of the user experience and the user interface, the friction that is involved, the capital leakage and cost that it creates, and really move into a system that is not only more friendly, but also can provide immediate more gains, both to patients and providers during their therapeutic dialogue. Now, if there's one thing that COVID has shown us, and it's shown many vulnerabilities, is that we need trust. And when I say trust, it's not only the veracity of the CDC guidelines or the consistency of whatever federal or state policies command, but also in terms of trust of the numbers of how many have been infected by COVID, how many have passed from what, anywhere to how many ventilators are they, how many hand sanitizers do we need? Is there really a shortage of toilet paper, or is a vaccination boost necessary? So the whole idea of creating pristine, reliable data that we know its provenance can be solved by blockchain. And the way I like to explain blockchain is that simply it's the software solution to the social problem of mistrust. That I want to believe what I see, I want to believe what I hear, I want to believe the contracts that I sign, but I can't. It turns out that it's not true. I don't know. There's some opacity in it. There's some inconsistency in it. And the decentralization of that data can contribute to the integrity of that information. Now, how does it do? How does it do that? And if anybody will Google how does blockchain work, they'll find out these type of things that I'm not always sure that they're very helpful or that we can actually understand what it means. The way I like to explain it to myself is, for example, for this presentation, I worked on Google Slides. And so I just put in whatever I want. I put in all the data and information that I thought was salient, with research, with some speculation, and just showed it to myself. But then I started to share it with other people. I made it distributed. So other folks started to look at it and they had remarks and they weren't sure that the data is accurate or that the statements are not misleading. And so I started to pay attention to the quality of that information because of the fact that it was not just centralized in my eyes, but it was organized in a way that other people were looking at it. And this is something that we call a private or permissioned blockchain. I gave permission to people to look at it before I sent it out. Now imagine that I would put it on a world computer where everybody in the world can look at it. Obviously, there would be a lot of eyes, and definitely there would be ideas to even improve this presentation way more than what you're hearing right now. And that is called a public blockchain or permissionless. So the idea is to create information that is not only centralized in the eyes of one or a few, but actually in the eyes of many. Where the real magic comes in is that once I sent it out, once I gave it to the organizers of this conference, I basically signed on it. I cryptographically locked it, and I said, okay, this is what I want to sign. And you can say, this is Alex at this day, at this time. It is time-stamped, audited, and we can look at the history of who changed what when. And this presentation became a block. And that is a block of data. Now imagine that block of data is done. I'm doing this every day, or every day I added a new slide, or every day I added a new presentation to my library. That is a chain. So it is a block chain where all this information is unchangeable, or what we call immutable. It is transparent. It is audited. It is traceable. And obviously the data in it is way more pristine than if I would have just written it all by my own and decide what information I do or do not want to include. So basically, blockchain is a peer-to-peer network technology that, from a physician's perspective, minimizes the need for trust agents. So the reason that we have not used decentralization is because we had all these trust agents around. We asked for notaries to verify our documents. We asked nurses to put witnesses on our medication disposal. We ask the front desk to pre-authorize or to verify certain transactions. So we've created a whole economy of administrators and billers and coders and brokers, and not just in medicine. This is in all wakes of life. We have created this economy of third parties that they are our trust agents, which we trust will represent us and represent the veracity of the data that's inputted. And unfortunately, this has not been the case. And in many times, we know that this data can be manipulated. And so this trust that we're talking about that is in blockchain is actually embedded in its architecture and in its structure. And the way I like to think about it, the advantages of it is, for example, with long distance phone calls. I'm old enough to remember that when I called Australia, it used to cost $10 a minute, and now it costs $0. Why? Because there's VoIP, voice over internet protocol. And so blockchain could be DOIP, data over internet protocol, and cryptocurrencies can be programmable money or money over internet protocol. And the reason this exists is because basically the internet itself has not, during its creation, inserted an identity protocol. And so I'm sure you're all familiar with the caption of the dog that's sitting in front of the computer saying, "Nobody knows I'm a dog." So here, this peer-to-peer network technology really verifies who is on both sides of that network. And so, as I mentioned, there are different flavors of blockchain. There's not one kind of blockchain or one kind of internet, if you wish. There are blockchains that are more public, they're permissionless, it's an open network where all devices can communicate, and the ledger, the list of informations, the list of slides or the list of numbers or calculations are open source and people can look at it. And then there are private blockchains that are permissioned, that they have to be permitted, and we're very much familiar in the healthcare system of the permissioned design, where only certain people, if you're an administrator or a healthcare professional at different levels, what they can or cannot look at. And then, of course, there are hybrid designs where parts of it can be public and parts of it can be private. Certain types of information you only want that people can have access to it, and you can revoke that access when you want, and others that can watch at all time and have access, like my information on the DMV or someone who wants to look up my number in the phone book. So this is called a hybrid or federated blockchain. Now, why is decentralization so exciting? Now, if you look here on the left, when you see things that are centralized, you can see that that's a honeypot. So imagine that white dot as a source of information or a lot of money. And these are around them are all these people that are trying to steal this money. And so you have all these people that are trying to hack. And this is really what we're going through. All these data centers and what we're seeing in medicine with ransomware is a net result of the centralized structure of healthcare networks. And so they are attack vulnerable. And so when you decentralize it, you don't have one point of failure, but you have multiple points where the amount of information is actually protected, because no one person can get all white points at once. But once you also distributed it, then those attackers actually become interdependent and become defenders. It's thinking about almost like the prisoner's dilemma, where you agree to collaborate or have a competitive collaboration because you have more to gain by working together and more to lose by working on your own. So it's really a community-based technology where you create economic incentives and also, I would say, computational incentives that protect the system from being hacked. And simply because if it is, then everybody gets hurt from that malevolent behavior or malicious actions. Now, one thing that determines the type of blockchain that any organization will use is part of what we call the blockchain trilemma. And so it means that you can have two, but you can't have all three. So if you want something that is really speedy and fast and super secure, it cannot really be decentralized. And so that's what we see, for example, in money transactions through our credit cards or PayPal or Venmo, where they are secure. I don't know about super secure, but they are secure enough, and they have quick transactions, so you don't have to wait for minutes for the transaction to go through. But again, you are totally dependent on the goodness of their heart. So if there is a hack to one of the companies or providers, or if there is a malfunction at one point, then suddenly everything can be lost, or everything simply will be frozen. Now, there are types of blockchains that are super secure and very decentralized. And one of them, the most famous one, is probably Bitcoin. And Bitcoin has not been hacked. It has been used as a currency for hacking. That's something different, but it has not been hacked. And so the reason is that because it is so decentralized and because there are so many people involved, it is protected in a way that the trust, the computational trust, makes its attack almost impossible. But then others, if you say, well, I can't wait for a transaction for 10 minutes, I want to wait only for 2 minutes, then you will have other flavors on it and other solutions of it that will have keep that decentralization and will be faster, but of course will be to some extent less secure. And when I say less secure, then each one has a level of tolerance. Do I really tolerate that I want 0% never, ever, ever being hacked, or am I willing to have a risk of 1 in a billion, 1 in a million, 1 in 100,000? So this is why we have different flavors of blockchains. And I would again, use the analogy that if blockchain is the internet, then all these type of cryptocurrencies that we hear about and we see, Polkadot and Cardano and Lightning and Stellar and so on, these are like different websites that are out there. So what does that have to do with healthcare, or what type of emerging use cases can we have if we agree that, again, as I said, blockchain is the software solution to the problem of trust? So since healthcare is a high trust environment, there are certain areas where blockchain can be extremely helpful. For example, digital identity management, supply chain management, the clinical research, and finances and insurance records. And this is really all the things that we've seen in COVID that really have not worked. The digital identity management of knowing who was vaccinated, who was not, transfer of information from one state to another, the records of the people who were infected or not, have been various levels of qualities that are influenced in state levels. And we know that there were states that manipulated their data for political expediency. The healthcare, the health supply chain management in the early days, especially when it pertained to PPEs, private protection equipment, and ventilators, there was a lack of interoperability and liquidity of that data that can be solved by the use of blockchain. And needless to say that clinical research is highly centralized, has a lot of friction, costs a lot of money, and many organizations opt out from doing real-time research simply because of it being cost prohibitive or functionally impossible to execute. And needless to say that there's a whole economics behind it, which I'm very passionate about, and I will speak to it a little bit later, where we can also include the users, meaning patients and healthcare professionals, in the economic activity that healthcare generates. So when we talk about identity management, what we talk about is person-owned, citizen-owned, patient-owned digital identity. So this is how we can track people in a way that keeps them private and keeps them in control. So obviously the identity issuer is something centralized. It could be the state, the government, the university, that could sit in an encrypted attestation in a cloud or in a decentralized cloud or on the phone of the user. And the access to it can be governed on the blockchain that register identity. And so data doesn't have to reside on chain. It's actually preferable that it doesn't, but the access to it is done on chain, and the data, raw data itself, is off chain. And whoever asks for that data, the user can give through giving access or revoking access, cryptographic permission to people to look at it. So you can understand this is very helpful for credentialing, or this is very helpful for locums. And so you can imagine a system where really we don't have to spend so much time, energy, and money in order to acquire these different types of identity that are asked multiple times for multiple reasons. If we want to track material, for example, then the supply chain, again, we are looking at multiple stakeholders that write into a ledger, and they can be monitored and given different accesses to view that data under privacy regulation. And so anywhere where the vaccine, for example, can have a temperature monitored label put on a blockchain register, and then the manufacturer can distribute it to the warehouse, and you can see under what conditions and when and who transferred the first batch, and then the second batch and the third batch, and it could be geolocated or geotagged. This can enhance the ability to schedule or to understand the inventory management of, for example, a vaccine. And when it gets to the healthcare provider can provide this information of either adverse event monitoring or any type of inventory management that is I would say proactive and agile, and go into reporting dashboards that then again the user or the provider can give access to different types of agencies. So in that way, we can digitally enforce these protocols and automate the reporting, and there's no need for all these intermediaries that can fail at each and every point. And when you track people and you track material, you really get pristine data. And here you can see where each person now has their own QR, they register, they can provide their pre-health assessment and do their screening tests. The healthcare professional can use a quote unquote blockchainized or validated vaccine where its provenance is known. The data then is married. And after that, it can be part of the whole digital health assessment and analyzed either for reporting or for predictive AI or machine learning analysis. So you can see that these technologies already exist. Now, the question where they are used or where they're not used or why they are not used is a separate conversation that I'll be glad to answer any questions about. But I just want you to leave with the strong impression that these things already exist. Another use case, for example, is clinical trial management. And again, we all know how expensive it is and how frictionful it is and how data and payments do not arrive in real time to the various stakeholders. And again, the idea is all the same, that the subject of the trial is the center through his or her digital identity. He gives or she gives access to either the healthcare professionals that participate in the clinical trial or the virtual primary investigator or other research professionals that are interested in that information. It is connected to other remote devices that can curate this type of data, and all stored on the device, or at least off-chain in a cloud that has access on-chain through the device, and that there can be a direct data transfer to the sponsored database. So again, we change it from a patient-centric to really a patient-driven process where the patient is motivated and advised to share information with the various stakeholders. And of course, for me, the most interesting and the most relevant for everyday life is really a patient-owned, self-sovereign, or patient-owned personal or electronic health record that is decentralized. And so it's based, again, on the self-sovereign identity that is anonymized. You can permiss or revoke access to these data. And so you can see here on the right-hand side, where on this access control, I can say, okay, for my daily diary, my physician can look at it, but he can only view it. He can't alter it. They can't alter their notes, or they can alter and edit. The prescriptions they can view and update and edit, and medications the same, and so on. So you can decide who sees what when. It can be time-stamped, and I can say, I will give it to to Dr. X tomorrow between the hours of 8 to noon. And so on. So these are traceable timestamp data, but most importantly, they are portable and interoperable. And that's very important because electronic health records here in a centralized structure have been built for brick and mortar. So if building A has one electronic health record and building B has another, and they don't talk between themselves, then it's impossible to transfer the information, and so the data becomes siloed and illiquid. Whereas if it is held by the patient is portable, and it can move from A to B and interface with the respective electronic healthcare system in building or hospital A and B. And I think the most exciting of all is that because it is on blockchain, it can be tied to programmable value, or it could be money, it could be services, it could be access to different types of features that can reward or discourage people to behave in a simple way. And we can almost take it one step further, and this is the work that we're doing currently now in Africa, where we incentivize patients to social distance, to wear masks, to participate in surveys, to eat well, to sleep well, to consume less unhealthy food. All these are part and parcel of the ability of the physician to impact the patient by inclusive economics. So a decentralized health ecosystem, again, in general, is based by a patient who has a self-sovereign identity that is theirs. It is immutable, cannot be changed, it cannot be tampered, it cannot be altered. It is audited and time-proof, and they can access it to any of the stakeholders, be it a doctor or a hospital or payers or research institutes or the industry. And of course, if we connect that again to currencies, and again, this could be real money, or this can be features that have value. I want to incentivize doctors to treat patients in a certain way, and I give them access to libraries or going to conferences at half the price, or I incentivize patients to eat vegetables and not smoke. I provide them access to insurances and copays and less cost following certain types of behaviors. This is all possible in a decentralized health and wealth ecosystem. And the last, I would say, use in the future, and this is why I'm so excited to work with the Global Health Impact Network, is that these abilities to provide verifiable credentials to the members of a professional community, then you can not only reward them for participating in that network and give them more of a voice, either by their reputation or by voting, but also to provide them opportunities to invest and get rewards in the cryptocurrency market. So to summarize, I would say that decentralized health is better when data is decentralized. It creates trust. And again, when I say trust, I mean computational trust, not just because Alex is Alex. I actually believe this because mathematically it is encrypted and unhackable. It is attack resistant, sensor resistant, and collusion resistant. So the temptation to fudge the numbers or change the numbers or fix them to our will is not possible. But most importantly, it really creates a community of users that are connected by a consensus that is built on what is valuable for that community. So a community of patients would be maybe different than a community of doctors or a community of nurses or a community of a consortia in the industry of pharma or medical devices. And it connects data in a way that we become interdependent and where our interest is to maintain the integrity of that data, because if everybody starts lying, then we really don't know what's going on. And this is really what we're living through, the fake news era. And finally, unfortunately, the macroeconomics of healthcare system excludes patients. It does not motivate them or tangibly reward them to behave in a way that is healthy. And if I would use, I would say, blockchain parlance, we use in the healthcare in the US death coins, because you get more coins if you're sicker and you need more tests and you need more procedures, and we don't reward them with life coins if they maintain health and exercise and sleep well and engage in mindfulness and in purpose in their everyday life. So I think that the future of where healthcare should look at is the burgeoning ecosystem of decentralized finance and DeFi. And the reason is because if you look at it, it is a sensitive, high trust, private data environment. It has multiple stakeholders, just like in healthcare, where there are payments and infrastructures and exchanges and custodians. You want to know your client, know your transaction, know the identity of who's using it. And you have different insurance and insurance products. And of course, the increased area of creating lending and credit for users of healthcare, and prediction markets and marketplaces for data. So at the end, I think the most important thing that is to think not about blockchain as a technology, because technology doesn't do anything. It's what people do with that technology. I would say that this type of decentralized school of thought will allow us to transition and transform from health service consumers to actual health and wealth producers. And this is really what we're aspiring to. So I'm really, thank you for listening, and I'm now open for questions and looking forward to answering it. Thank you very much.
Okay, great. Here we are. Alex, great to see you.
Good to see you. Thank you for the opportunity.
Of course. It's always, I'll take a brief opportunity to just to rave about Alex. Alex and I met a while back, and we've been working together now for a couple of years. Alex is just an incredible resource from many different perspectives, but certainly as a global expert in blockchain. He's also involved in some incredible initiatives across the globe, including in Africa, which Global Health Impact Network is hoping to get involved with and work with him with respect to that. And Alex is truly, as we say in Yiddish, a mensch. So I always use a little bit of Yiddishisms when I speak. So let's go through some questions here. We've got a couple. You know, I'm sitting in front of 3 different streams here. I've got a YouTube stream, I've got a Zoom stream, and then I've got a list of other questions that were provided as well. So let's go through that. So let's start with the YouTube stream. And actually, Nicholas has a question. He says, is there a blockchain project that could handle COVID vaccine passports, Alex?
Well, the short answer is, of course, yes. And there are actually multiple ones. I think that the longer answer is what is the intention behind it? And for this, I would urge people to read a bit about the history of passports in general. I wrote a post on this on Medium a while back. The question is, what is the intention behind these passports? Because originally, passports is to allow people to pass ports and to move from one place to another with an identity. And what has turned, especially in the, I would say, late 20th century, it has actually become an obstacle. Everybody who knows about visas and how to move from place to place, it has disenfranchised actually vulnerable populations. It's become a tool of centralized governments to actually control the movement of people. So from an approach of laissez-passer, where you let people pass, it is actually now a whole list of reasons why not to pass. And in that, now we have COVID. Now we have COVID as another reason. And so they say, okay, we need this and we need that. And so the true question is, are the passports integrated in a real global response to try to eradicate COVID-19? Is there a strategy? And if there's a strategy, I would love to hear what that strategy is. Forget the United States and the difference of what happens in every state. But in general in the world, is there a concerted effort to try to eradicate COVID-2 from our unit? Or is this, we're just going to have it with us like influenza with the cost of taking care of that every year? So the technology answer is very simple. Yes, there are applications out there. Some of them are a little bit better than others that have a self-sovereign, decentralized identity structure. Some of them have really nice front ends, nice interfaces. I just did one in New York because this morning I read that I can't go into restaurants without having a passport. And so I downloaded the New York State one. I put in information. I don't know who can see it. I don't know how it's protected. I don't know what the cryptography behind is it. But I said, you know what? For giving that information, at least I can go and eat, some delicious food. So this is really not a technology question. This is a question of what are our governments selling us on this story. And I think, and this is very important for the audience to realize, we are sold a story that is simply not true, where we have to give up all our information to stay secure. In order for you to stay safe, you got to give me all your information. You need to give me your secret bank account, your number. You need to give me everything. And like that, I can keep you safe. And that is a false narrative. There are decentralized technologies, not only in blockchain, there's federated learning, there's ways to transfer information for machine learning analysis without divulging IP or without divulging sensitive information. And so this is why, for example, the geo-tracking that at the time Google and Apple offered did not succeed, because we're here strong enough and private enough to say, wait a second, I don't want people to track me using Bluetooth with the false positive stuff. And so that's the idea behind it.
Great. Thanks, Alex. Great answer. Great, interesting question. It's an example of, you and I have been around on this planet a long time, and we've gotten to the point now where the technology has got beyond the needs of society, and we clearly haven't defined how it can be used appropriately. So the technology is there now, but now the world has to catch up a bit. So there's an interesting question here by Will Chen, and it says, can you comment on the energy input, quote unquote, sustainability concern of blockchain technology? Or does this concern only apply to virtual coin mining?
I think it's an important question, because we read it all the time, and this is why it's so important for media to actually come up with thoughtful pieces. I would recommend everybody to read Nick Carter, NIC Carter, CARTER stuff. The narrative that is behind the idea that Bitcoin mining is consuming more than Denmark, Greenland, Switzerland, choose the flavor of the week, is simply out of context. The use of energy to maintain the safety of the system, the safety of the network, is built in places where there is an overabundance of energy. In other words, not using it, that energy would go to waste. So this is not, I am taking away from cities or from rural areas that need that energy in order to mine cryptocurrencies. This is like, for example, anybody who knows aluminum, these are very intense technologies to create aluminum. And then with that aluminum, we go and we sell it and we use different things with it. So that is the same thing with cryptocurrencies. We move them and afterwards they serve different things. What is wasteful for electricity is, for example, to light trees in Christmas or in Hanukkah. That's waste. So the question is, are we willing to waste? And of course, if you don't see the intentionality or you don't see the need to put in energy to maintain a network that, by the way, uses way less energy than banks and fiat currencies and all that energy ecosystem, then it's easy to say, oh yeah, it's very wasteful. But in practice, yes, there needs to be movement to renewables more, but it is not using energy that is for core needs, but rather surplus energy that otherwise would go to waste.
Great. Thanks, Alex. We've got another question by Matt Weeks, and he says, Blue Cross is working on a Blue Cross component to pre-approval and payment agreements between payers and providers. The idea of the immutable ledger and single source of truth are among value points. What are your thoughts on that?
I think it's great. I think that it's great that serious companies are starting to realize that there's a technology out there that can be used, that can improve their processes. But again, like with my answer with the passports, the question is the intention. So just like with the passports, is the intention is to allow you to pass a port or to give you a reason why you cannot leave your house? The question here with the payers is this to increase their margins by automating their services and making everything streamlined, but not availing it to a front-end user experience and not utilizing this powerful tool of self-sovereignty and the ability to tokenize and reward users? Mm-hmm. That's really the issue. So again, these are all great questions, but I want to always take a step back and ask what is really the question behind it. Because like I said in my talk, technology does nothing. It's what people do with technology. So we can use blockchain as a hammer and break systems and make them more efficient, more automated, and displace more people. Or we can do a Michelangelo David and build masterpieces where we include users like patients, like doctors, like healthcare professionals in the economic activity. That is when the secret sauce of blockchain is leveraged.
Gotcha. And just a little clarification in the background here. I misread what Matt said. He put BC, but I interpreted that as Blue Cross, but he's talking about his organization and he meant blockchain. And his follow-up was to create a streamlined processing and reduce denials and the expense of working through them. So that's kind of what they're working on.
So I would say to Matt, go for it, improve it, but use it for the betterment of your community.
Great. So now here's a question from Patrick Damaso. Will moving health data to a distributed ledger really solve the interoperability / data siloing problem? Or is data capture and retrieval just not properly standardized?
Yeah, I think you're right. I don't think that it will solve the problem of interoperability. A lot of times it is thought that it can. I actually, in the beginning, I don't know, 7 years ago, thought that that is it. But when you go deeper and deeper into the technology, you actually realize that that is not the case. Data interoperability will happen, like with the prisoner's dilemma, when it makes sense for me to share information with you. As long as I don't want, there's no incentive for me to do it, or I believe that I will lose by telling you something that I think is secret, there will not be interoperability. So yes, there's taxonomy, standardization. We have this fetish towards it that I think will diminish with time, because now we understand with AI and machine learning that non-structured data can actually, everything can be analyzed. And just like I was reading earlier today that everybody should not be coders but no coders, because soon the machines will be able to code. And now they're actually, anybody who read GPT-3 knows you just say something and then it already codes it. So the point is that interoperability, again, is not a technical issue, although there are a lot of technologists that would like us to think that. It is more a macroeconomic issue. And so what we need to build is a new way of a business model, which is called coopetition. It's collaborative competition. We compete, that's fine. There's GHIN, and there can be GHIM and GHIL and GHIF, and all these GHI whatever. But it's better for us because none of us is as good as all of us. And so you have to build in incentives, monetary and non-monetary, so that this liquidity that will happen is meaningful from a I would say transactional perspective.
Great. Here's an interesting question from David Liu. Will quantum computing destroy blockchains?
So it's interesting because we barely started one technology and already our minds are going fast into a technology that might be ripe in 3 decades of saying, well, that makes it so it's equivalent of the horse carriages saying, should we really go into 4 Ts, because eventually Bezos and Musk and Branson are going to take us to space, so why waste all this car in the middle, the internal combustion engine? So I would answer this with 2 parts. One part is no, I don't think, because in the meantime, as quantum computing evolves, there will be also quantum computing resistant technologies that will be created. But more importantly, and that's the second part, is not to think of it again as one against the other, but to think of it synergistically. And we see that already now with quantum key cryptography. So in other words, we can use things from the quantum world that actually makes blockchain even safer. So even with now, and just to give I'm not going to explain now what quantum computing is, but the idea behind it is that instead of deterministic algorithms, we're talking about probabilistic algorithms that all superimpose at a certain moment, that makes an infinite probability of someone coming in and identifying and going as a third party to know what's going on. So we're walking into a passwordless world. And I think that in the next 5 years, passwords will not be a thing anymore. And so the short answer is no, it will not ruin it. It will change it, and it will make blockchain stronger, because blockchain, again, is a peer-to-peer network that is anti-fragile. So the more you attack it, the stronger and better it gets.
Mm-hmm. Great. Thanks, Alex. So let's move to a topic that's near and dear to your heart and my heart, is the idea of tokenization and tokens. As you know, and from the very early stages of our friendship, we've talked about this, and I had ideas about tokenizing and gamifying the network in a way that would encourage members to actively participate and engage in what we're doing. As we all know, like the movie says, if you build it, they're not necessarily going to come. And how do we work with that? So with that in mind, I'll throw 2 ideas out. One is the tokenization of a process to encourage active participation and reward. But the other side of it is more on the monetary side. And you've heard me wax on about this. I feel strongly as the founder of the network that the network should be basically owned by its members, right? If the members are actively participating and actively innovating and actively, changing healthcare through technology, they should benefit from the other side of it. So yes, we're democratizing the investment process, but more importantly, how do we leverage blockchain technology in a way where now the members, as they actively participate and are rewarded, can then take those tokens and possibly invest in the network, invest in individual companies, invest in a fund? So it brings up the question, what types of tokens are there and what are the differences?
Well, maybe now we have a theme for our next conference about tokens, because this is like and I love this topic, and I think that people would love it too, because it's just super interesting, your questions. Just for clarity, we need to kind of make sure that we're all on the same page. A token for me is either a physical or non-physical manifestation of value. So people like to think of tokens in a casino, so it has a monetary value. Or I have my stars on Starbucks that has, I need to do stuff in order to earn them, or my miles on United that one day they call and say they're worthless anymore. So that's the problem with centralized tokens. They gamify, but they're controlled by the central parties, and so they can change the conditions. And one day a token that was worth $1,000 is now worth $1. And when we talk about tokens in the context of decentralization and blockchain, these changes cannot happen because they're embedded in the code of that token. So if I say I want to use a Gary coin, then I say, Gary, what is it that you want for the members of GHIN to be in that coin? So say, well, if you show up to my conferences, boom, you get a coin. And if you listen to Alex and this, you get another coin. If you can ask her a couple of questions, you can get another. And if you volunteer and call me and say, I want to do some talk, and I want to be an ambassador, and I want to, you translate the intrinsic value of your community to some tangible value. That's really what tokens are. And so you tokenize processes, you tokenize behaviors, but you also tokenize identity and status. Because honestly, as healthcare professionals, this is really what makes us move. Mostly, I know that we're all how many make more money, but really, when you think about it throughout our careers, really what made us go through is the respect between our peers and to gain a certain, recognition. And so this is a very nice, fun way to identify it. And I know that we have only 1 minute left, so I'll finish. The different types of tokens represent these type of things. So if you want to make money on it, then these will be called security tokens, because you have to go under some security SEC regulation. If you want to do it for services, these are called utility tokens. If you want to do it for Gary, these will be called social tokens or personal tokens or work tokens.
Okay, great. And then I'm going to finish up. We've got, probably about 2 minutes, 3 minutes left. I'm going to, a question I know that's near and dear to your heart, and I find extremely interesting, is the idea of, how do we make decisions? How do we make decisions as a practice? How do we make decisions as a community? How do we make decisions as a group? We make decisions every day, and we do it in using the current system that we have. Talk a little, very briefly, about just quadratic voting and how that can change how we make decisions and decide, vote on things.
Yeah, that's a great question, and also a topic that I would love to go through next time, because we're living now in a post-election world where we have all these confused feelings. And by the way, blockchain could solve a lot of things regarding votes themselves. But as tokens are representations of us as individuals, the voting represents the interaction between it. And we are used to thinking of one person, one vote, 1P, 1V type of voting. And the problem, the very intuitive problem of 1P, 1V, is that we're not all equal. And so instead of saying, well, Gary, he did this, so he's worth 100, and I'm, just doing this, so I'm worth 10, which gives that sense of non-fairness. We create something that's called quadratic voting, which basically can capture the skin in the game. So I say, Gary, you get 100 coins. Alex, you get 100 coins. Now you have an opportunity to vote on different issues. I want to vote on the topics for the next conference. And so each one puts, I say, I want blockchain, and you say, no, I want to talk about French cuisine. So I put in a token, you put a token. Then I said the second round, because I put 2, you put 2. But then 4, 16, 6. Soon you're going to find out that all your 100 votes are going to go on just one topic. So at some point you're going to say, Alex, you know what? Have your talk about tokens. Have your talk about quadratic voting. I don't care. I'm out of this game.
Right.
We can really create behavior economics that can capture not only who we are, but how we interact with each other.
Okay. Alex, I want to thank you again. As always, every time I listen to you, I learn something new. Thank you so much for participating. I want everyone to understand that all of this content will be available post-conference on Global Health Impact Network. If you're a member, obviously it's free to access it. But more importantly, what we're trying to create here is an environment where not only can we collaborate during a conference, but we can collaborate before the conference with the attendees and interested parties and the lecturers, and then after the conference. That's the whole premise of our collaborative platform. So again, thank you for participating. And I think we're about to jump into, we're perfect timed here, to another topic that's really near and dear to my heart, and that's the concept of physician burnout and physician clinician wellness. And we have a great group of knowledge leaders in this area speaking with us who are also part of the network.
Hey everybody, up next we have an amazing topic that we've covered so much in the past couple of months, physician burnout. So I'd like to introduce you to Lindsey Williams, who's going to be moderating this panel. Lindsey is currently the CEO and founder for MyUti. Lindsey, it's a pleasure to have you.
Hello, thank you for having me. I'm so thrilled to be here to discuss this topic. It's such an important conversation to have. And joining me on the panel today is the CEO of StressPal, Penny Senpal. Penny, thank you so much for coming on, as well as Dr. Dike Drummond, the CEO of the PatientMD. Thank you. Thank you all for coming. So just to open up, if you guys don't mind just giving us a quick background, Penny, we'll start with you, maybe just a 1 to 2 minute introduction kind of on your background and your company.
Okay, thank you. So my background started in the beginning days of mind-body medicine. I was a UC Berkeley psych student and interning at a biofeedback institute, and was amazed by how you could think about something that upset you yesterday and that GSR meter would just jump up to the top, how quickly the thoughts in the mind translate into the body. And I continued my education at UC Hastings in law and found myself gravitating toward conflict resolution, and developed my skills as a professional mediator, and really saw then again how with people have these incredibly adverse, complicated adversarial situations, either in their personal life or their business life, and how with good guidance, people could come to see things in a different way, to look at what mattered to them and find ways to find a new way to approach it and find common ground and find resolution. Not for everybody, but it really interests me. And I continued my study on how is it that people go about changing and making changes in their behavior and in their way of living their life. And long story short, I started working in the ICU at a major medical center under a grant to try to train heart transplant patients in safe, non-invasive modalities. Again, hooked up the instruments where you could see the impact of changes in people's thoughts and feelings on their physiology. And that led 20 years later, I stayed there for 20 years, developing protocol in self-care education. And I saw really the need that clinicians had for medical grade tools to help their patients and to help themselves. And it was safe, non-invasive approaches. So I teamed up with longtime colleague Jim Monroe, a clinical psychologist. We expanded our team to include physicians, nurses, health IT people, and a cadre of creative media artists to develop really self-engagement tools that organizations, coaches, leadership could use to scale to help all healthcare workers on the team, management, clinicians, nurses, staff, everybody. So that's what we did at StressPal, and we'll get more into why we did it as the talk goes on.
Yes, absolutely. And Dr. Drummond, please.
Yeah, I'm a family doc by training, med school at Mayo, my residency in the UC Davis system up in Reading, 10 years, full service private practice. I was old school, admitted all my old patients, delivered 500 babies, and burned out of my practice in 1999 when I was 40 after 35,000 patient visits. And immediately got certified as a coach for the last 10 years since 2010. My website, thehappymd.com, has been a hub of focus on trying to figure out how we can help individual doctors and organizations recognize and prevent burnout. And we've had some success. I have 5 coaches who now work with me, several thousand hours of one-on-one experience. And the trainings that we developed from blog posts I made about the patterns and what was putting the doctors out and getting them better. We've trained 40,000 doctors for 175 organizations on 4 continents and counting. And one of the things that's interesting about me, since I'm not an academic, I'm a coach, every tool we teach, you can put into action today for benefit today. And one of the things we know is, again, just like Penny said, every single person in the organization who draws a paycheck from your organization is at risk. The physicians are the ones, though, that we concentrate on typically.
Yeah, that's wonderful. Thank you so much. I know this has been a hot topic, especially in light of the stress and additional, just demand mentally, emotionally, and physically being placed on healthcare workers across the board the last 2 years. So this is something I think that we now can address in a way and have a conversation at a higher level that maybe prior to the previous 2 years wasn't as open of a topic of conversation. And I think the idea of mental health, especially for our healthcare workers, is one that we need to elevate the conversation on. And Penny, I know you and I spoke the other day and talking about one of the most important aspects of mental health is building that resilience, and how there's a lot of applications nowadays, right, for meditation and yoga and things that can help, but really the core foundation of what you guys are working on at StressPal is implementing real change and in a way that is proactive. And I would love for you to share a bit more about that with us.
Okay, let me step back a little bit on resilience. This is a word we're hearing about a lot lately, and it's a bit overused or misunderstood, I should say. But there's a lot of research on psychological flexibility and resilience, and this is very exciting science because it helps point the way to what are actually the most effective and efficient ways to maintain and protect your resilience. The physicians are above average in resilience, and they arrive in that condition. But there's kind of a misunderstanding that if you have resilience, you're resilient, nothing's going to happen to it. But it's like, we all want good teeth, but we have to do a little bit to take care of those teeth to keep them good, strong teeth, right? And it's like that with resilience. Resilience, and the science is very solid on this, shows that there's actually mindful, proactive steps that we can take that take moments to protect our resilience and recover our resilience. And those steps are concise. So we can look at things like, yoga or meditation, and many of these practices are helpful, but we need to look at the science for what's the most efficient and concise ways, and that's going to reach the most people. And so I'm happy to launch into that, and it really derives from leading mindfulness-based therapeutic approaches integrated with cognitive behavioral approaches, and you could put in some mindfulness meditations to support that. But there's some very direct, easy to learn skills, and we're coming from a place of saying healthcare is a hazardous kind of profession. It's a unpredictable, challenging. Burnout rates by my standards, were high even before EHR, at 30-40%. They're very, very high now, and it's unacceptable. These are indispensable professionals, greatly talented, and they need the most advanced skills. So we set out to really help provide this concise learning, this concise professional development in the leading intervention strategies.
Yeah, that's an interesting thing that EHR has increased the rate of burnout and that correlation there. I think, obviously the goal of EHR was to start to simplify things, but maybe Dr. Drummond, you can speak to some of the ways that advances in technology have placed, higher expectations on physicians in ways that they were not either trained or prepared for, or have not then been adopted into a system that allows for reducing burnout.
Well, if you talk to any group of physicians who practiced in the paper chart days and who now are still practicing with any commercial EHR, what you'll find is that implementing the back office EHR doubled their workload. That's even before patient portals and the inbox and even open charts where the patients can see your charting. And the challenge becomes somebody can talk about it being an innovation from a programming perspective, and they can spend millions of dollars a month subscribing to things like Epic. But what happens in the back office is it overloads the doctors. Because what happened is when you doubled the workload in the back office, nobody doubled the staff to take care of the workload. And there are evils out there like the MGMA staffing averages that people say are gold standard. No, they're not. It is systematic understaffing of the back office that produced the 50% burnout rates of today. So for instance, MGMA will say a family doc, outpatient family doc needs 1 MA. No, they don't. They need 3. So we solve the EHR problem, the EHR contribution to burnout problem. And I'll just give a couple of references and you can go look them up yourself. One is Corey Lyon, C-O-R-E-Y, Lyon, L-Y-O-N, at the University of Colorado, family doc. His program is called the APEX program. It's been published on extensively. They have no burnout in the back office because they have 2 super MAs, scribing MAs for every doc there, and it's fiscally responsible and hits every single quality and patient satisfaction metric that you'd like. And I'm just going to say one thing. The most important current COVID in the wake of COVID development is you can't hire an MA for love or money right now. And so they laid off MAs during the downturn of profitability during COVID. And now the doctors are even more understaffed in the back office. What's that going to do? It's going to take all the boomer docs who've been looking at their retirement plans for a couple of years and wondering when they were going to pull the trigger on retirement. And they're all leaving this year. There's nothing you can do about it. Because at Dick's Drive-In here in Seattle is given a $5,000 bonus at month 3 to anybody who'll flip burgers with them and show up for every shift for 90 days. Can't hire an MA in a labor market like that. So it's about to get a lot worse.
Interesting. Very interesting. So, I mean, not only are we having a burnout issue, but we're going to have a massive, which we've been saying for years, physician shortage, right? That's just been increasing.
Well, it actually makes it easier for us who work in the corporate world. So if you're working with the individual doctor, that's one set, the canary set of skills. If you're working with the leadership, that's the coal mine set of skills. What it does is it focuses us all, it'll help us focus the leadership team in the future on just one kingpin metric. What is it? Recruitment and retention. That will be number 1 going forward, bar none.
Very interesting. Very interesting, especially inside of systems when you start to think about a lot of, not just healthcare systems, individual practices. Now we also have dynamics coming into the market with private equity and large roll-ups of group practices and then flipping those into larger systems. How do you see all of those market factors impacting burnout?
All bad. As a leader, you prevent burnout on your teams by being able to high touch. Enough touches, frequently enough to have somebody believe that you've got their back. And you come with an awareness that you're here to solve problems that get in the way of the doctors doing their job efficiently. If your leader never comes out of the ivory tower and the only time he shows up is when you're in trouble, and your leader happens to be now because you were merged and that leader's 3 time zones away, all bad, all bad, all bad, all bad. And private equity sucks all the slack out of the system and burns everybody out. There's nothing good about private equity in healthcare, nothing.
So I see you're very open-minded about this.
There's nothing good about it. No private equity firm will put wellness as one of their top 3 priorities ever.
Well, it's yeah. I mean, there's definitely a fair point there. If you're loyal to the street, right? How can you be loyal to the patients? Because those things are Yes, at odds. So, I mean, knowing that we have a healthcare system whose structure is predominantly based on a lot of these transactional requirements of success, how do we even begin to address physician burnout? Because the system is not changing overnight.
Are you asking me?
I'm asking you both. Who wants to jump in?
Penny, it's your turn. Come on.
Okay. All right, I'll jump in. These are hugely important points that Dike is raising. And it all comes around to human beings, right? It's human beings either effectively or ineffectively communicating, collaborating, and figuring out ways to solve this complex dilemma that's faced. You know, they say if you're a carpenter, everything looks like a nail or else looks like a hammer, right? And if you're a lawyer, everything looks like a conflict. And we have such a sea of conflict going on here with different needs, different agendas, different interests. And so the coming together around this to find those changes, to implement those system changes in your organization, and to look at culture of physician changes, culture of wellness changes, of course, the giant being the system drivers, right? That's the driver. That's going to take a level of the best level of communication, capacity, and ability to collaborate that you have to creatively problem solve. And one of the hidden benefits of psychological flexibility and resilience, which again is a well-studied, complex psychological phenomenon that has to do with how we react to stressors, how we react, how we adapt, how we learn from, how we recover from stressors in our environment. The benefits of that relate to problem solving, creative thinking, more effective communication and collaboration. Do these sound like skills that could be helpful in making inroads into this giant dilemma that's facing healthcare with this really disastrous potential result for all of us if we fail? So we've got to get this right, and we've got to get it right this time. We can't be trying a little of this and trying a little of that. We really need to get an integrated approach at the system level, which involves humans collaborating and talking and either giving out little microaggressions all the time or not. Because one of the things that's a lack of awareness is of our stress-triggered responses. There's generally a lack of awareness of that. And when studies have looked at, do people even understand what they would do to reduce their burnout, their distraction, their overwhelm? Most people actually don't know what to do, but the science is there. And if there's core concepts, we can get into that in another part of the discussion. But just look at stress-triggered responses, just to give you a feeling what I'm talking about. These are typical ones: hypercritical, defensive, blaming, passive-aggressive, excessive errors, more accidents. So you can see these few that are typical stress-triggered responses, because we're humans, we're hardwired, persistent stressors like is getting dumped on everybody in healthcare, tends to make people more rigid and more patterned in their stress responses. You can see how these things undermine collaboration, right? So where do we start? We start with the individual, not with the idea that it's the individual's fault, but with the idea that if you can improve your own capacity for communication and collaboration and your own personal resilience, you are going to be at more the top of your game as an influencer and a decision maker in making these changes that are needed now in the coming years, and to be effective at that. I'll turn it over to Dike.
I think that it's actually a leadership conundrum. So everybody who employs a doctor has to understand, doctor, nurse, all people who come through some sort of professional training to be in their position in the organization has a hole in their education. And when they graduate, they don't know anything about stress management, burnout prevention. They don't know anything about collaboration, collegiality, teamwork, or anything like that. It's like sending soldiers off to war without their body armor. They can shoot the gun, but they're going to take the first hit and go down. So it's our responsibility as leaders of the organization to care enough about our people to, number one, give them the finishing touches on their resilience tools, how to understand, recognize, and prevent burnout. And then it's up to me as a leader to care enough to put something into place that is constantly wringing the stress out of the systems of care, constantly asking the people, what can we do to help you? Constantly reinforcing that I've got your back. to the point where every leader in the organization, when they walk into your office and you're not expecting them, you look them right in the eye and you say, hey, Chuck, to what do we owe this unexpected pleasure? As opposed to, oh, damn, what did I do now, right? So it's a leadership failure on such a massive scale. It's actually hard to wrap your brain around. And it's basically about, do you care enough about your people? Do you recognize that you're being hauled below the water line every minute of every day by the 50% burnout rate in your physician population, not to mention the nurses and everybody else? Do you have the capacity of empathy to actually make a proactive wellness program for your people one of your top 3 priorities? Because if you do, you'll be the only one in the whole nation if you start to take meaningful action at that point. And I believe we can make a business case in the near future that is a disruptive innovation, that is a best practice, and we can actually make a business case for burnout, especially if we're 130,000 doctors short of what we need in 2030.
It's a really interesting concept. I mean, are there examples from allied fields where this has been implemented efficiently or effectively? Is this still relatively new to all of us? Because I know in the last 2 years, there's been a lot of conversation around self-care, which came about as almost like a novel concept, right, to many. And so if we're looking at basic self-care as a new idea, do we have any examples that we can look to of where this has been done successfully?
Well, self-care in a healthcare professional is a novel idea because the toxic over-application of the patient comes first, pollutes everything. The leadership has to focus on the people so the people can focus on the patient. Go, Penny.
Well, I think I think even beyond self-care being kind of a concept, gee, I got to actually eat lunch and not skip my workout but the work-life balance, is one of the screaming problems. People are getting that there's not the balance in their life. And I'm going to ask a question, here to everyone to just reflect on themselves who's watching here. We can all name, if I ask you to name, 5 healthy foods, 5 good sleep hygiene practices, a couple of good exercises that you should be doing to self-care. People can rattle off things like that. But if we were to ask you, honestly, are you aware of several cognitive strategies that take less than, 30 seconds in your mind that you can call up that will help protect your resilience in the heat of the moment, that you can apply anytime? Do people know evidence-based strategies that they can use right now that they can easily learn? And I think the honest answer is no. People may think, well, I maybe could go relax but what can you do to defuse the stress response? Because that stress response is really damaging for you. Your stress response can be maladaptive. It can become not aligned with your own values. So as you develop the capacity for awareness, and this translates to the organizational level too, the capacity for awareness, what are my stress triggered thoughts and feelings and behaviors and physical reactions? Are my reactions lined up with what matters to me and what's important to me? And am I willing to act on more workable strategies? This concept of awareness, assessment, and action translates to the larger organization too. What are we doing here? Actually, what are the problems we're facing? Awareness of the problems. Not accepting that they're good or bad, just candidly and non-judgmentally looking at them and assessing, do these line up with our values? And that means everybody getting together and actually talking about what matters. What do we value and documenting that, putting that down, really becoming clear about what matters to us individually and as an organization. And then what actionable steps could we take that are more aligned with those values and what matters than what we're doing? So on an individual level, when you cultivate skills internally and you are solid in your own capacity to harness your brain's ability to really optimize your own personal asset, resilience, you're better able to say, this is what has to happen at the organizational level. We have to be honest about what's going on. We have to assess it, and we have to be willing to take actionable steps to change it.
Yes, I think that's, I think the question for many is, where do we even start with that, right? You said at the beginning, start with the individual. Is it a collective of individuals? I think, Dike, you mentioned starting with leadership, right? I mean, what is the single most important first step that
I'm going to say one thing to clarify, and then I turn it over to Dike, because I mean, this has to be a multi-pronged approach. It is insulting to clinicians if you just say, well, here's some resilience, tips and tools for you to do. There needs to be an authentic commitment to looking at the system drivers and to being inclusive in the leadership there. But I would say organizations with a tool like we developed at Stress Pal, is a virtual wellness home that coaches and teams can use. There are tools you can use to jumpstart at your population level to help everyone, because all those people involved in the micro changes that are going to happen will have a common language. They're able to recognize, model behaviors themselves, reinforce and recognize more productive and actionable resilient steps in others, and be able to help just elevate us out of overwhelm just enough that we're better able to collaborate, communicate, and resolve conflicts. I'm turning it over to Dike because he's got the deep insight into the leadership piece, which is where his expertise is. We're down there at that professional development level.
Brittany, I agree with everything you say. If we take the human interactions out of the layers of bureaucracy in a healthcare delivery organization, I believe in everything you say. I'm self-regulating. I am emotion-free, presenting my ideas to the leadership team. And that's where the question is, what's the quality of the leadership team? Because if that leader looks at you and says, Dike, every time I see you on my schedule, I wonder what you're going to say, but it's always you complaining about something. What's wrong? Here's the phrase. What's wrong? Don't we pay you enough? And here's what I'll say. If you've calmly presented your idea and you know it's a legitimate concern, and doctors always have legitimate concerns, we're diagnosticians for heaven's sake, and you go speak even-handedly and create a case, maybe even you call it a pitch to your boss about something that's just not right. It represents true hypocrisy, where the organization says one thing and we're doing something completely different. And they look you in the eye and they say, what's wrong? Don't we pay you enough? You need to really quickly put a lid on your practice until you can find a new job and get out of there. Because that's the classic failure of leadership inside a healthcare organization. Realize we don't even have the infrastructure to have good leaders in healthcare. Because if I go into a leadership team and I say to the physician leaders in the organization, how many direct reports do you have? If you were a leader and you were charged with touching all of your direct reports every month, just to make sure that you're in the loop and you're helping them and you're expressing your thanks for their hard efforts, it would probably be between 8 and 12 people if you were a part-time leader and you were also seeing patients yourself. You're going to really struggle to find any organization in the United States of America that has physician leaders throughout the organization who only have 8 to 12 reports. And all day long, we're focused on stuff streaming in from patients who are sick, hurting, scared, and dying, and their family members are irate. So we're all constantly on overwhelm. And so the challenge is inside the bureaucracy, with the patient always come first, with poor leadership. Yes, you can defend yourself. The canary can defend itself. And I can always build a mind that'll kill even the strongest canary. So it always has to be parallel. Canaries, we all have to have our own strategies that we build ourselves. Coal mines, somebody's got to get the leadership team on board to be constantly wringing the stress out of the mind. Together, if we work collaboratively, which I've not seen an organization who does a good job of this nationwide. It has nothing to do with your national reputation for anything, right? So you can't hold Stanford or Mayo or anybody else up as an example. You cannot, because what you're talking to is a leadership team and they'll say anything. I want to talk to the frontline doctors and say, what's it like to work here? That's what I do on my website. 20,000 times a month, they come streaming and telling me stories, okay? So this is something that can be done only on a small scale in little circles of influence around good leaders. And if you can build the collaboration and the awareness and complete their medical education so they can defend yourself, maybe you got a chance. Outstandingly difficult to do, Lindsey, especially if your private equity firm just bought 8,000 doctors in 14 states, right? And just a real quick last thing. I had a chance to train a group of CFOs recently, 20 CFOs from a state medical association. And I said, before we get started, I just want to ask y'all a question. Raise your hand if you've ever watched a doctor seeing patients during their workday. How many hands went up? 2. And I said, you're impressed with that? Please, come on now, Lindsey. Be authentic with us here, right? It should be shocking. It's like they've never seen the sausage get made. The only time they ever saw a doctor was when they were the patient, okay? How about this? How many of you make that a routine that you maybe go out once a month and round and shadow a doctor? One guy, he said, yeah, I learned it back in the days when I was in manufacturing. We would walk the assembly line every month. How in the world can you count the beans and think that your profit and loss spreadsheets mean anything if you've never actually seen a doctor in your organization see patients? So this is the kind of, can we get out? Can we be collaborative? Can we be aware? Can we understand the stress that our people are under because we're down there doing the old school management by walking around enough that we know the people that are our direct reports and that we are constantly wringing the stress out of the system, because you can't abstract any sort of educational outreach from the insanely complex bureaucracy that we're trying to launch it into.
Yeah. This term that you use is so great, wringing the stress out of the system. And I would love for you to share, if you have one or two, just like quick things that you think organizations could relatively easily implement for themselves in that way to help at least start to wring out some of that stress.
Well, the first thing you have to do is be responsive to your people, because the mistake most leadership teams do is they say, anesthesia sucks, get the lean team on them. They're doing it to the anesthesia department. When lean comes in and rearranges your workflow, it destroys your day and makes everything completely worse. So all you have to do is ask them, what's the number 1, number 2, number 3 biggest stressors in your day? Pick one and get on it. The simplest way to do that without necessarily having to do the survey is a GROSS project. GROSS. Get rid of stupid stuff. And all you do is in one department, you put a box in the lounge and you say, hey, everybody, for the next 2 weeks, you put your suggestion, make sure you put your name on it because there's prizes. Put your suggestions for anything that you see that we can stop doing. That's kind of stupid that we're doing it in the first place, because if we stop doing it, it's not going to make any difference to everything. It's just flush, it's trash, it's waste, it's historical artifact. And then you have a party with awards and you pick one and you do something about it. And what happens with a GROSS project, which is so cool, is it's not about doing something new. It's about stopping, doing something old that isn't working. So what it does is it frees bandwidth. Everybody's overloaded. Freeing bandwidth is your number 1 task.
Perfect. Penny, I think you were going to chime in on some of that.
I'm a very strong advocate for inclusiveness of the nursing team, other clinicians, non-clinicians, and the full cadre of management staff. And one of the things parallel to this assertive movement toward what's wrong, what can we fix, is getting some concise, evidence-based professional development for people. They'll feel cared for. They'll be getting valuable skills that will help them hang in there while you are fixing this other problem. But I wanted to say something else. You talked about where can we look. I think within medicine itself, the building of the culture of safety for patients was done, and looked at the airline industry for how can we create more safety around acknowledging where there are problems? How can we really start looking at the way we do things for building more safe environments for patients? And that's not a bad model for your team, right? I mean, because we need to create a safety net for our health workers. By that, I mean everybody in the picture. And that's millions of people. And I didn't say earlier, but we've got this looming public health crisis, but we have an immediate personal tragedy going on for millions of people. And as Dike said, your difficulty getting MAs to come in and so forth. But if we look at safety and how built culture of safety, that's an analogy that medicine knows. And building a culture of wellness and resilience is going to take those micro looks at things and how can we make it safe to talk about? How can we make it safe to bring things up? And how can we be robust as a team in listening and active listening and taking proactive steps to make changes? So I think there is an example right there, really, where you're rebuilding the coal mine as well as strengthening the canary. I mean, they go hand in hand, and it is medicine is a team sport, And it's not just a team of doctors, it's a team
Could be.
with non-clinicians as well. So I think look at that safety, culture of safety. Okay, we need a culture of safety, wellness safety. I'm going to say well-being because the idea of mind and mental health, physical health, to me, they are so intertwined. You really do need to address how are we supporting well-being, the whole picture, and make it safe. It's education. It's not mental health treatment. It's about providing foundational skills that if we draw from psychology and psychoneuroimmunology, there's been extraordinary advances with acceptance and commitment therapy, cognitive behavioral therapy, and how those intertwine to provide concise training on platforms that organizations can implement right away. So those are the comments I want to make. I think you can look inside your own world and navigate from there.
I think that's a phenomenal point. And I actually think that's, a phenomenal way to kind of bring it back home is saying this isn't just a firestorm that, healthcare workers are operating in. This is fundamentally a safety issue with our healthcare system. If we are not protecting the mental health of our healthcare workers, right? What does that mean? Not just physician burnout, physician shortage, but then how is that impacting the quality of the care you're receiving as a patient, right?
And Lindsey, it's not just mental health, because when people are fatigued and exhausted, is that mental or is that physical? Right? You've got this whole range of responses of how people respond to persistent stressors, right? These extra stuff. So you've got the firestorm. If it's a little bitty fire, you don't need much PPE. If it's a bigger fire, you want a little bit better equipment. If it's a raging firestorm, as exists now in healthcare, in terms of the workload, feelings of autonomy, not respect, the whole spectrum of complaints that we all know about. You want the best PPE you can have, and you want to know how to take care of it so you can fix that thing. And you didn't start that fire, but you are part of the system that's in the fire. And so, and you have your intelligence, the training that physicians have, that other clinicians have is phenomenal, and that needs to be listened to. These are very dedicated, highly self-motivated individuals, and they're indispensable to all of us. So I think we already have, responding to something else came up earlier, I think we already have strong, ethical, legal, regulatory, and business reasons to be assertively building interventions to prevent burnout. And we have also on the side of why, it's not just it's mental health, yes, but we also show increased accidents. There's many healthcare workers have among the highest rates of disability claims. When you're exhausted, you're fatigued, slip and fall, don't do things, don't remember quite. There's physical injury, there's malpractice risk, which is a vicious cycle. There's more errors and there's malpractice. Nobody likes to be in those situations. They're highly stressful. It further undermines confidence and fulfillment. And so we have to stop this vicious cycle. System drivers, the internal microaggressions that happen, the ineffective communication, problems not really being solved. And all of that deepens and worsens the feelings on the, of your experience of your work. So the safety issue for our workers is full spectrum, or from everywhere from physical injury and emotional distress and moral injury. It's much bigger than burnout. Burnout takes a look at this, but the actual problem is much bigger.
Much bigger. Points very well made. Dike, I don't know if you have any kind of final comments. Otherwise, we can go into our question and answer session here.
Well, burnout's a normal response to stress, and anything mental health wise is a complication. Burnout is linked to worsening safety, quality, patient satisfaction, all of those indicators, turnover. And if you're negotiating with the leadership team in the years ahead, your number one argument with them is going to be recruitment and retention. I just want to tell you that now, because the retirement wave is coming. And I think it's coming quicker than we ever thought possible. Sure, safety is important, quality is important, it really is. But again, inside of bureaucracy, you have to have a negotiation point with the leadership team. And I think recruitment and retention is going to be where it's at. And the one thing I would say is Find a trigger in your office stay, something that you do between every patient that you can hook to a big deep breath from the top of your head to the bottom of your feet, and just let go of everything. Doesn't need to be there in that moment before you go see that next patient. And what you'll find is it'll make a tremendous improvement in your office stay without needing any leadership intervention, no legislation, no union, any of that kind of stuff. Just remember to breathe. You're going to do it anyway. Trigger it off like a doorknob. Try it out.
Love that. Thank you so much. Thank you guys so much for this panel discussion. Let's go now to our audience to see if we have any questions for our panelists.
I can't hear you.
Hi, I just wanted to jump on and let you know we've got Gary here. Going to add Gary, and as soon as we have Penny, we'll get her on for the Q&A. Hi, Gary.
Okay, here I am. I was on the YouTube screen and not the StreamYard stream. Hey, Dike, how are you? Good to see you.
Good.
Always a pleasure.
Likewise, I'm sure. So are we live right now?
I guess we are, and I've got a whole list of questions in 2 different places. So just let me get back to where I was.
Okay.
Gosh, what do I do with my, okay, so I'm going to go back to YouTube where the questions are. You can still hear me, right?
I can.
Okay, great. So we've got a bunch of questions. And then let me go here too. I'll start with the audience, some of the audience questions on YouTube.
Please.
And here we go. Let's see. Wow, there's a lot of them.
I would hope so. Let's focus on them. Anything we put up as dummy questions is meaningless. Let's just
I leave that for the end if we have to finish up with a little bit extra time.
You won't.
I know. Okay, so for Matt Weeks, who's actually CEO of a startup, we have been working on staff, including clinician early warning flags for burnout /stress to empower intervention, resources adjustment, and attention to the working environment. Oh, that was an admiration. Sorry. He admires both your work. All right. Well, that's yours. I'm going to get rid of mine because those were some of the posted questions. Sorry. Wow, these are a lot of statements. Okay, Dike, from your perspective, what is the ideal healthcare ecosystem where physicians will thrive? That's a pretty broad question.
Well, if you're talking about a healthcare ecosystem in terms of being some sort of large employer, so let's say a community hospital system that employs 150 doctors, I can say that size is really important, and I mentioned a little bit of that in the recorded remarks, because there is a certain scale to leadership. Hey, Penny, there is a certain scale to leadership. If you can't get out amongst the people and get regular touches to build the 5-to-1 ratio, to have trust and a relationship between the two of you, it's hard to build the culture and the leadership backing of the providers that you need for a healthy atmosphere. And you also need to be asking questions often enough about what is stressful for you in your practice and being responsive to the physicians. It should be a collaboration. There should be acknowledgement of the fact that 80% of your income comes from the pen of a physician, the mind or the pen of a physician, and we should be working together. And what usually blows that out is scale. And what really gets in the way is the whirlwind of everybody's day. Everybody's overwhelmed, overloaded, tapped out, no bandwidth. And so we need to be getting together more frequently outside of the practice of medicine to talk about how we do our job and working together to always make it better. And then the organization, if you employ these people, is responsible for completing their medical education and giving them the tools for resilience. Yes, we're resilient, meaning we survived residency, but we didn't learn how to take care of ourselves through a lifetime of being a healthcare provider. Medical school and residency are survival contests. Hey, Lindsey. That would be my short answer. So if you're talking about what is the healthiest business model so far, because it is less chaotic and less volume, you're going to have to look at things like concierge practice. But concierge practice can never be something that delivers the majority of healthcare in the United States. But certainly the business model is impressive. And Gary, you know the secret to the business model of concierge, how I can make the same amount of money and see 12 patients a day. It's overhead. You're muted, my friend.
Absolutely. I have numerous friends that have gone that path and are much happier, and their patients are much happier. So it's an interesting concept. Okay, so let's see. It's funny. It's always actually, I think, a compliment to the chef, so to speak, when most of the comments are supportive comments of everything that you said, as opposed to actual questions, which is what's on here quite a bit. So I'm just reading through these.
We could always talk about Z-Dog's latest screed.
Yeah, there you go. Here's one. How do you deal with leaders who respond by gaslighting their physicians when they bring up issues? You addressed this a little bit.
That's a psychopath. Get out of there.
What are the best practices to avoid burnout in residencies, especially with the wide range of training and hour requirements?
Penny, you want to jump in on that?
Yeah, I'll jump in on a few comments on that. I think let's get into some of the nitty gritty of what we're talking about when we're talking about protecting and maintaining your resilience. Because that's where the education could really come in early on. That's why we created a virtual wellness home in StressPal with a professional development tool, as well as something that could scale for the students, trainees, and everyone in practice by having you do incremental learning that expands the brain's extraordinary capacity to change your stress triggered responses. And here is where you do have measure of control and choice around how your brain functions in those first instances of the stressor. And these stressors are many. We've described this in great detail. But when the stressors come along, with the path, the evidence path, and just is kind of a teeny tiny Reader's Digest version, is the leading for efficient skills around protecting your resilience, is around learning how to become aware of your stress triggered thoughts, behaviors, physical responses, and to be able to observe those in yourself and others, to be able to identify what's really important to you and what you value, be able to call both of these up in the moment, right in the heat of the moment when the conflict is happening. What matters to me? What's important to me here? How am I thinking, feeling, reacting? How are they thinking, feeling, reacting? And then making a choice on the more workable strategies. And these strategies are ones that would take more time than we have here to identify, but they can be learned over a brief course of training. We're talking about, 4 hours or so spread over a month. The kind of training that psychologists have developed and use in clinical practice that can be taught online is surprisingly brief and will last you a lifetime, that you will continue to perfect as an internal cognitive skill that you have when the stressor is right on you, when the conflict's right there. So I encourage you, there's some reading we can do. I'm always happy to pass on resources and citations for any of you to look at, so that you can learn more about the modalities.
Right, and that's a good segue to lead into Global Health Impact Network. And we do have a physician burnout community that's growing. I know Dike has been a small part of it. It's growing, and Penny, Paul DeChan are involved, and we built it with the idea that this conversation should not stop here. This conversation should start here. And it's an opportunity for everyone, including the attendees, to jump into that community and pose questions, which will then be responded to by the knowledge leaders for that particular community. So I encourage people. Here's a great question, because, it's something, it really resounds with me, because, we're very good, I'll go into the global versus domestic discussion. We're very good as a group. A lot of the knowledge leaders tend to come from North America and where we are. But the reality is, and I think we couldn't have picked a better way to focus on this, is that healthcare is global. And the pandemic has caused burnout, not just where we are, but anywhere where there are clinicians interfacing with patients in the middle of a pandemic. And frankly, I would venture to say, and I'd love your opinion, that it's much worse in other places because they don't have the resources that we have. And even that has not been sufficient. So the question here is, worldwide/globally, how do you define physician burnout, lack of empathy in a health system anywhere, like India, Egypt, etc.?
Yeah, it's a whole different definition, right? If you haven't got the resources and you haven't got the staffing to do anything like what we would expect to be standard of care here in the United States of America. So when you've got dead bodies in the ditches in Quito, Ecuador, and I'm a doctor trying to see patients without PPE and ventilators, you're on a whole different measurement scale of distress, moral injury. Moral injury meaning you know what you want to do and you know what you would do if you had the supplies, but you don't have any of that and you can't help people in the way that you want. So here's the way I think of it from an ethical perspective. It's sort of the same way I think about environmental concerns in the United States of America. If we can't be environmentally responsible in America, who else can? If you've got subsistence farmers burning down jungles in Brazil, if we can't figure out how to protect the health and well-being of our providers of healthcare, physicians, nurses, everybody in the system. In the United States of America, where 17% of the GDP goes to healthcare, if we can't figure it out here, nobody can figure it out. One of the stressors that you don't have to deal with, in my experience, is Australia, Canada, National Health Service in England. One of the stresses that they don't have to deal with is multiple payers. They direct bill the government and get a check the next week. They don't have to worry about what's on the formula. There's just one, what things are covered, pre-authorization and those kind of things disappear. The business office, you don't need one. So there's an international example of one of the differences. But I would hate to be, and I can't imagine being, a physician in the trenches of a slum in South Africa in the middle of a COVID epidemic. I mean, we aren't even getting news reports from those environments because even news won't travel in a disaster like that.
Penny, you want to chime in on that a little bit?
I find I actually maybe you could narrow the question a little bit more, because and to how it might relate to the burnout that we're experiencing here.
Right. I mean, when I talk, from my perspective, when I look at burnout and when I speak about burnout with my colleagues, it's important also, and the pandemic has really shown a light on this, is that burnout is not just the clinicians. I mean, burnout right now is from the C-suite down, and is, as much as I hate to admit it, they're experiencing as much burnout as we are. And even now, we're quote unquote, we're on the upswing of the pandemic, which is arguably, another discussion that we can have, is that we have, even in our local hospitals here in Silicon Valley and San Francisco, not enough nurses. Dike talked about it, not enough doctors. People are leaving in swarms from healthcare. So the burnout is finding its way up to a C-suite where they can't find clinicians to take care of the patients that are coming. And now the ICUs are getting full again. I mean, my wife's an obstetrician, and today she told me there were 12 pregnant COVID patients in the ICU as of last night in our local hospital. So we don't even have the appropriate resources here to address this. And I guess my question after that little soliloquy is that the solution has to be more than, it has to be preventative. It has to be episodic in that we have a huge crisis now of episodic burnout that needs to be addressed. And then how do we come up with a solution that's both preventative as well as episodic in the now? You know, because there are different solutions between you two and Paul. You're all in different aspects of the solutions of burnout. Dike spends his time and his effort exactly dealing with individual clinicians and practices and at the level of burnout. Whereas Paul tends to address it more at the executive corporate C-suite level, and you're in somewhere in between, but coming it from more of a preventative educational and as well as what I guess we would call digital therapeutic perspective at this point. So it has to be all over the map, and yet like everything else in healthcare right now, everything is siloed. You know, Dike is working in his network and you're working in your network. Paul's working in his network. We're trying to pull it all together in our network. How do we fix that part of it?
Okay, well, there's a lot there. Right?
There is.
We could have a very good hour-long conversation just on this point. And I think part of this is unpacking the different pieces of it. Like with any complex problem, you might say, you might compare it to in a legal setting, a giant class action suit where there's many factors to it. Part of it you're going to have to parcel out. One of the things that we are attempting to do with our program is to provide that platform that helps make an integrative hub so that you really can start integrating your wellness initiatives and your leaders can start being coaches right on that platform with your teams. That's something so that you can really build that internally in your organization. So I think that, we do see our program both as something that facilitates that integration because we see that lacking. There's larger pictures where we have to look outside of the box relating to how are we going to attract people to this field. And we do need, I think one recommendation I have is to accept humbly that within your own training and discipline that you have within your medical sphere, whether you're on the MBA side or the MD side, you may not have the expertise. You may need to bring in some consultants who you can join your team or maybe in other parts of your team. There's talent that you haven't identified to help you think outside of the box. How are we going to start setting up some collaborations with other hospitals in our area? We can start having broader conversations about this. And how can we also join maybe statewide or national advocacy organizations? I'm, with my law background, I'm a big advocate person. You need to join forces to advocate. And this also comes down to communication. So if you can start to integrate your wellness initiatives so that you're not just preventing, you're also providing real missing skills right now. You can start to set up conversations with regional, statewide, and participate in national conversations that start to change policy. One area for this, for example, is changing the legislature in your state around privileging participation in wellness programs. So doctors don't have to worry about any stigma there. Are they going to be penalized? Are they going to be, is somebody going to find out about this? There's a couple of states that have led the way. Others need to join it. All 50 states need to make it completely safe, as psychologically safe for your credentialing and all. So I think one of the strategies here is identifying and putting in buckets some of your key bucket areas and what can we start with now here? What's our longer range? What's our shorter range? How can we integrate our wellness initiatives so they're not scattered? Some are over on here and some are over here. How can we pull things together? And how can we create a common language so that we all can talk about this in a way that we understand each other? And this means bridging from other disciplines and translating that in a way that I hope we've done in our program, and I know others are doing in their programs.
That's great. So the other comments, there's a couple of comments in the string, which are, I'll refer to it as the us versus them problem. So here's the first question. Do you think the medical system is fixable, given how rigid and ingrained the system is and how much power physicians have given up to the admin, C-suites, suits, and powers of insurance companies, Medicare over our practice? And then the second comment where physicians' income and autonomy were robbed by non-medical C-suite executives and admin. I mean, this is an area which is close to my heart because it's the whole reason that I started Global Health Impact Network, is that we are in a position where we've been given I would be hard fast to call it a present, but in a way, the white cloud of this pandemic is a bit of a present. It's showed and unveiled all of the gaps we have in healthcare where we are right now. And it's our opportunity as clinicians to take back our roles as guardian of healthcare to improve that patient-provider interaction. So, Dike, how do we get from where we are now with the tools that we now have available and the opportunity to kind of take back control?
Certainly the pendulum has swung in favor of the business savvy folks gathering together doctors as commodities into pools of employees. And one of the things I see a lot, because when you're under stress, this is what happens, is a lot of tilting at windmills. You signed a contract, you punch the clock when you come into work, you gave up your autonomy when you became an employee, specifically to the organization whose job description you're now attempting to fulfill. And one of the things that's going to be nice about the shortage is that it's a seller's market, or there's going to be demand for doctors. So if you don't like this job, if you feel like you're giving away too much, being taken advantage of, you got a psychopath boss who won't listen to you, asks you, what's wrong? Don't we pay you enough? You have the ability to shift that. But what I can say is, and what I'm working on is trying to find a leadership team who's willing to make meaningful change in the way they do things in the organization to honor the health and well-being of the physicians, so that we can create a business case, a white paperable business case, that it's a best practice going forward, not a luxury for a few who happen to have a solid gold profit and loss statement. So I think that there's a way in a smaller group to show superior performance on all indicators you want to look at, because again, burnout affects quality, safety, patient satisfaction, productivity, engagement, turnover. I think there's a case to be made for wellness as a disruptive innovation in the healthcare space. It just hasn't been made yet because people think bigger is better, and bigger is never better. It's just bigger. One of the things that you were having trouble wrapping your brain around just now is the sheer complexity of healthcare. The healthcare industry is the most complex industry on the planet. Nobody's ever, apart from occasional large group practices in the United States, the development of a large group of employed physicians managed by non-physician managers is a unique development in human history. And there's just 2 points I got to make because we teach this everywhere we go. Burnout's not a problem. It's a dilemma. It does not have a solution. You must have a strategy. And every individual canary has to have a canary strategy. Every individual organization has to have a coal mine strategy. And they're all different because of the different ways these things came about. Also, burnout in residency and med school is very different than burnout in practice. Right. And we don't have time to talk about that.
Right. So it is 2:00. I want to thank this amazing panel, Lindsey Williams, who, as always, did a spectacular job moderating. Dike and Penny, who I always enjoy listening to and learn something new every time I listen to both of you. So again, if anyone on this string or on the video strings in any place that we're broadcasting this, if you have further questions, want to be more involved, join the Global Health Impact Network, get on our physician burnout, clinician burnout community, and start collaborating and be part of the solution as opposed to watching in the grandstands. So thanks again, everyone. And I think now we're going to move on to one of my partners, Bob Sweeney, who's the head of our Global Health Impact Network Education Network. Thanks again, guys.
Thank you.
Hi, everybody. Up next, we will be talking about the Global Health Impact Network Education platform. And our speaker is going to be Bob Sweeney, who is one of the founding principals for Global Health Impact Network and the Global Health Impact Fund. Bob, it's a pleasure to have you with us.
Well, thank you very much, Martin. I'm happy to be here. It's an exciting topic for me. I'm looking forward to our conversation and to whatever questions and comments our audience might have.
Well, why don't we start with a quick introduction of yourself?
All right. Well, I'm Bob Sweeney. I've been involved in clinical education or the management of clinical education companies for a long time. I spent my first 15 years as a manager, first running a health maintenance organization, and then I ran contract medicine groups for a long time. In fact, I was one of the founders of TeleHealth, which is a very large contract medicine company in the United States. I went from there to Challenger Corporation, where I served as the CEO for nearly 20 years and worked with my colleagues there to build a national audience, a national market for online medical products, both institutional and retail. And then I resigned from there 4 or 5 years ago because I wanted to do something else with my life in addition to that. And so I met Gary Goldman, whom I'd known for quite a while. And Gary and I said, let's start a venture capital fund and a venture capital network with an education component. And I said, well, that's great. That appeals to me. We'll learn as we go, and we'll try to make something that people can actually use. So I did that. I've got a 10-year academic background. I have a doctorate in history from Carnegie Mellon University, an MBA degree, and an MS in experimental psychology from the University of Memphis, and a variety of other experiences teaching and writing books. So I've spent a lot of time in the educational field, made plenty of mistakes. I'm looking forward to sharing my adventures with others.
And that's a pretty impressive record. Thanks, Bob. So let me ask you this before we kick off. So why an educational network?
Yeah. Well, our belief about education, it goes back to what does education mean? And, for a long time, and traditionally, it meant there was a source of knowledge, an instructor, and there were learners. And the information, the messaging was one way. It went from the teacher to the audience. Well, that's not really how people learn. There's been an awful lot of research done in the last several years about how people learn things. And that research hasn't yet produced the results we'd like to see in terms of fitting in with how people actually learn things. I'll talk about that a little bit today. But the idea of a network was that we would engage both sources of knowledge and people who can use it and focus on those areas where they could collaborate and share information with each other and therefore learn collectively as they went along. We think that's a lot of what goes on actually in clinical education. When a physician is treating patients or dealing with at the point of care, he or she is often in the company of other professionals and also in the company of the patient, and they learn from one another. And that's what education is, the sharing of knowledge and the retention of that knowledge for future uses.
Perfect. So why does the Global Health Impact Network, why is it important for us to have an education network?
Well, I think there's a couple of reasons for that. First of all, every professional clinician, probably most professionals in major fields, I know it's true in accounting and law, are required to be educated. In fact, there are formal education requirements they have to meet periodically to retain their licensing. They have to have education in order to acquire their license. They have performance requirements they have to meet. So it's a requirement of clinical personnel to have education. It's material to their actual practice. We felt also we were well suited to do this because many of our customers and many of the people that we had met over the years and worked with were in fact educators in the clinical space. And we wanted to include them in what we were going to build. And finally, of course, I had spent so many years as a clinical educator and running clinical education companies. The company believed I would be able to help them organize that process in a way that would be useful and beneficial for our members.
Okay, so what makes the education network so unique?
So the content is taken from peer-reviewed, high-quality sources, or it's content we produce ourselves. You'll find when you look closely at medical practice, there's much knowledge or much content that falls between the cracks. I'll give you a good example because we're producing a course right now in this space. So primary care and acute care physicians deal with personal interaction with the everyday health of their patients. But there are things that relate to their musculoskeletal health that you won't find in a typical textbook for family medicine or journal articles for emergency physicians. And physiatry is a specialty. I mean, musculoskeletal medicine is a specialty, but it often, when you think about it that way, it's high-level care, tertiary care, complex things that take place in teaching hospitals. But are there things in the musculoskeletal area that technically aren't part of family medicine or emergency medicine, but would be of value for those practicing docs to know about and have expertise with and have experience with the procedures involved? We think so. We have an expert physician, a couple of them actually, working for us to design this content. Nina Karandikar from Stanford and Becca Rosen from the University of New Mexico. And these are people that are very expert in this area and will produce a product that we can use. The second thing has to do with the process itself. In this network, the stuff that we're producing and using is made available to our membership, thousands of physicians and other clinical professionals who can use it and then feed back to us information that lets us revise the content and upgrade it. So we actually have the distinguishing characteristic about a member of a Global Health Impact Network is that they participate effectively in creating the fund itself. They create what we use because they draw from their own experience to comment on and refresh our content. We have established sources like MedForums and Challenger Corporation and others who provide their peer-reviewed content to us. And we also develop it ourselves. Just take Challenger as an example. They have something like 200 professional editors and reviewers who prepare this material. I've seen this material even used, the production of that material used as an item on a CV for people seeking tenure at universities. I mean, it's very well regarded. Now, how do they use it? They use it for boards prep, for preparing for their boards examinations or recertification. They use it to meet licensure standards in states or other areas. They use it to present competency and specific skills like trauma care. And they also use it to refresh their skills. So physicians who've practiced medicine for a while, they might want to have a refresher course in ultrasound, or they might want to learn something new that's completely new about medicine. Suppose they want to understand something about blockchain, which, frankly, I don't know a lot about, but it's a new force with a heavy prominence in medicine. And so we make it possible for these docs to use it easily and effectively and without great expense. And they can then share their findings and observations with us and their colleagues. It's a very personal and very fulfilling experience to be able to study in a way where you can provide feedback and believe that your own insights, comments, and questions will be taken seriously by the people who create the content themselves. Another aspect of this training is that our efforts will embed the latest research findings in education as a science itself. We hear the phrase commonly used evidence-based medicine, but there's a great deal of the same type of activity in education. But a lot of places, including many, many medical schools and medical training institutes, don't use evidence-based medicine, evidence-based education, because they're not familiar with the findings. And we try to embed those things in the content and in the process itself. Things like the timing of how often should you study? How often should you rehearse or review material? How long should a test be? How many questions should you ask at once? What's the retention time for the typical user? Those things are not used as factors in the design of training content in medicine. More often, you're using things for other purposes. For example, large organizations, even medical societies, want to use content that's easy to write. So they make a simple question and answer process that's simple to use. And it's simple to score. So if you're testing thousands of physicians, it's easier to score something that has simple answers than something that doesn't. I'm just giving you some examples, but we try to create a structure or an infrastructure, if you will, that embeds these principles without having to spell it out, but it affects the learning and retention on the part of our users.
Okay, that's superb. And then I would like to talk a little bit more about like the assessment platform of the education part. Can you just explain, what it is we're doing with this?
Well, an assessment platform ought to provide a variety of information to not just to the learners, but to the instructors as well. Let's suppose you have a course that has 25 different topics and has a couple of hundred questions and answers associated with it. How do you know which parts of that curriculum are effective? Do you know who misses the most questions? Do you know which answers are most often need to be corrected? Do you use that information to help focus on parts of instruction where individual or groups of people are deficient? And does that deficiency tell you that there's something wrong with the course itself or its instruction, or that your learners are having a difficulty with that type of information? Many people do better with audiovisual instruction. Others rely pretty much on pedagogic text. Others rely on the exchange itself of question and answer to improve their learning. And assessment platforms usually provide you with global information about how many people passed the test and what was their average score, but they don't tell you individually how your members have done. They don't provide you with that level of detail. They don't tell you how often you should test. They don't tell you which parts of your curriculum are supplementary and supportive of others. That kind of information can be collected and displayed in a way that makes it possible for both the instructor and the learner to see what it is they're learning and how quickly. You can also, if you're teaching in a large institution like a residency program with 50 or 60 people in it, you can see, if you're the residency program director, for example, you can see who's behind, who's ahead, who's not completed their work. If you were running a medical group, say, instead of a residency program, maybe the group wants to know what areas of knowledge or cognitive skill or procedural skill their members seem to have deficiencies in. And they can collect that information anonymously if they wish to, and then use it to inform what goes on in the quality assurance committee to teach the staff how to do better in these and handling these kinds of cases. The assessment platform could be easily displayed. It would takes half an hour to walk an interested party through it, and we'd be glad to do that. But it's highly effective that way, and it also is prescriptive. It can let you know which areas you need to study more and what topics are places where you need to spend more time looking at references or sources, and we provide those references, of course. Does that give you an idea about what we're talking about here, Martin?
It does. For me, I'd love to know a little bit more of why an assessment platform is so important to GHIN and the strategy that, especially the education network, is going down.
Well, it's important because you have to know whether your instruction is effective. How do you know if it works? And how do you know if your students are doing well or doing poorly? How can you attach those outcomes to components of your instruction program? And a good assessment program should let you do that. It will give you insight in detail into what's going on with your users. It'll tell you things like how long does it, if they take repetitive tests or scores, what's the longitudinal rate at which people learn things? How long will they retain that information if you test them again? Where do they spend more of their time, and which questions and which topics are more time intensive? That information is part of education. It's part of instruction. And even if you're not using a formal instruction system, users who use this assessment system can learn things about themselves that they didn't know. Well, if you study a topic and if you're interested in it, When should you retest yourself or refresh yourself? What's the gap? Because there's plenty of evidence that gaps are critical to learning. It takes time for your brain to form, to form and retain components of knowledge. It doesn't just go in once and go out the other ear. And it doesn't just go in there and if you can let it sit so long that it atrophies, goes away. Or if you time it correctly, you can reinforce what's already there and embed the learning. Those are things that are just, most people that are instructing, even in a professional environment, aren't aware of. And we're trying to build that in because we want to have an education system that people find will be functional for their retaining and learning things, and a way to prove to themselves that their effort has been worthwhile.
Okay, so we're talking about the users who are going to be using the platform. Like, can you explain like what kind of material is going to be on the platform? Like, is GHIN creating all these materials, or are we partnering with other companies to deliver these education parts?
We're doing both, and we're selecting material. We can, we don't have to reinvent the wheel. If there's good content from other sources, we use it. How do we know that? Well, we look at we have experts in medicine, not me, but look at the content and tell us if it's accurate. These people essentially are peer reviewing the content to see if it meets up to an expectation of being independent and being able to be verified by our users. Secondly, we have data collection. Information is invaluable. Does a training institution or does an individual want to have a reservoir of information about themselves? A lot of people do. What makes a network functional? What makes a network have a high engagement rate? Because engagement is what matters when you're building a network. And if people will engage and use things that are of value to themselves, but that value doesn't have to be just a score on a test. Sometimes that's all people are interested in, but others are often interested in what it is they're learning and how to retain it. Others that teach themselves want to know what things should they focus on that are going to engage the attention of their users and will actually reinforce their learning. I could give you some examples. We have courses, for example, in ECG interpretation. I'll just take that as an example. It's a pretty straightforward technology. But when you're teaching it, how do you know, other than the test outcome, if people that are going to be in practice actually functionally know how to use the technology? Those are things that will be valuable for users because they'll feel like they have more control over their own lives if they can do that, and will engage them with the network, make them more interested in using it.
Okay, so you've had a very extensive background, especially when it comes to like the education part. What's your vision for the GHIN education platform? Where do you want to see this platform going?
I would like to see the platform and its tools, its assessment platform, and its content development process imported into and used by other organizations that are in this space. If you're a healthcare company, or particularly if you're a medical group or a medically oriented organization or a specialty society, wouldn't it be beneficial to engage the capabilities of a company, of our network, that's based and designed from principles of evidence-based education to teach people? You can improve your own organization that way because it's a secular system. We're not limiting who can use this. All you have to do is be a member of the network, which is free, in order to be able to use these things. We would like to see the use of these principles become sufficiently widespread that that it can be verified that educational training and testing actually has a positive outcome. It isn't just based on hearsay or anecdotal information. That's the golden standard. And how will we know that? We'll know that if individual practitioners and medical and healthcare organizations join and actually use our technology and our content.
Okay, so we talked a little bit about cross platforms and engagement. Like, what would it take for other companies to engage with the network to bring these assessments to their organizations? And how can these organizations benefit more from the expertise of the likes of yourself and Gary and the whole GHIN network?
Well, I can give you an example that might just illustrate what I'm talking about. Basically, we could work with any education company that's willing to try something new and effective. So one of the organizations we're joint venturing with is called MedForums. It's a physician-designed company based in Salt Lake City. And they make, amongst other things, they make a credentialing system or a badging system to provide what amounts to a good housekeeping seal of approval on content. So we've agreed with MedForums to let them rate and badge the content on our system, whether it comes from them or another source or is ours alone. So when you use it, you'll have that seal of approval on it, and that lends more credibility to its usage. In exchange for that, they gain access to our network, which spreads the use of their design technology for rating, and we can expand it into the physician community writ large. Same thing can apply to the use of the platform. Let's suppose you have your own platform, or either a legacy platform or something else that you're using. If you want to improve it or modify it or expand it, you can join our network and we'll work with you to expand the use of that platform into your instructional environment. The test at the end of the day is, does it produce the results that we're looking for? Any educational system needs to have objectives. It can be passing a test, it can be learning skills, it can be expanding your knowledge. It can be proving that you're in touch with new technology and new ideas. We'll have a platform. We'll have a sector based on blockchain technology, which I'm just learning about. And blockchain technology is very material to the future of healthcare information systems. Why not? Why can't we have a course in that area? And why can't we use our assessment platform to measure the learning and application of this skill on the part of clinicians and organizations?
Hi. I've had questions to ask you. Is there any other questions you want me to ask you? Because I can't think of anything off the top of my head. So we got like 10,
well,
10
you might ask,
minutes.
You might ask something like, how willing are the professionals to use new methods to learn things or to improve their records?
So, Bob, can you tell us how professionals react to new education and new technologies?
Yeah, I think I can. I mean, I've worked with physicians for almost 40 years, thousands of them over the period of time. One thing I've learned is that very few physicians are excited about the prospect of taking another test. Now, they'll study in order to pass the test because they have to, but that's not what the emotional motivation is. They want to learn things. Physicians are learners. They're scientists. They're curious. And yes, they do have to study in order to pass exams, in order to meet one criterion or another, but they also want to improve their skills, and they want to improve their insight into what's going on with their patients. So I've found that, when it comes to the formal testing or education requirements, the certifications, the licensing expectations and things of that kind, most physicians just want to do whatever they have to do to pass the exam. They'll go to conferences, they'll buy a book, they'll get online and take some courses, and they're basically loading up information to pass an exam or to meet a licensure expectation or to satisfy some requirement to practice a certain kind of skill. But when it comes to learning that will make them better practitioners, better people, if you will, or more understanding of the interface between clinical evidence and practice, they're open to all kinds of ideas. And so the things I mentioned earlier about learning how often to study, learning what mix of questions and answers or studying techniques to use, learning more about themselves in terms of the methods by which they learn. Do they respond to audiovisual information? Do they respond to text? Do they respond to question formats? How long a gap does it take? That information is critically interesting to most docs. And I found when I was a CEO in this space that CME is a pretty, commodity type product. You get CME for basically showing up and eating hot dogs at a conference and filling out the back page of a booklet, which doesn't really mean you learned anything at all for more than the 20 minutes you paid attention to get the test done. But if you want to learn something, you want to spend enough time to acquire that skill, and at the end of the day, believe you have it. And so the methods that we're importing from the world of educational science, are actually materially of interest to our users. I can give you the best example I had of that was when I worked at Challenger Corporation as the CEO. We took learning materials, and we were selling things at a premium price, and people bought it because they knew that they were getting a quality product, and they would learn better than just regurgitating answers from a presentation at a conference someplace. So physicians are curious, they're open to learning things, they're scientists, but they learn better if the environment tells them or conveys to them that they'll be better practitioners and more knowledgeable once they do this, not just that they pass a test. Did that answer helpful?
It is. Like, the big question I have for this is, how can we make sure these physicians and these organizations, collaborate with one another to create a better education system for both organization and both for the physician?
Well, I think that, it's a good question, because naturally, at least for the commercial companies that are in this space, it's very competitive, and they're motivated by profits. If you look at the American education industry, there's lots of different ways to count it, but you can think of it as having a huge industry-sponsored component, billions of dollars. I think the last number I saw was $4 billion. And $2 billion is in the non-industry sponsored area. That's the stuff that universities make, professors make on their own, and there are some that are used by companies that produce peer-reviewed content, meaning the content itself is not subject to authoring or tampering by the sponsoring industry source. And you can see that when the audience believes that the material they're being presented is at an arm's length from sponsorship by industry, they have more enthusiasm for it. It's more credible to them. And you can make a market of that if you do it correctly.
Okay, so I'd love for you just to talk a little bit more about the GHIN. Why did you want to set up this education? At the very beginning, you said you wanted to go into the venture capital side of things. Like, how important is the education network that plays into the investment side of things as well?
Right. Well, there's a number of ways they overlap with each other. First of all, the network is a source of potential investors for the fund. Many of the people that belong to the network have decided they're so interested in what we're trying to do that they ask if they can invest, and it's actually quite affordable for practicing clinicians to do that. But beyond the reasonableness of the sum is the nature of the fund we've created. And the fund we've created is a unique one. It's aimed at physicians. So our members, our investors, by and large, are individual physicians, individual clinicians, or people in healthcare. And one of the things that appeals to them is that this is an organization run largely by the fellows like them. 3 of our 5 general principals are physicians. We have a finance officer who's not a physician, a young guy that works with us, and we have me. I've worked with docs for 40 years. I think they make me an honorary physician when they're kind-hearted enough to do that. But it's run by physicians. We have a very powerful due diligence network of docs. So ask yourself, when was the last time anybody who ran a big venture firm, or any medical firm for that matter, called you up as a practitioner and asked you what you thought we might invest in, or whether the thing that we were thinking about would actually work or be used. We do that. We actually have committees that look at potential investments. And those committees are dominated by physician members of ours or other physicians that we bring in to take a look at it. And they tell us, if they can't tell us that the product will actually work and that it will be used if it gets into the market, we don't invest in it. And by doing that, we increase our likelihood of actually having more success. So investors in our company become members, and they become active with our clients. We have several examples where physicians are either board members or they serve as advisors to these companies they've actually helped us select. So they get a personal feedback in their own lives from having played a good, important role in helping a potential company become successful. So it's a back and forth relationship. Network members can become investors. They don't have to, but if they can, they do. They also provide leads to us on both investment prospects and on other investors. And of course, investors automatically become members, and they can point out to us other potential investors or other companies we might look at. It's a very synergistic relationship. And I think the key to it is that we have a structure here that comes to the aid of what we call the disenfranchised physician. If you look around medicine in the United States and probably elsewhere, a lot of docs are burned out, and they feel like nobody really asks them any questions when it comes to doing things novel, whether it's using new technology or putting in new ways of doing things. And you'll find that most of the physicians in the United States, for example, are very unhappy with electronic health records and how they were put in, because nobody asked them about how to do it and what type of model would work. It was purely driven by industry. But we're trying to get away from that. And by empowering docs, we not only give them more control over their own lives, but we give them an antidote to burnout because they feel like that they're involved in what's going on in a critical role.
And I think it's important for everyone to understand the synergies between the education, the fund, and the network. So thank you for that. Is there anything else you want to talk about the network that the listeners should know about? Do you have any advice for those who aren't part of the education series but should be?
Well, there's some exciting things going on. We're expanding into other countries, building rooms for things to do. It doesn't have to be medicine. If you have an interest in venture capital, we have a section on that and a section in our education system on it. So we can teach you the elements that you might learn in an MBA course or a finance course right on our network. We have a lot of experience in that area. Can you hear me, Gary?
Yeah.
Okay.
Okay, here we go. Hey, now I see you.
All right.
I have 4 different screens in front of me, Bob. I have a YouTube screen. I've got a StreamYard stream. It's all over the place. Great to see you. Thank you for that great talk. Bob and I have known each other for a long time when we were both young guys. So yeah, it's kind of exciting to really talk about the educational component of it, because that's how Bob and I met, 20, almost 30 years ago now. I guess what I want to talk a little bit about is the possibilities for how to change the way we educate and change the process a little bit. Bob and I met again, 25 plus years ago around continuing education. That was my first company. His company had acquired my first company. And even in those days, we were looking at a prescriptive learning model, right? Where you weren't just educating yourself, but you were educating yourself with a system that took you in the direction of where you lacked knowledge, as opposed to continuously reading about what you already knew.
Yeah.
And that to me was really radical from that perspective, because at that time, what we had was a portal where we were throwing up some education. And here we are, fast forward, So now we have technology, and Bob talked a little bit about some of the relationships that we're forging and partnerships like MedForums with the idea of feedback loops and feedback mechanisms about education. But let's take it another step. And, we've talked a little bit about this. We've got a partner of ours that's working on data analytics, and another company within our network, which is looking at surgical quality. And there are all these tools out there to look at clinicians and look at clinicians' practices and look at the diversity of their practices. You can have a general surgeon who may do a lot of thyroidectomies, but maybe only does a couple of gallbladders a year. And how do we have ways now leveraged on electronic healthcare systems and data to look at a practitioner's outcomes in a way where they can be, not criticized, but certainly compared to their regional and national performances.
Right.
And it was just recently brought up to me, and I brought it to Bob, about the idea of taking that data and then creating, to coin a term we hear, precision medicine all the time, precision education, where now clinicians could have continuing medical education curriculums, okay, which are, by the way, mandatory. This is not something you may want to do. You have to do it to maintain board certification, to maintain licensing. So there's lots of reasons why you need to do it, but do it in a way where it's more than just prescriptive, but it's actually precision customized for you based on your practices, and not necessarily the strengths in your clinical practice, but the weaknesses that you have, but done in a somewhat anonymized way. What are your thoughts on that, Bob?
Yeah, that's a great question, and it's a timely one. I'll give you an example. Recently, I had a discussion of some depth with the CEO of one of our client companies, Plethy, which deals with post-operative rehabilitation in orthopedics and other areas. And I asked the president, I asked the CEO, how do you get your big clients? There's a tremendous amount of competition here. Everybody and his brother has a new solution for this kind of issue. What makes you stand out, and why do big orthopedic organizations like the Ohio Alliance for Healthcare and Illinois Bone and Joint, why are they picking you to use? And he said, I've got something that other companies don't have. Aside from being reimbursable, which of course that's important too. He says, I've got data. And one thing that drives decision-making by large medical groups or hospital institutions or places like this is data. And they collect it, and they have and then they're able to use that information to tailor the solutions they provide to individual patients based on that information. The precision element of this is where we're going in the future. I think we've seen it already, and you know better than me, the audience knows better than me, in oncology, where tailored precision medications for this patient and that seems to be becoming the standard when it comes to addressing aggressive illnesses. And so I think that's going to expand to other spaces as it becomes plausible. And it is plausible with the technologies we have right now. You got anything you want to add to that, Gary? Go ahead.
No, I would agree with a lot of that, and then just taking a step back towards what we're trying to create at the network, and certainly leverage, with our partnership with our fund and other funds, is that, trying to be a global agnostic environment that is not just focused on, we're not trying to be the next Medscape. We're not trying to be a Doximity, which is clinical based. We're more focused on innovation, entrepreneurism, acceleration, and generation of ideas from clinicians, and providing the supportive ecosystem to make that happen. But much of that is education based. I mean, a good example was Alex's talk before. As you know, I mean, an area for me that's I find a lot of interest in its possibilities is blockchain and healthcare. But at the end of the day, I would say that if I would venture to bet that if we try to discuss blockchain with most of the members of our network, and certainly many of our colleagues, that what they hear when you say blockchain is Bitcoin, right? But the reality is that blockchain is much more than that. So, Bob and I went, and, when we first met Alex, instead of saying, Alex, help us identify those blockchain startups and blockchain organizations that need to be accelerated, which there aren't that many, certainly domestically. There are some in healthcare. Is how do we educate the clinical user base on how we can benefit from it? Let's use some practical examples. So the idea of taking a blockchain community and tying it to, one of our blockchain educational communities and having modules of education related to that to show the value of it and how it can be used, again, stimulating idea generation from clinicians who now are a bit more educated on it and can see the value of it. So, from your perspective, how do we build on that, in the network and start to build these, and continue to build these communities? What do we have, like 90 plus communities now, which are not that large because we haven't marketed them quite a bit yet with our new version coming out. But how do we promote it through those communities and promote that education, which then stimulates innovation?
Well, I've got some ideas about that, and they're certainly not necessarily unique to me, and they're certainly not exclusive. But from all the years that I spent running a company that produced new curricula, I can tell you that what you need in any idea community is a champion. You've got to have one or two people, in this case, clinicians, who know something about the area and can provide information or anecdote or whatever with respect to that audience, but also has a passion. They don't have to be the Francis Collins, the head of the NIH. They need to be somebody who's serious about their practice, cares about it, and cares about enough to push new ideas and is willing to put those ideas into a community, which they may monitor or they may be part of, and put those ideas out there for criticism and comment, and then be willing to take the feedback and run with either creating curricula or content or developing forums in which those new ideas can be expressed. It could be a convention, it could be an online conference, but we need, if you don't have a doc backing a project of this kind, it's not going anywhere in the long run.
Yeah, I know we're aligned on this. And that's what we are trying to promote here, correct? Right? We're trying to promote creating these communities, bringing in the knowledge leaders, but then stimulating the interest of the greater global community to collaborate on it. And, it's one of the things that we are trying to build within the network is the idea of not a one and done episodic lecture where you listen to it and it sounds great and then you go back to work and probably the next time you think about it is the next lecture you listen to 6 months later. We're trying to use the education and use the conversations to stimulate ongoing, enduring conversation, which then results in innovation. So,
right.
Yeah.
One of the things that stands out in my view, for us, probably most of the people on this call are familiar with desk drawer studies at pharmacy companies. And what I mean by that is they're looking at the uses of a potential medication. But typically they'll bury negative results so you don't get a truly representative set of findings about effectiveness. You get biased study results. That's exactly the opposite of what we're trying to do. We want to create communities where these ideas can be criticized and can be looked at and revised, but where the audience, and that could include everybody on this call, can go on there and engage in a conversation with others with the belief and confidence that a full, fair examination of the proposed idea is going to be provided there.
Yeah, I agree. Is there anything else that you want to talk about? It's probably, it's been a relatively long morning and afternoon for a lot of our attendees. Is there anything else that you want to chat about, or we can give them a little bit of a break because we're going to come back at 3:00?
Yeah, I think I'm fine. Education by nature is something that requires a long-term thought process. It's not like an immediate reaction. So I just hope that today I've been able to sow some ideas and some thoughts, and that at least it might encourage some of our audience to join us if they're not already members and look at this opportunity as we build it. And,
right. Yeah, and I think, again, shameless pitch. I mean, as you join the network, I would encourage everyone. We do have a global health impact network, education network that we've created and continue to grow. We have communities within it, and virtually every community will ultimately have a parallel education community, which will hold its podcasts, which will hold its educational events and summits. So we're going to try to take even the content from this particular day and then unbundle it into its appropriate communities as well and foster ongoing continuing education in that. So for Bob and for what he's creating, I would encourage anyone who has an interest in educational theory, medical education in general, ideas of how to do things differently than we do, please join the community, get involved in the conversations, collaborate with us, because that's what we are. We're a collaborative community. So Bob, thanks as always. A pleasure to be able to chat with you on a global scale today. And why don't we just give everybody probably 10 minutes or so. And at 3 o'clock, we are going to be talking about the future of telehealth. Our network has a telemedicine 2.0 initiative, which is how do we avoid creating the problems that we did with electronic healthcare records with now this significantly increased usage of telehealth because of the pandemic, and take it into a specialty specific model, which is more comprehensive, which includes remote patient monitoring, chronic CCM patient monitoring systems, and including our goal to create a patient side of our network as well. So thanks, Bob. And why don't we return back in about 10 minutes or so.
Imagine what 1 million healthcare professionals could do if they work together to shape the future of our healthcare industry. Introducing the Global Health Impact Network, a clinician-driven collaborative network of communities focused on healthcare innovation. Through intra-organizational, intra-community, and inter-community collaboration, GHIN enables healthcare professionals to become leaders in healthcare innovation at the precipice of the evolving digital healthcare revolution. Clinicians, C-suite administrators, and others can actively participate in all aspects of the healthcare continuum. Healthcare organizations, including hospitals, academic institutions, and nonprofits, can securely and safely share their ideas and innovations on our platform so that healthcare professionals can create a future of improved access to healthcare, improved care delivery efficiency, and safety while decreasing the spiraling healthcare costs. A pediatrician can interact with top experts to access and learn best practices when approaching pediatric oncology or chronic disease management. A doctor can engage with early-stage healthcare technology companies through our partnership with the Global Health Impact Fund. No matter the purpose, every member has a wide variety of opportunities to ensure active involvement. Please contact us if you are interested in joining our growing clinician-driven global healthcare innovation network. Together, we can shape the evolving digital healthcare revolution. The Global Health Impact Network. Imagine the possibilities. Today, most social media and communication apps can feel like a trap. Click by click, you navigate their maze of countless windows and hidden ads, and in the shadows, they secretly mine your personal data to sell for a profit. We have a better solution. Hansen is a platform created for people to connect in private, secure spaces. Your data belongs to you, not us, and we'll help you to use it efficiently to make the right decisions. Within a single window, you can collaborate with teams or individuals, host and broadcast video chat meetings, seamlessly manage files, post social media links, and stay up to date with all your content on the dashboard. Even more, Hansen allows you to build beautiful, customized workspaces to serve your community. Creating and sharing content has never been easier, whether you're video chatting with one person, conferencing with a dozen, or broadcasting to millions across the globe. Organizations like the Global Health Impact Network have transformed digital health by sharing their innovative discoveries across vast communities, all without ever leaving the platform. At Hansen, your data is not our product. Instead, we provide a simplified, seamless, and secure work environment for you and your mission. Hansen, building communities of the future.
I'm Chris Kager, the Chief Medical Officer of the Global Health Impact Fund and leader of the neurosurgery community on the Global Health Impact Network. One reason that I was drawn to the Global Health Impact Fund was the emphasis on physician-driven innovation. By integrating expertise from all corners of the healthcare world to build a system that works for us and improves the patient experience was an opportunity that I could not pass up. As a neurosurgeon, I can appreciate the value that the Global Health Impact Network offers in organizing communication channels. The ability for members to collaborate asynchronously as well as live in the same call thread opens the doors to exciting opportunities. To kickstart the neurosurgery community, I've created several threads focused on innovation for members to share their experiences and insights into some of the most important topics in the industry. It will be here at the intersection of cutting-edge research and business development where we will find the founders and startups to invest in.
Hello, it is a pleasure for me to introduce you to the telemedicine panel. We're talking about the future of telehealth. And my name is Doug Sumuraga. I am the CEO of Vitel Health. And with me today is Dr. Brittany Busse, MD, President and co-founder of Vitel Health, Harjot Singh, and Chris Pavlatos, founder of PatientMD. And what I'd like to do is for each of them to introduce themselves, starting with Brittany, Chris, and Harjot.
Hi, everybody. Welcome to our chat today on the future of telehealth. I'm Dr. Brittany Busse. Like Doug said, I am the president and chief medical officer and co-founder of Vitel Health. I've been in the telehealth space for about 6 years now, mostly consulting with companies in occupational health on policies and procedures surrounding telehealth in that space.
Thank you.
Hi, my name is Dr. Chris Pavlatos. I am a board-certified internist and orthopedic surgeon, MBA from Kellogg, and CEO and founder of PatientMD.
Thank you, Chris. Harjot?
Hi, this is Harjot Singh. I'm a physician turned healthcare leader turned advisor and coach now. I'm chief of service of Kingsview Behavioral Health in California. And I have been doing telehealth since January 2006. So at this point, over 30,000 hours of work and counting. So I'm also faculty at American College of Healthcare Executives. So my work is, informed by all three perspectives, and that's what I bring.
Fantastic, Harjot. So today we've got some questions, and I hope that we will be as candid as possible with our experiences being brought to the table, different perspectives that we have here, but all with a lot of experience with telemedicine and telehealth. So the first question I'd like to pose on the panel and get a couple of different perspectives. Telehealth is a tool. We all know it's a tool. From your clinical perspective as physicians, what would make the telehealth experience the preferred doctor-patient visit before choosing an in-person visit? So who would like to go first with that? Chris?
Sure. From my perspective, I think what's really important is that we realize that probably close to 65 to 70% of patient visits do not require to have the ability to have to examine a patient, that many things can be done virtually. So I think what's really important for doctors to make it better is to have a list of diagnoses that they feel can be treated through virtual visits. I think having that first, rather than people all of a sudden scheduling telemedicine visits that are just not going to be able to be properly managed virtually, that will require an inpatient visit. So I think having a list of diagnoses is really important. Second of all, I think it's important to have access to patient data. So as we begin to see more interoperability in the market and patient data is more available, not just to us as physicians, but it's available to the patient, who can begin gathering that data from multiple sources and be able to share that with their doctors through use of telemedicine means or any digital means, is extremely important, because then we're able to make better decisions on the care of that patient. Other options, obviously, healthcare is a business and doctors have to run a business. So making sure that reimbursement is at least close to inpatient or in-person visits, I think is important. And we certainly saw that during the pandemic, and hopefully that still holds, because I think that creates the incentive for doctors to still want to be able to offer telemedicine visits. And the other thing that's going to dictate doctors providing this is the demand side. We're moving into a consumer-driven marketplace, and patients are demanding convenience, and they want the convenience that they see in other industries, from the banking industry, from the entertainment industry, the airline industry. They want a similar situation like that. So from that perspective, I think those are some of the key features that I think would be beneficial to promote telemedicine.
Brittany, what are your thoughts there?
So I agree with most of those points. I think, coming from the occupational health perspective, we would say, even 85 to 90% of those visits could be handled digitally, because the majority of those visits are musculoskeletal in nature, sprains, strains, overexertion type injuries, things that people get from repetitive motion. And, it's important for people to know that we are still doing an exam, and there's a lot that can be seen and done over telehealth. We are able to really inspect the area. We can have the patient do range of motion in front of us on the camera. So it's really important to say that we are doing it with video. And so you're getting a lot more from that interaction. Just because you're not putting hands physically on the injured body part, you really are still able to get a lot from the exam in those situations. For general health type situations, I've spoken to physicians. They are really keen on having the ability to have more digital devices that are in the patient's homes. So vital signs are really important for chronic care management. So getting those devices out to patients, making them simple to use, simple to connect, simple to get the data out to the doctors. And my doctor was listening to my chest the other day, and she said, I'll do telehealth when I can have a stethoscope that works as well as this one. So she couldn't really see herself doing telehealth at the time. But I have yet to show her the one that I have, which I think does work just as well. It's like I said, getting that equipment to the patient in question prior to the telehealth visit, or making that equipment so affordable that every patient could have a doctor's bag in their home. I think finally would be important to talk about the fact that in many states and also federally, there are regulations preventing telehealth visits from being a first-time visit. So to establish a doctor-patient relationship, for many situations, you do have to have an in-person visit. That changed a lot during COVID, but there are situations where states and federally, they still require patients to be seen in person prior to having any telehealth administered. So all of those things would be important to change before we can really have a digital first experience.
Great thoughts, Brittany. And Harjot, I'm sure you've come across and have comments on what both Brittany and Chris have shared here in the telehealth world. Now, you as you mentioned earlier, have been doing and clocked in how many hours of telehealth visits?
Over 30,000. We stopped counting after that.
Okay, right. You stopped counting. Exactly. So
Yes.
you've got firsthand experience, and you've seen what works, what doesn't work. Share with us your experiences there on this telehealth as a tool.
Both Chris and Brittany said something so eloquently, which is when we start talking about preference, sometimes the focus is on the patient preference and sometimes the patient is on the doctor's preference. However, the reality is we have to integrate the both. And second thing is the integration has to happen with new ideas. So we can't be practicing almost like 19th century medicine. You know, I'm sitting under the apple tree and seeing patients. It has to involve, like Brittany said, you know, something better than a stethoscope. We have off-the-shelf technology which can be integrated now. So that will really eliminate, you know, 65 to 90% of office visits, which actually should not be done. They have no point or a purpose. But sometimes we are forced to do, and, you know, okay, I have no shame in saying because of billing purposes. Because the state law says you can't bill if you didn't see the diocese, if you didn't see the patient. Now, of course, COVID came and uprooted all those things. You know, imagine how fast the transformation happened. I remember in summer of 2012, 9 years ago, there was American Telemedicine Association's meeting in Washington, D.C. We had congressmen from both sides, and we were saying, give us national licensing.
Right.
Nothing happened. Nothing. And COVID comes and boom, it was never an issue. So that means that this kind of just haphazardly put change can be very, very difficult. But if you try to organize the material, if you try to see it in your head, we're doing it for InnovatorMD. So we are focusing on MDs who are thinking of telehealth. So my message to them is, you have to take the lead in this thing. You cannot just sit back and say, I'll just go and sit and use the stethoscope that's given to me. You have to take active role in this process. There are going to be 4 layers of issues and problems. The very first layer always is the legal issues. We can't get around that. We just talked about a legal issue, which is the licensing issue. Second is the financial factors. We can't, and Chris was talking about financial factors. We can't get around that thing. It's very, very difficult. So we have to make it work. Now think about the innovation. In psychiatry, for the last 10 years, we have integrated health in which the psychiatrist doesn't see the patient, but guides the other physicians in managing their patients. Research shows it's good for the patient, it's good for the doctor, and it's good for the consultant. We haven't figured out a way to pay the psychiatrist till now. So financial fact, and the program can't take off in the majority of the country, even though the program is known to work. It is an innovation. Integrated behavioral health is an innovation, and we can't apply it. National Institute of Health has even stopped measuring if it works. They're just seeing how are the better applications of this going to be. We can't use it. So legal factors, financial factors, and then come the technical factors, which means the remote teams can get kind of very much lost in technical issues sometimes. I remember using T1 lines when we were there. We were using the hardware and software were integrated, and we couldn't do what we're doing right now. The equipment that used to cost $30,000, now I can set it up for $800, $400, even if we start pushing it. So technical factors, and we know that remote teams can spend, a remote team leader can end up spending up to 8 hours a week just doing email and texting and messaging and stuff like that. So technical factors have to be taken into account as well. However, if the program is going to sustain itself, the program has to take care of human factors. So the human factor, which is the patient on that end and the doctor on this end, they all have to be taken care of. I'm a big fan of our human force, and we call them our telemedicine champions. So the team that's on the other end, which is on the distal end, needs to have a champion. Even though people have written guidelines about it, and they try to call them coordinators. No, they are the champions. I have seen the difference where a champion made the program a success, and where they had a turnover, we couldn't find a champion, and the program failed. So the legal stuff was in place, technical stuff was fine, financial stuff was running, but because we did not have a champion on the other end, the program fell.
Yeah, so the value of people, right, is so important. And on that note that you're making, I want to jump to the next question because it has that hands-on importance. And that's this. Do you have thoughts on advancing a hybrid model of care with a combination of in-person and virtual care?
So I can start, I guess, with that one too.
Sure.
Anyone can start, but we at Vitel Health definitely believe that it's a digital first model, not a digital only model. Like we all know, there will still be situations where follow-up will have to be done in person for primary care issues, for orthopedic issues. There will be times when someone from the team should lay hands on a person. So the way that we've done that, very frequently in occupational health is by partnering with in-person providers. So usually therapists, physical therapists, occupational therapists who put their hands on the person and let you know really what's going on with them musculoskeletally, which I felt was really an important part of what we were doing in occupational health, because what you see in this area is that most providers were not experienced or trained in doing a good musculoskeletal exam. They aren't orthopedic surgeons like Chris, they're just maybe internists, or they are, interns who went to work at urgent cares or concentras who really have no idea what they're doing when it comes to an exam. So I think it's really important to realize that as much as you can do a really good exam remotely, and that 85% of the diagnosis is going to come from listening to the patient, from taking a good history from that patient. There are times when you're going to have to physically put hands on the patient or listen to the patient's heart and lung sounds in person, just as a follow-up, but do some of the interim follow-ups remotely. So we really want to champion that type of model where we use our time resources and our physical location resources well between all physicians in a group, where we're not just stuck in a clinic or you're not just working from home, but you have the capability to use both sides of that facility.
Thank you for that, Brittany. Chris?
Yeah, the hybrid model I think is critical moving forward. One, patients are going to demand it. Two, it's a money and time saving process. So if you're in a value-based healthcare system and you're taking potentially full risk capitation, I think it's important to be able to have that hybrid model, because you certainly save a lot of time and money by going through having telemedicine visits. So from that perspective, I think it's going to be really important. And the other thing is people want to stay healthy and don't want to get sick. And we're starting to see more and more the adoption of smart watches, other home devices, sensors at home that produce tremendous amount of data that in the technical world referred to as the IoT data, Internet of Things data. And that data is extremely important. In fact, there was a nice review done by Deloitte, who projects that within several years, IoT data, that data coming from home, is actually going to be more important than data that you get from a hospital or a doctor's office, which tends to be episodic data. And here we're getting continuous data from these monitors, where we can then use technology and artificial intelligence to be able to detect if there's going to be a problem and be able to manage patients from home. And patients want that. They want to be able to be managed from home. If there's any problem, catch it early so patients don't have to go to a hospital or to an emergency room, where we all know that once you're in the hospital, bad things can happen. So you don't want to go there. So I think from that perspective, I think you need that hybrid model. And I think physicians that do offer the hybrid model are the ones that are going to flourish in their practices, because it's going to be a demand that patients are going to want. Things that we're still going to need to see, obviously, the prices of some of these devices going down. We're going to need to see a lot more broadband in the rural areas where access is somewhat limited. Growth in the 5G network, I think, also would be advantageous. I think all those factors coming together, I think, make it a perfect timing for a hybrid model for physicians to adopt.
Thank you, Chris. Harjot, you have a thought?
Well, I totally agree with everything, mainly because what I have seen so far is that at this point, even in our wildest dreams, we can't think of what's going to happen, what we can hope, what we can do. It's kind of like a wild, wild west out there.
It is, isn't it?
But yes, it is. And
it's a very fragmented market. Still, it's very fragmented.
Yes, very, very fragmented.
Tremendous opportunities right now.
We have tried so many video conferencing platforms. It's like unbelievable. And what I have found is that if you set aside time to talk to people who have boots on the ground, they come up with ideas, workarounds, or you can call it innovation, that I can't even think. I can't come up with it, because they know what's happening on the ground. They have done things. They know their local resources. Things happen if you are open-minded. So instead of having that top-down model that we know the answers and then we're going to go and tell these people what is going to be working. No, you listen to them and you figure out they know more than you. In fact, patients know more than us about what's going to work for them and what's not going to work for them. So imagine, let's think of a hybrid model. Now think of how wild this model is. But some of this has already been applied when the doctor has been traveling to patients' homes. So high-risk patients who have volume of admissions each year. So let's say a patient who gets hospitalized more than 3 times a month. I'm just making it up. They're costing so much. And we know at this point, if you figure out a way for them, for the doctor to go to their home, and the volume of visits goes down, the patients are healthier, they live longer. However, now think about, how about the people who are on the cusp and did not even qualify for this level of services? How about if we have people who are not physicians, but who are out in the field, and they go and they can put their hands on the patient, like what Brittany was saying. And you have 4 people out in the field. One is setting up the patient for the doctor to see. Second is where the doctor is actually seeing the patient. Third is who's wrapping up with the patient. And the fourth one is traveling out in the field. And
Right.
how many patients are still in their homes? We're using all the devices, which at this point are really off the shelf. We haven't even used off the shelf stuff that's out there. Doctor is still in their office, and such a simple innovation. You are of course, there is so much cost savings. The patients don't have to travel. The time is being saved, and patient acceptance is high. There is no-show rate in this model, and the doctor satisfaction rate is very high, because this is a true hybrid model in a way that the patient is being seen in person while remote at the same time. So it is a wild, wild west out there. So this is not the only one. And this idea was actually brought up by one of our case managers.
Yeah.
She brought it up, and I said, wow, look at that.
Absolutely.
And the other thing, Harjat, it's not just improving what's best for the patient and the doctor. Let's look at it even from the employer side. When you can have patients that don't have to take a day off from work.
Oh, yeah.
To go see a
that's right.
doctor. The loss in productivity at an employer's has a significant economic effect on our economy. So having the convenience of maybe over lunch hour or taking an hour break to have a telemedicine visit with your doctor and not having to leave work and still be able to be there, and they don't miss revenue. They don't have to use a sick day or a vacation day, what has you, is a huge benefit to not just the patients and us, but the employer.
The workers' compensation industry is a $100 billion industry, a lot of which is how do we keep the employee healthy? Let's look at preventive or holistic type of care, which brings us to the third question. So I appreciate everything that you guys have brought up there, Harjat. And when we look at holistic care, how do we improve upon current telehealth models to promote a more holistic patient care model? Patients are, and do we even want to use that term, right? It could be employees. It can be, they're not patients yet, right? The idea is that they want to remain healthy. So how do they become, whether they're an athlete? I was just speaking with a group that focuses on athletes. The Olympics is going on right now, right? They want to stay in the game. If you're an employee, employers and yourself as an employee wants to stay healthy and working. And more people are taking responsibility for their own health. So how do we promote a more holistic patient care model? And how does this benefit doctors as well as their patients?
The area where I think it's going to be extremely advantageous is in the ability to care coordinate for the future of virtual care, because one of the things that you see many people go to the Mayo Clinic is because they get a team experience. It's a team-based approach to managing a patient's care, where you go there, you get all the visits, you get all the tests, you see all the different doctors, and they collectively come together and tell you, okay, this is what we're going to do and how to manage you. So imagine being able for us to manage patients with chronic disease, who we know cause 75% of healthcare expenditures. Over 50% of the population has at least one chronic disease. That if you have a patient with diabetes, hypertension, cardiac issues, COPD, to be able to bring in the primary care specialist as a moderator, you have the cardiologist, you have the pulmonologist and the endocrinologist there. You're doing a Zoom-like meeting with the patient and their family there, saying, okay, these are the medicines you're taking. We're going to eliminate this. We're going to add this to your regimen in the management of your care. And you get a common agreement from all the different parties in the management of your care. How often do we see that now? Many times we write a prescription and the other doctor doesn't know what prescription was written in many cases. And you write a prescription and that may interfere with the drug that the patient's currently taking. So having the ability to create that patient experience where they feel comfortable, where all their doctors having a Zoom meeting like this, where you can see all the doctors, ask them all the questions, and they're telling you, this is how we're going to manage your care. And as we move more and more into a value-based healthcare system, and especially in full risk capitation, I think having this team approach where you could do it maybe once or twice a year with the patient, depending on the severity of their medical conditions, I think is going to be a huge benefit, not just to patients, but to doctors, because we feel like we're providing the best quality of care we can to our patients. And obviously that's the reason why we went into medicine. And being able to do that and provide that to a patient, I think can be extremely rewarding.
So team collaboration and using technology to advance that collaboration in a practical way is what I heard, Chris, maybe once or twice a year where you can bring all the team members together, because you can't really do that on a regular basis, right?
No,
So
that's right.
But setting up a plan, very interesting. Brittany, do you have thoughts on this?
Yeah, I mean, I definitely agree with Chris in that sense that, collaboration is extremely important. You need to have all of your care providers on the same page, and that's really helpful for the individual as well. But I guess stepping it back, even from chronic care patients to people, like you said, who are otherwise healthy. So for employers who have a large healthy population, who potentially just want to prevent injuries. They want to be looking for things in their employees, screening for mental health issues, screening for stress, screening for burnout. You can really incorporate a lot of those tools into your practice that people can use on a daily basis or a weekly basis just to keep track of their own health goals. And if they do have something coming up, making it really easy for people to get the education that they need, make it easy for them maybe to get laboratory exams even before seeing a doctor if they just have a concern, and that can refer them to a doctor in the case that something comes back negative. We see people taking this into their own hands already all the time. There are companies that are really well out there providing people at-home testing for all kinds of things like gluten intolerance, other food allergies, and people are out there and they're taking these tests and they're not necessarily getting any kind of follow-up on them. So incorporating testing into your holistic treatment plan, and also incorporating other types of providers into that program. So allowing people access to health coaches, access to nutritionists, access to behavioral health specialists, all of the people that they may want to talk to, including for, like, say, skin concerns. A lot of people maybe are better served by an esthetician than a dermatologist, and they just don't know that. Or they're better served by a massage therapist than a pain specialist, and they just don't know that. So providing them the resources to tailor their care is something that patients and people are asking for. People want body autonomy. People want to feel in charge of their own health. And I think, Harjot had said this earlier too, is that what we're seeing is that, people will want a physician for guidance. And it won't be that top-down approach anymore, where the physician is telling them what to do and they're just going to go ahead and do it. We're going to have to incorporate other kinds of care providers. We're going to have to educate ourselves in addition to the patients, and we're going to have to do a better job listening. And I think telehealth can help us with all of those things.
Thank you, Brittany. And great thoughts. And Harjot, on that thought, because you're much about training and QA and getting it out there, share with us your thoughts on that perspective.
Well, this is where they both said it right. One of my great culture teachers was a neurosurgeon in India. I was moonlighting in an emergency room. He taught me in medical school, but he later on moved to this hospital. If we had a patient and if he had 5 minutes, he would walk out of the ER and he would find the family. But because in that place, there would be people from the neighborhood, people from the village, sometimes the village chief is there. He would gather everyone. And no matter what, he would answer everybody's questions because
No,
he knew. Yes.
no concerns then, huh?
Well, here's the thing. He said, look, they all know each other. And it's almost like insulting somebody, because then that person who feels like who was not heard is going to create problems to the doctor and patient care. Whereas if you calm everybody down just by acknowledging them, you would comfort them. And what Chris said, it's like, I used to consult with a group home in Mariposa County, California. Very, very nice place to work. But it was never the patient alone. It was always the therapist. It was the non-therapy staff in the group home and the family members. And with telemedicine, we were able to get everybody in. And even in 5 minutes, you could address their concerns. The treatment went smoothly. Because you see, in the mind of the patient who depends on the family, there are so many pressures they go through. Oh, that doctor doesn't care. Oh, that doctor gave you a medicine that killed my neighbor. And now the patient is refusing the medication. And you come back 2 weeks later and the patient has not even taken the medication. Or the staff is calling you, the patient isn't taking the medication. But if you listen to them, you talk to them, telemedicine is like beautiful for this. And now it's so cheap, there's no reason not to do this. So what can be more holistic than, putting all the human beings together, listening to their concerns.
Giving them real news and not the opposite that we seem to be talking about all the time here today in the media. Give them real news, not the opposite.
That's right. And one of the things that, I emphasize more about primary care and specialists coming together. But as Brittany said, and you said, Harjat, it's bringing other providers also in on the care. Because one of the key issues for managing a patient's well-being and their health is looking at the social determinants of health. And we know that requires other providers to be involved in the caregiving team. So being able to bring in the clinical providers and social workers, dietitians, behavioral health, and all the other people together to do a comprehensive management of patient care, I think is the ultimate that we should all strive to achieve.
And even when we talk about training staff, these are live trainings with the patient right there that happen. You want to educate your staff, you educate the family, staff, patient, all at the same time. And over time, the staff gets the hint that you're going to say the same thing again. And so they get what you're going to do, what you expect them to do. The quality of care goes up that way. And the staff satisfaction and patient satisfaction too. I'm sorry.
So which kind of
sorry, Doug, I would just add one thing, that we saw a lot, and that was in the compassionate care model. And it always had to start with agency. If you take away somebody's agency, then you are going to fail in treating them. And that's going to happen every single time. And if you don't advocate for them and you don't listen to what's going on with them, you're not going to succeed in having a good patient-physician relationship with that person. So I think, like everyone's saying, telehealth is a great place for both agency and advocacy because you're allowing so many people to be heard. And when someone feels really heard, then they're going to want to participate in the treatment plan or the preventative health plan or whatever else you feel like is going to be helpful for them in that situation.
Thank you for that. So we've been focusing on the patients. Let's go to the other side of what telehealth does in impacting healthcare for providers. Can telehealth help reverse the trend of clinician burnout? Brittany.
Yeah, so this is something that I am particularly passionate about because as a physician, I had gone through several stages of burnout, several instances of burnout clinically. And when I had heard about telehealth, I thought, oh my gosh, this is the answer to all of my pain points. I had a friend who had been working remotely in consulting and government work for a long time. And I would always just think in my head, if I could do that, if I didn't have to show up to the clinic every day, I would have such a better quality of life. And like I said, it goes back to agency again. What does the physician want to do? What is going to be beneficial for that physician in caring for patients and really fulfilling their purpose and utilizing their unique skills? And how do they find the patients that they're going to connect with? Sometimes you're in a limited geographic area and you're trying to provide care for people you're just not connecting with. And maybe you have a passion for lifestyle medicine or functional medicine, and at your clinic, you're doing mostly chronic care management and nobody wants to change their diet. They just want you to give them more pills, and you're burning out because you're not really living up to what you feel like is your purpose in life. Well, the great thing about telehealth is you can expand your geographic presence. You can start marketing yourself and you can find the people that you're going to connect with who you're really going to help provide services to. And you can do that on your own time, at your own schedule. And you can use other digital tools to supplement your income so you can actually see less patients and have more of an impact. So I think that telehealth is providing an immense opportunity to help physicians really balance in their work-life schedule, again, by bringing them closer to patients, by helping them connect with other care providers so they're not taking the burden of care all upon themselves, that they can act in a capacity of guiding healing and really quarterbacking that person's healing process and coaching them through their healing journey rather than taking the full responsibility for patient healing on themselves, which is really the old paradigm of care, something we need to start moving away from.
Beautiful. Chris, I'm sure you have thoughts on this as well.
Yeah, certainly burnout is a big problem right now that we're seeing. We're seeing a fairly high suicide rate in doctors. Some reports say as much as one doctor per day has committed suicide in the U.S., which is obviously very tragic. From a burnout perspective, doctors want to be able to do their work, but then want to be able to go home and spend time with their families. One area, you never want to bring your work at home, but if you can get out of the office a little earlier, spend some time with your family, and then finish some of your visits at home via telemedicine, I think that could create a little bit better balance to do that on an occasional basis so you're not stuck in the office finishing all your work and being away from your family. And then if you have young kids, your kids are going to go to sleep by the time you get home. You don't spend time to see them. So having the ability to maybe take some of your visits and put them towards the end of the day and leave the office and go back home, spend time with your family, have dinner, and then finish up your office at home virtually, I think could be another attractive feature for you to do on an occasional basis to help address some of the burnout issues.
And I guess I would just add to that, as a person who's been doing kind of full-time telehealth for a while, is that I think it is good to have a space that is dedicated to your work. But honestly, I embrace the opportunities to be more human in my interactions with patients. I mean, we started seeing this a lot when people did Zoom calls. I mean, you have a kid running through the background or my dog's in the background. Honestly, patients, they love it. And they see me as a human being, and they are a lot more likely to open up to me. So yeah, if my child is crying in the other room and I got to strap them to me during a telehealth visit, I'm not going to feel embarrassed about that. I'm going to tell my patient, hey, I'm a mom. I strap a baby to me sometimes during a telehealth visit to keep my baby calm, but I'm here for you, and this is what I can do to be a good overall person. And I understand that we all have things that we're going through and we're never going to be totally perfect.
No, that's a great point. And Harjat, someone that's been pretty much full-time telehealth for many years now too. What's your perspective?
Well, I looked into the issue and I found something which is in a new team, the providing team is still more once all in the same place at this point. However, because we have been doing it for a while, our providing team is also spread out. So our doctors are all over the country. And our people who are coordinating from our side are also not at the same place. So then we have to look into how remote teams work. Tell them the team or not, Because even if we see the patient, sometimes I may not see my coordinator, who is, in the background running everything, making sure the scut work doesn't come to me. And that's where some of the sinister things start to show up in remote teams. So Vital Smarts, they had done research. They showed that when they studied, when they actually studied it, that 13 out of 14 common workplace relationship problems, they happen 2.5 times more in virtual teams, in relationship and communication. And what people have found is also that when you try to solve these problems, they also are more difficult to solve, and they also take longer to solve than on-site colleagues. Because it's natural next step that the team is gonna go remote when that starts to happen. At the same time, the problems are not just actively done. There is a lot of passively bad things that start to happen. Silence, dissuading people from working with remote colleagues, criticizing, gossiping, and because it's hard to read body language, misreading body language at times in remote teams, it happens 2.5 times more common than with the teams that are at one site. At the same time, if you think about it, now we don't notice it as much, but this becomes so prominent in remote teams. This was an article in Harvard Business Review that almost 1/3 of value-added collaboration in any team is going to come from about 3 to 5% of the employees. These are highly engaged people in a particular team who are on the opposite end of the burnout. And in a remote team, just imagine a discussion is happening. They are going to be looking like they're live wires of energy, and the ones who are not contributing, they're going to stand out. And their contribution or lack of contribution, the downward shift in productivity on that end, and the low bar that they are going to set is very clear to see. And that is not a very good place for creating burnout. If you look about, as I had mentioned earlier, it puts even more pressure on the team leader to have even more two-dimensional communication, and which is texting instead of talking. And there's less chance of socialization before the meeting, after the meeting. So actually, the remote work can put a lot of pressure on the teams in that way. So for a doctor, to feel efficacious is to feel spiritual. My life is meaningful, my work is meaningful, my life and work have a purpose. All three can kind of deteriorate in remote teams if it's not taken care of. I'm going to put a shameless plug here. Healthcare Administration Press is coming out with a book called Physician Engagement: What it is, why you need it, and where to begin. Because engagement is the opposite of burnout. And my chapter is the showcase chapter in the book excerpt. You can go and read it. That's where what I basically talk about is that doctor needs to feel like they're engaged.
On that note, we're running out of time, so this is our last question. Okay. But I want you to finish your thought on that note. And this is the question, because it's how can we work to improve quality, right? Because that's exactly what you're trying to answer there.
Yes.
Quality and access to telehealth, so it becomes a more universal part of the healthcare ecosystem. Let's end with this question. Let's tie it all together, because really that's what we're looking to do. Yep. We know telehealth as a tool is going to become mainstay. It's just what we do as part of healthcare. What is going to increase its quality, its acceptance, its adoption, because it's here to stay? You want to finish your thought on Harjat?
Yeah, well, what I was going to say was that engagement, like everything else, can't be forced. We're going to engage. You have to, the other person, human being, the doctor or the other workers have to feel like they're engaged in the work. And the concept is called flow.
Exactly. That's a great thought. So Chris, You want to have a
Yeah, again, like we talked earlier about the expansion of broadband and 5G networks, obviously, technology to become more easy and very simple, both from patients and physician standpoint. Having more training for physicians, both from a technology standpoint, a privacy perspective, as well as how to handle themselves when dealing with virtual type of care is important. And then I think eventually the use of AI, where you could begin collecting data through telemedicine and do some predictions on what the provisional diagnosis is for a patient that could assist the physician before they even actually see that patient coming online, I think could be extremely beneficial. And in fact, you could use that data eventually, and with the proper algorithms, you could determine what's the appropriate visit for that patient. Is it a clinic visit? Can it do telemedicine? Can it be a phone call? Can it be asynchronous form of communication, the form of chat? All those are potentials. And that's where I think technology could play a better role in streamlining the type of patients that should do it, as well as assisting the physician in helping make a diagnosis in the management of the patient care. Not using AI exclusively, but as we get more data liquidity and more data is available to the patient who could then share with their doctors, and the use of AI, I think can certainly make life a lot easier for the physician.
Thank you, Chris. That's fantastic. So Brittany, as a summary, before we close up.
Yeah, I would say I agree with a lot of what everybody is saying. It's really important that we have access to data, that the patients have equal access to providers. So really making sure that underserved, not just remote communities, but also those in cities who don't normally have access to healthcare, have access in places where they go, like churches or barbershops or other community gathering places where they can actually have access to good quality healthcare. So really improving that. And, the last thing, it would be improving the health of teams, like Harjot was saying. It isn't just the physician on these teams. We found that it was really important to train and hire the right people, not just to take a medical assistant from a clinic and stick them into a remote position, just like you can't take a physician from a clinic and stick them into a remote position without training. They need to understand how to communicate. The physician or who's ever managing those people needs to be well-versed in emotional intelligence, and they need to have regular meetings with their team and one-on-one meetings with their team, not just group meetings, so that they are checking in on the health of team members, because any person on that team who's going to be interacting with the patient is going to have an impact on that patient's health outcome. So I would say to our team in the hospital, even the janitor working in the hospital had an impact on the patient's outcome from surgery. Every single person who touches any element of that patient's care, we need to make sure we're caring for those people as well, so that they're able to put their best self forward in patient care.
Thank you so much, everybody. I appreciate all of your time. We're going to open this up to the audience for questions and answers, and hopefully give them enough time. And on that note, I want to thank you again, Dr. Brittany Busse, Dr. Chris Pavlatos, and Dr. Harjot Singh, for your time today. It was wonderful discussing the future of telehealth. We'll see you guys.
Thank you.
Bye now.
Thank you.
Bye.
Welcome. So we're back to the live part of this with question and answer. Doug, thank you for moderating that. Harjot, thank you for participating. Thank you to Brittany. Thank you to Chris. I think this is yet another example of the value of having a place like Global Health Impact Network and a community focused around telemedicine and our Telemedicine 2.0 initiative to show the value of collaboration, okay? Because, again, like we mentioned earlier, when you go to HIMSS and there's, several hundred companies and everybody's at their own table and not talking to each other, not a lot gets done in terms of interoperability, where this is a perfect example of a group of telemedicine experts coming together to collaborate for the future of healthcare. So thank you, everybody. Good to see you all.
Good to see you, Gary.
So let me see, we've got, I laugh every time I jump on here because I'm sitting in front of 4 different streams. I've got a StreamYard stream for GHIN, and then I've got the YouTube stream for GHIN, and then I've also got the IMD group and their Zoom stream, which is actually streaming the YouTube stream. So we're all over the map. So there's questions and a number, questions are coming from a number of different places. I'll start with, for Harjot, we've been talking, the group has been talking about challenges in building remote teams. And certainly Global Health Impact Network and our hands-in platform is working to address that from a clinician perspective. So when you talk about that, how do our clinician members in the audience build their remote teams to address these kind of issues, right? Not we can get as granular as the patient-provider interaction, but then there are steps above that as well, at the practice level, at the enterprise level. So how do the people down in the trenches start to build those teams to take advantage of the technology?
Well, like I was talking about, there are 4 levels of factors that are going to come into play, no matter where and how we look at it. The first one are the legal factors, and then there are financial factors. There's no way around it. That's like the entry in. In fact, the finances are important. Brittany was talking about impact, but the money gets you in. That's what I've seen. If you can't kind of justify with money, but the money only gets you in. That's a very important thing to remember. It's true for jobs. It's true for hiring people, hiring employees. Now, the next step is technical factors. Just like you will not compromise on legal factors, you can't afford to compromise on financial factors. I would urge you, don't compromise on technical issues and factors. That's not where you're going to do any cost cutting. It's not going to serve anybody at all. That's right. That's where some time and money spent is going to go a long way to make sure things are done right. Even like, I may sound like I'm afraid, because right in the beginning, we were always worried some bad thing was going to happen somewhere and we will be shut down. We're talking 2006, 2007. A lawsuit was going to happen in Ohio or somewhere. Somebody was going to do something weird and we were going to be shut down. No, none of that happened. But we still should not compromise on legal issues, financial issues, and technical issues. In fact, technical stuff is so cheap at this point. But the thing that ends up sustaining it, one of the commentators was saying that in innovator world, people want to build and sell and get out. Telemedicine is not like that at all. In fact, building it, okay, you're done, but then you're going to have to sustain it. And it's in ongoing sustenance where the impact is going to happen. The impact that everyone will feel for a long time to come. That's where the real innovation is going to happen. So that's where. So let's take what COVID has done. COVID has actually done. It's like a tree has been uprooted and shown the roots for. It's like a big storm has come and shown us for who we are. At the same time, this is a great opportunity. If you think from the crisis model, when a crisis comes, a team or an organization has 3 options. One is that it's going to deteriorate, disintegrate, disappear, and go away. Sadly, that does happen. The second is it'll try to come back to its baseline, and that's what the entire medicine is trying to do. And that is the wrong thing to do at this point. Mm-hmm. The third option during and after a crisis is to get to a new, better, higher, more efficient level of functioning. And that's where telemedicine is going to play a big, big role. Yeah. And like I was saying, this is where sometimes people start asking me, well, how do you train these telemedicine champions, or how do you create these teams? I said, look, each one has such an individualized situation. It is going to be like that for some time to come. So this is a very, very good opportunity to not only look at legal factors, financial factors, and technical factors, but also to put human factors in place, right, and not compromise on any of those things. I can vouch for it. In our experience, it was by not compromising that we sustained ourselves and serving the humans, like what Gary was talking about, team on this end and team on that end, and taking care of those people. Like our contracts, the sales cycle is long. We help them do paperwork, and they have political winds blowing on their end. So be in it to sustain and for the impact, like Brittany said.
Yeah. So, I mean, let's take this to the next level. As you all know, what's very important to me, having spent the last 9 years as an informaticist for a 27 hospital system and dealing with electronic healthcare records, short of having to avoid the darts that were thrown at those of us that were implementing it. Here we are now. We're post-pandemic. We have the advantages that the pandemic has given, but the expectations are also much greater as well. So to take telemedicine pre-pandemic, which was essentially a video connection between a provider and a patient, and then say, what we really need to build is to optimize the patient-provider interaction and make it more specialized, make it more targeted. I mean, there's no reason that a dermatologist and their patient should be using the same platform as a cardiac surgeon and their patient. So how do we take what we have, take it to the next level, and add that comprehensive interaction between a provider, including RPM, including CCM, including revenue cycle, including specialization of that interaction between the provider and the patient? Brittany, what are your thoughts on that?
So I think what we really want to do, and what Vitel is trying to do, is build those kinds of customizable solutions to find best-in-class EMRs that are already built, or to add in the features that each individual specialist is going to need. We started with occupational health, which was really different than general health EMR. You have to have a lot of specialized functions in there. You have to have a different way of communicating with patients and with different stakeholders that just simply weren't found in your traditional EMR environment. Mm-hmm. And we want to take that experience and customize that across the board. Like you said, we add in the ability to add RPM and CCM. We provide the right kind of clinical management. We can train the teams, using our connections, especially, through Harjit, because he's done that many times. And, we're really looking to create an online community with GHIN where we can find the providers, and we can bring these providers together, like we talked about during the talk, from all different walks and specializations in health, and create these customized solutions so that patients can come there knowing that they will be in control of their bodies, that we will find the best solutions for them, that we can knit together a comprehensive care plan for them, and we will become their guides to better health rather than the gods trying to control it.
Right. Doug, just quickly, some input.
So we've talked about precision medicine, and that telemedicine is that tool that I believe, with interoperability and truly understanding the ecosystem, and the ecosystem is all about people, right? It's about the physicians, it's about the patients or the workers, and the payers are all part of this ecosystem. So as long as we understand what each stakeholder requires in that ecosystem, and we streamline it, and we meet those expectations of that ecosystem, it becomes a much more personable, and it can be a much more personable, real relationship where it solves not only this physician burnout, which is a big topic. Real relationship where it solves not only this, but it also is a part of a bigger solution, which is solving the interrelationships between all parties And that can all be done with the technology we have today. We didn't have this before, Gary.
Yeah.
And me being a technologist for my entire life and seeing where we are today and the tools that are available through AI, telemedicine is another tool that we use. The remote patient monitoring, chronic management, they're all combined to provide a preventive way to better medicine.
Okay, great. I'm just trying to keep track of the time.
Yes.
Nicholas just gave us a little bit of a reprieve. I apologize. Chris had a little bit of a trouble getting in one of the 4 streams that we
Hey,
have.
Chris. Hey, how are you, everyone?
So here he is. Welcome.
Sorry about that.
It's great to have you here. So from a PatientMD perspective, just take maybe about 30 seconds to talk about how you're working on, adding a level of specialization and optimization for that patient-provider connection.
Yeah, I think what's really critical for us, and something that you believe, as I do believe, Gary, we need a network. We need a network of physicians and a community of physicians, and we need various technology that will allow us to be able to deliver the best quality of care to our patient. That requires multiple technology fully integrated on a single platform. And that's been one of our focuses with PatientMD. Create a one-stop shop for the digital health world. So physicians can go to one place, patients can go to one place and connect with doctors across different areas in their community or across the country. And I think that's what's really important. That's what people are looking for. I think physicians are looking for that, patients are looking for that, and that will take the technology headaches out of most physicians' practices, where they can go to one facility, one place, and be able to get all the services that they need fully integrated, and we're connected with each other. That's absolutely critical for us as physicians, to stay connected with each other, communicate with each other, share information with each other regarding patient care. And I think that's going to be the future of medicine and the future of our profession.
Great, thank you. So I think that, what resonates amongst the whole group and probably this whole day is if you look at the bottom of the screen and you see GHIN, you see InnovatorMD, you see Summit, what do those emanate, or what comes to mind when you look at that? Well, the market differentiator of what we're all creating here is this is a clinician funded, founded, and driven environment, okay? It's the clinicians taking back healthcare and returning ourselves to the clinicians, guardians of healthcare. And the only people that can do it are the clinicians, really. Of course, we need the help of the employers, and we need the insurers, and we need all of that. But at the end of the day, we're the ones who have to drive this. And that's what we're creating with Global Health Impact Network. And I have to tell you, I'm honored to have individuals like Chris and Doug and Brittany and Harjat working with us as part of this network, building this. And at the end of the day, the message to all of you listening to this is that as clinicians, you need to be part of this. You need to actively get engaged. You need to join the network, join the communities, get involved. We're democratizing the investment process through the fund, but it's a small part of it. But we want you to be advisors, consultants, active participants in our future, because without it, we're going to end up with EHR 2.0. And I don't think anyone wants to go in that direction moving forward. And then the other thing that we are working on, we haven't forgotten about the patients. This group is actively looking at working on building the patient side of this network to connect those clinicians to the patients, not just in episodic care, but in complete care, involving preventative, involving episodic, involving chronic care management, and just in general, how do employers take care of the employees that work for them and provide them with the resources, both technologically and face-to-face in a hybrid model, to improve the healthcare delivery system moving forward. So again, I thank all of you. We're about 3 minutes over. I would encourage everyone listening to jump on the network. You'll have access to all of these incredible knowledge leaders that have been, on a lot of our talks today, and get involved. So thank you, everyone.
Thank you.
Thanks, everybody.
Thank you. Thank you.
Right, so up next we have Ella Lee, who is the CEO for ZGC Capital, as well as the founder for MedLabs. Ella, it's a pleasure to have you here.
Thank you so much for the invitation, Martin. Hello, everyone. My name is Ella Lee, and I'm the CEO of ZGC Capital and a partner of our US fund in charge of ZGC's investment and incubator operation. The company-wise, we have two innovation centers. One is where we're located in Silicon Valley, and the other is in Boston. Both with around 70 to 80,000 square feet building. Investment-wise, we have a quite comprehensive fund system, including one fund of fund with portfolio funds, including Manlo, KPCB, Andreessen, Excel, and the Foundation. And we also have several VC funds that target at portfolios from seed to B round stage. Starting from this year, we're also expanding into healthcare sector and are launching MyLabs Accelerator. This is a ZGC's first healthcare-focused accelerator program run together with our funding partner, GHIN. We're going to talk about more detail later in the next section. Myself is a PhD trained scientist turned venture capitalist, and I have more than 10 years experience in biotech research sector. I have strong interest in therapeutic investment opportunities from drug discovery to commercialization stage, and also look at the deals from medtech and medical device sectors. So if you are raising money, and especially if you are in the A round to B round stage, please just let me know.
Fantastic. And right now we're going to talk about precision medicine. So can you tell us what is precision medicine?
So it's an advanced technology that uses big data to achieve a precise and customized treatment for individual patient who has a very different genetical background, lifestyle, living environment, and also medical history. So compared to traditional treatment that has one size fits all solution, precision medicine provides a tailored method to target a large and also diverse population. Very often, there's a lot of side effects. Side effects caused by wrong medical treatment can account for around 30% of acute hospital admissions, study shows. And the application of precision medicine can decrease significantly the number of hospital admissions caused by side effects. In the field of oncology, precision medicine has been also increasingly used to test breast cancer. And also by conducting blood tests, scientists and also researchers can now find cancer by sequencing blood and also locating tumor DNA sample. And also with precision medicine, doctors will not only be able to see better responses and also less effects of the treatment, but also they can now have a better picture of whether patient is responding to treatment or what they see is just in remission.
Okay, so with oncology being the major application of precision medicine, what about non-oncology therapeutic space?
Yeah, so oncology is definitely the major application focus of precision medicine. Currently in oncology field, around 35% of FDA approved drug are precision medicine, and most precision-based medicines that have been submitted to and approved by FDA now are for the treatment of cancer. So compared to the second highest application, precision medicine has been used 30% more often in oncology field. compared to the second highest application field. Meanwhile, there are also signals that the focus of precision medicine is rapidly expanding beyond oncology and towards non-oncology area. After all, 2/3 of phase 3 clinical trials are focused on non-oncology area. So example of areas include infectious disease, central nervous system disease, and cardiovascular disease. For instance, right now, 30 million people with type 2 diabetes get the same diagnosis and the treatment, but the growth of precision medicine is providing great opportunities that can provide individualized treatment and also can recalibrate the current treatment for those patients. Precision medicine is also important in neurological disease. Examples are Alzheimer's disease and also Parkinson's disease. Both of them has a very strong genetic correlation with the incidence of this disease. For instance, studies have shown and also identify around 19 genes and also 25 proteins that play important roles in the development of depression, which are therefore the perfect disease target for precision medicine.
Okay, so what regions or countries are leading the precision medicine market?
Yeah, so currently, despite of all this setback in life science research and healthcare industry caused by the outbreak of this COVID-19 or COVID-19 pandemic, United States can still be counted or still the leader in the precision medicine industry. And this trend will likely continue in future years. So in 2015, United States created a program called a Precision Medicine Initiative, is also called a PMI program. And the aim of the program was to power or strengthen the individual diagnosis and also treatment. There are two components in the program. One is to expand the precision medicine in the area of cancer research as a short-term goal. And a long-term goal is to expand the research to all areas of healthcare. So the second component of the program is to create a large research cohort with at least 1 million participants across the country. These participants can provide and also share many types of data, such as about medical behavior and lifestyle data and information. The program has teamed up with the Department of VA and FDA for this purpose, which puts the United States in the leading position in the precision medicine industry around the world. In addition to United States, Western Europe is the other major region for precision medicine research, especially in oncology application. The support from state funding has also played a very important role to accelerate the market growth. Asia, meanwhile, also has a big potential, especially when the cost of the precision medicine technology can jump further in future.
Okay, so why technology development and advances like genomic sequencing? Like, how can they help with development of precision medicine?
Yeah, so next generation sequencing or also NGS test, for instance. So this is one of the most common tools to quickly sequence and identify patients' genome. By analyzing for mutations and also variants, it can tell medical professionals what are the best treatment options for specific patients. Most commonly used genomic sequencing in precision medicine therapies can cost over $5,000, and advanced technology can help further lower the cost for this genomic sequencing, therefore leading to a wider adoption of precision medicine moving forward. And in the past, more funding are shifted from research application to clinical application, which allow the researchers to gather a large pool of human data in shorter time. Meanwhile, companies that work with big data, such as IBM, are also gaining more information on, for instance, how gene or genetic and chronic disease function. So this can help further the application of precision medicine in the non-oncology field. Another point worth mentioning is that the wider adoption of precision medicine is also accompanied by the better acceptance of data sharing and the tracking by public. For instance, if we look at the use of fitness tracking device and also watches, they have become more and more popular in recent years. People want to participate more nowadays in the healthcare decision-making process, and therefore the advances in precision medicine could allow them to achieve this goal.
Yeah, so for any startup that wants to have a better understanding or jump into the field, is this a competitive market for precision medicine?
Yeah, so the current market for precision medicine, you can say this neither too crowded nor being dominated by only a few major companies. There are some major companies right now in the market holding big shares, such as Medtronic, Pfizer, Novartis, Cahana, and Teva. But mid-size and smaller companies are also playing important roles. Generally speaking, there are two types of companies help drive the development of precision medicine. One is the data-driven medical research companies powered by AI and also machine learning. They take healthcare data side from patients and also conduct analysis to determine what are the best treatment options for the individual patients. And the other type is the medical testing and also analysis companies. They use genomic sequencing to examine big data set of medical records and also trials from patients. So it's good to have all this company in the market, and also it's good for the advances of precision medicine, because such a greater organized and also competitive environment is more likely to generate lower cost solutions for the space.
Okay, so what are some of the ethical challenges of precision medicine?
This is a great question. So many patients have right now disease diagnosis and also treatment by genetic testing or precision medicine method. But many of those who are discovered to be at a high or higher risk of certain disease very often find themselves vulnerable to discrimination. We call this genetic discrimination. For instance, employers can choose to hire those who they think healthier. They call them, like we're called a healthier talents quote. And the insurance company can also using this data to reject applications from the different individuals based on their genetic profile. But also meanwhile, there are also more voice calling to limit those entities' access to those genetic testing information in order to stop this genetic discrimination. There is also increasing debate whether doctors should communicate with patients for conditions or disease for which there's no known treatment available. Practitioners or doctors should consider, in this case, not only whether patients' healthcare expense will be increased, but also the psychological impact on patients when they have diagnosis results to find a higher risk of to develop certain disease. So they need to decide whether it's truly wise to tell somebody they have an increased chance to develop certain disease when truly nothing can be done. And the issue should be addressed, but yet the solution hasn't really been there yet. So one last concern in precision medicine about this ethical issue is the data safety and also privacy. Questions has been more frequently raised regarding who owns the genetic data, whether the data should belong to the healthcare professionals or individuals. And one possible solution is to use blockchain. Blockchain, the benefit or the advantage is that it does not reveal personal information about the patients, but meanwhile can also grant the patients full control of their own data and usage. So the ethical challenges right now get more attention from the professionals, and we all hope regulation could also relevant regulation could also come out to help solve these issues in at early as possible.
Perfect. Well, thank you so much for talking with me about precision medicine. What I want to do now is I want to bring Dr. Gary Goldman on, and I want to talk about the MedLabs Accelerator, because this for me is very exciting stuff, what we're doing. So, Gary, welcome.
Test. Testing 1, 2, 3, 4. Nothing yet.
Test. Oh, maybe I can hear it. Which is good. I think we're there. Can we hear Sandra? Can she test?
Hello. Hello. Hi. Testing 1, 2, 3.
Hello, Sandra.
Hey, Sandra. But we have
Hi.
to hear you. So.
Can you hear me?
Oh,
hello,
we're just
hello.
testing right now. I see. Testing 1, 2, 3, 4. Oh, because then what's going on the computer? Oh, here we go. Yeah, this is the StreamYard. That's the StreamYard stream. I mean, what do you want to see here? Should we just show YouTube? Here we go. Well, it doesn't. That's it. Okay, I think we should be good. Testing 1, 2, 3, 4.
Test.
Testing. Hello.
So can we hear Sandy? Can we test you just so we can hear you?
Hello, testing 1, 2, 3.
There we go. Now we hear you.
Hello, testing 1, 2,
Can you
3.
hear us, Sandy?
Yes.
Sandy, can you hear us? Testing 1, 2, 3, 4. Can you hear us?
Test.
Yes, I can.
Perfect. All right.
So should we start? Okay, great. Hello, everyone. Good afternoon. Thank you so much for joining today's Accelerator talk and also GHIN Summit. My name is Ella. My name is Ella Lee. Should I continue?
There's a delay. Yeah. There's a bit of a delay.
So we'll just continue. My name is Ella Lee. I'm the CEO of GHC Capital and also partner of our US fund. Today is really a pleasure to share the stage with Dr. Gary Goldman, founder and the CEO of GHIN. And also we have Ms. Sandy Miller on the other side of the stage. She is the CEO of Runaway Innovation Hub. So Gary and Sandy, it's a really a pleasure to be here together with you. So first, can you please give us a really brief introduction, who you are and also what you do? Gary, do you want to start?
Sure, I'll start. And just Sandy, just so you know, there's a bit of a delay, so we'll wait a minute before you start. So, God, there's an echo. Hold on 1 second. So how do we fix that? So is there any way to fix it? Yeah. Okay. So there's a delay. We'll just have to ignore it on our end. So yes, my name is Gary Goldman. You've been listening to me all day, probably on and off. I'm the CEO for Global Health Impact Network and founder, and I'm also the founder of Global Health Impact Fund. And we are sponsoring and putting on this day's conference in partnership with InnovatorMD and their 4-day conference that's coming up. So I want to thank everybody for being here. I want to thank Sandra for being here and Ella for being here to talk about accelerators. So just a little introduction is our network is a clinician-driven, funded, and founded network focused on innovation and entrepreneurism in healthcare. And we have just started an accelerator in partnership with ZGC, where Ella is the CEO. And we've also recruited the expertise of Sandra Miller from Runway. And today we're going to just talk a little bit about accelerators and our MedLabs accelerator.
Thank you, Gary. Sandy, do you want to go next?
Sure. So Runway, we're located in San Francisco, and we think of ourselves as an innovation company accelerating the success of global innovators and entrepreneurs. By global innovators, I mean corporates. We mostly focus on tech companies from many different industries. My background, I've really worked with technology-based startups for the majority of my career, or corporates. And I co-founded the Stanford Biodesign Program, which is now actually in September going to celebrate 20 years. The Stanford Biodesign Program teaches a methodology for biomedical technology innovation and invention, and starting from a blank sheet of paper. And so that program has served to be the model for many programs around the world are based on that Stanford biodesign methodology and the Stanford program itself. So those are sort of the headlines. And in doing that, I also was able to work with some of the most innovative and entrepreneurial cardiologists earlier on in my career. That sort of led me to biodesign and so forth. I have run, designed, led a variety of startup accelerators at different stages with different objectives. And so some of those have certainly been in healthcare. They've been in the basic sciences and in other sectors as well. So we're going to talk in this session about accelerators. So that context is kind of important.
Great. Thank you, Sandy. So, if I may also give also an introduction of the MedLabs Accelerator,
Yes.
since Sandy is also expert, also running the Innovation Center and also Accelerator program, we would like to also hear your insight about that. MyLabs Accelerator actually is ZGC's first healthcare-focused accelerator program. We are very excited to run this together with our founding partner, GHIN. So each program or each cohort lasts around 3 months time, and the first cohort will start late this month. We're focusing in the sector of biotech, medtech, and also medical device. And the stage is from seed to pre-A stage. So for each cohort, we are admitting around 8 to 10 companies. And at the end of each cohort, we're investing around $100,000 to one of the 8 or 10 companies by our fund partner, GHIF. We're focusing so the partnership between GHIN and also ZGC make our accelerator so and also outstanding, different from others in the area. So we have really 2 strong focus and also features. One is our China focus, and the other is our clinical component. So for the Chinese side, we ZGC Capital, our parent company ZGC Group is the largest science park in China that manages 27 science park located in 20 cities in China.
check. Testing 1, 2.
Hi, Sandra. Sorry about that. We're just having a bit of technical issue with the audio feedback there. So, what is your connection to Gary, the network, and ZGC? Your startup story.
Testing.
Oh, we've got you on mute there. Sorry.
Check. Testing house. Testing 1, 2, 1, 2. Testing 1, 2, 1, 2, 1, 2, 2, 2, 2, 2. Check.
Hi, Sandra. Sorry, but you're on mute.
Check.
You can. There we go. We've got.
Can you hear me?
Yes, I hear you now. So thank you. So my name's Nicholas. I'm working here on the back end. We're trying to work on the audio issues from the studio there. Yeah, if you wanted to just take a moment and let us know about your startup experience and what you're working on these days.
I'm sorry. Are you interviewing me for a recording or?
Oh no, I'm just I just wanted to jump on while we're working on the back end and see if we can shine the spotlight on you.
Okay. Yeah, just let me know when you're ready.
We are live. The show must go on here. We're working. Looks like we've got a couple of other people joining us, so I can bring them on. And if you wanted to reintroduce yourself just for a moment, because we didn't get a clear shot.
Okay, sorry, I wasn't sure what was going on. So Gary and Ella are joining?
Yeah, they're in the studio now. We're just working on getting the audio loop so that they can also hear you at the same time.
Okay. So they haven't been able to hear me yet.
They could hear you. The problem was that their audio was coming through YouTube a moment later, and that was causing an echo. And in trying to mute that or resolve that, we're trying everything we can. But we have a couple other guests on here. It would be great if we could get Gary back up on stage or Gary individually. That may be the best way to go.
Okay. Well, if this is something where you need to scrap my participation so that things can continue, that's
No worries, Sandra. No. You're on stage now. We've got you live. So
okay.
Yeah, could you
sure
do a story and let us know a little bit about yourself?
Sure. So I'm CEO of Runway Innovation Hub. We are in San Francisco, and we think of ourselves as an innovation company that accelerates the success of global innovators, think big corporates, and as well as entrepreneurs. We tend to focus on tech startups. We help global enterprises through results-focused innovation consulting, and we really power the growth of startups through acceleration programs, mentorship, and flexible workspace services. We do have a space in San Francisco where we have a lot of great startups. My background as it relates to healthcare is that I co-founded something called the Stanford Biodesign Program, which teaches a methodology for biomedical technology and innovation. And that program is the model for now. There are more than 30 programs that around the world that model themselves after Stanford Biodesign. And so I have deep experience in working with startups, primarily medical device, but other areas of healthcare as well, certainly. From, starting, how do you go from a blank sheet of paper and develop something that you can actually get a patent on and get approval for, regulatory approval? How do you approach reimbursement? The whole thing. And it's really focused on sort of a clinical needs-based approach to that activity. So in addition to that, I've been on the investor side at the sort of seed and A level with a group that was called the Angels Forum, very successful. And actually, they really had a lot of medical device investments. And have also worked with and seen sort of that medical device invention process many, many times, from sort of the light bulb often going off in the doctor's head, sometimes the engineer's head, to all seeing that process all the way through from, prototyping, first animal studies, first clinical studies, and then all the way through to exits. And so I've really gotten a lot of exposure about how to navigate all stages of that activity. And then we're going to be talking about accelerators in this particular section. And so I have designed and led several different types of accelerator programs over the years, certainly some in healthcare, basic sciences, but also programs focused in other areas. So that's a little bit of background about me.
Thank you, Sandra. Thank you. Okay. So is there a greater collaboration that you see happening outside of just one hospital or one city in your organization?
In terms of, is that happening with startups engaging sort of at a healthcare system level? Is that where you're going?
Yeah, I guess, the new ideas, they may not come from the expected sources. So I'm just wondering how the internet and the opportunities to collaborate will help you grow, and what type of people you're looking to connect with.
Yeah. I think that my expectation is that a lot of the people in the audience are both healthcare entrepreneurs and people who work with early stage healthcare companies and advise them in some fashion. And I think that there's actually one of the things that in some ways is a discipline, if you will, that's built in on the healthcare side versus working with startups in other areas, is at the end of the day, you're focused on, making patient care better in some fashion. And the other factors that are coming into play these days in our current, regulatory and even market environment in healthcare are sort of the term faster, better, and even and sometimes cheaper. And sometimes one of the toughest parts, I think, of that is when a startup is helping with prevention, because that's not something our healthcare system has sort of paid for in the past, even though it's the right thing to do. So that's a particularly challenging thing. But I think the ability to demonstrate benefits to the patient
There we
and improving patient care are really helpful. There they are. Hey guys.
We went back to old school.
I
Now
love
we're
it.
just on 2 different laptops, and we got rid of all this expensive equipment, and it's working.
It's a still
Sorry
fancy,
about that.
It's a still fancy stage.
This is what our original plan was.
Okay.
Okay.
I am so sorry about this.
No, it's okay. You know what? You did a great job filling in there with Nicholas. I love it.
Okay, good. As
all
long
right.
as you approve.
Oh, it's fine. It's fine.
Okay. Great.
So
So we heard about MedLabs and how awesome MedLabs is. Do we need to, because of the audio issues, do we need to hear more about MedLabs, or are we good?
So should I just like say this again? What I talk about, I don't know why the audience heard by part or not.
I would just start from scratch about MedLabs itself, and then I'll chime in because they heard from Sandy already a little bit. So.
Okay, about the Chinese component, have they?
Yeah. No, they haven't.
I haven't heard anything. Okay, so I can just like give also another like a talk about also quickly about this MyLabs Accelerator. So basically, this accelerator is our CGC's first healthcare focused accelerator program, and we're partnering with Gary with the GHIN. And this program, the setup is each cohort around 3 months long, and the first cohort is starting late this month. And we're focusing on biotech, the sectors of biotech, medtech, and also medical device. The stage is from seed to pre-A. And each cohort, we are meeting around 8 to 10 portfolio companies. And at the end of each cohort, we are investing $100,000 to one of the 8 or 10 portfolio companies in the program, thanks to our fund partner, GHIF. So this is like a general setup of the program. And now I want to talk about why MyLabs is different from other program in the area and what make us standing out. So it has like really 2 different important differentiator. One is a strong China focus, and the second one is a strong clinical focus or component. So first about this Chinese side is about our Chinese connection. So our parent company, ZGC Group, is the largest science park operator in China. And it manages 27 science park that is located in 20 cities. It has around 135 public companies, including the big tech giants such as Baidu, Microsoft, IBM, and also Tencent. And more than 40% of Chinese unicorn have risen from our park. And then according to a report issued in 2019, altogether the tech companies in our park contributed to more than 35% of Beijing's GDP. So we can definitely provide a lot of great resources for those who want to set their footprint in China. And so this is the Chinese resource side. And in the program, we are providing actually 2 weeks long courses in the program under the theme of Link to China. So we are providing one-on-one meeting and also workshop, helping those who are interested to enter Chinese market and give them some advice, for instance, on patent protection and also commercialization stage, which are the most interesting, the topic interests most of the startup who doesn't really know China so well. And in addition to that, we are also organizing 10 days business trip, taking the portfolio company or who want to also enter Chinese market to China. And usually we choose several cities to tour and connect them with a local investor, policymakers, and also industry leaders. And we have done this before in a couple of times.
and all the expenses and the cost can be covered by us. But of course, this year, because of the COVID-19, we're not doing this activity. And one thing I forgot to mention is also the funding opportunities. So in the China side, we have actually our parent company has participated around 146 funds. And in the US side, we also have a pretty comprehensive fund system that covers investment opportunities from seed round to B round. So this is about the China's focus. And the second really big differentiator of our program, and which is really important asset, is our clinical focus. So one example is now we have more than actually 70 mentors for the program, and more than 60% of them are the clinical entrepreneurs. Thanks to GHIN. So I believe, Gary, you also want to also comment more on that part.
Yeah, thanks, Ella. So, from our perspective, having spent the last, 2 years building this global impact network that is clinician driven, between our fund and our network, it's funded, founded, managed by clinicians. This was a natural next step for us in terms of our network, because we have built an ecosystem of communities around innovation in healthcare, supporting it by bringing in the appropriate knowledge leaders, subject matter experts, access to those clinicians to drive this evolving digital health revolution. But from a fund perspective, yes, we also have been we're a small fund, all clinician funded, and investing in companies, and we feel that we have the ability to identify those very early stage health innovation companies because of the clinical input that we get, avoiding those Theranos kind of investments, right? So by starting at very early stages with us and joining our network, they have these organizations, whether they're clinician founded or whether they're not, have the access to our network of clinicians. And then by partnering with ZGC, we do have global at the beginning of our name, and that was our intention from day one, is healthcare, especially post-pandemic, but certainly pre-pandemic as well. One of the things that digital health accomplishes is it allows us to take excellent care and provide it in the most remote places of the world, leveraging technology. So when we have a partner like ZGC, who has a global position global position in general, and now wanting to get into that healthcare sector, the two together create what I think is a market disruptive partnership for these companies, because now we can come in, we can help accelerate the companies, but we can do it also on a global level. It's one thing to take a company and accelerate it and get local or regional or domestic funding, but it's another thing to take that company and give it global exposure through ZGC's innovation hubs, partnering with organizations like Runway and Sandy. And if you put that all together, then all of a sudden we are really making a global footprint as a partnership moving forward. This is our inaugural accelerator. We're building it as we go, but because we have all the resources that we do, we believe that we will, kind of test the waters with the 8 companies that are in this particular cohort, with the idea of then continuing that either on a quarterly or a semi-annual basis, bringing in cohorts and expanding the model. So, Ella, thank you for, certainly the opportunity for this. And, the first person that we reached out to was Sandy, because Sandy actually has a great reputation in terms of being an accelerator consultant. And we're very excited to bring her into this fold as we move forward. And that's why I felt it was great to have the 3 of us on a call to kind of just talk a bit about accelerators in healthcare, now that we have an idea about what we're doing with MedLabs. So Sandy, I'd love to hear some more from you.
Yeah, one question I think, if I just imagine for folks listening to this, that Ella, if you could just speak a little bit more specifically around, what's for a healthcare company, healthcare startup that has the opportunity to take advantage of all of these resources and relationships in China. Are there particular areas of healthcare where there's greater interest, where these types of companies or companies working on these types of problems in healthcare might have a better opportunity? Or is it, hey, we have great resources for manufacturing, or what? Help us understand just a little bit more specifically what the opportunities are and what the interest is for companies who might be in this program, and maybe some of the future cohorts.
Yeah. Yeah, this is a great question. In Chinese side, actually, I think what we can really help most is around the two area. One is about two type of companies. One is a medical device company, and also the other one is a MedLabs. I keep saying MedLabs, med tech company that really have a huge need for market and also commercialization need. And this is what China are good at. We have like a big population, for instance, one of our partner in China, first of all, two of our healthcare focused science park, they are very specialized to helping. One is focusing on the medical device, and the other is focusing on the biotech, and they have some special organization and also resources to help the company to understand and also to apply for the CFDA. First, you need to understand how the whole healthcare system is in China, and also in order to get really to start, you need to have the approval from different level. So you need as for instance, like outsider, you do not really expect yourself to start from scratch yourself. You need to find a local partner, sometimes via an agent, or sometimes from some accelerator or incubator from China. So one of our partner, for instance, their founder is the previous members from the CFDA, the retired member from CFDA. So from that side, they can give a lot of very valuable opinion. And also, meanwhile, a lot of times, this is also similar to United States. You need to first, before you submit your file to the committee, you need to first understand whether that meets a certain criteria. And a lot of times, you want the insight from the hospital professionals, from the doctors. And therefore, you need some people to help you to do that. And we do also have such different organizations can help. So this is like in China side, and also in United States, for instance. This is also I see the value of GHIN. A lot of times, for especially a lot of digital medicine companies, we're also including medical device companies. They are working really hard to make the product work, get a patent, and also they get a really great technology. We call this like a hard technology, and also get a lot of money from this investor who are really fascinated by this fancy tech. And then it just fail. It's not really because it doesn't work. It does work. It can definitely really help all these medical problems. But the issue is the healthcare industry is very, very different from other sectors, and it's more conservative in many, many ways to convince doctors to really adopt their product, which even though it can, let's say, if it can really help, for instance, increase efficiency or also solve a lot of issues. But because of, for instance, really the difficulty to adapt the technology or many other layers of the issues, physicians just say, no, I'm not going to just take it. That's become the issue. So one thing about this accelerator program is that before you really go to that step yet, you have the chance talking with doctors
that behind them, there are all this like hospital resources, and also they are specialized in many different areas. You get a chance to talk with the physicians, get their first line opinion or feedback. What do you think? And do you think this is going to work? So this is very important.
And I think, I'm just chime in real quick, Sandy, is, we've had practical experience with that. Here we were, from my standpoint, I was a serial entrepreneur practicing medicine, had zero experience with venture capital, other than the fact that I'd never raised a penny from a VC prior to this with all my companies, but what I'd heard. And then we started the venture capital fund. We have a small cap, $10 million venture capital fund, but it was so educational to experience that, because through the due diligence process of looking at our funnel, I would bring in the targeted clinicians for that, that type of company. I'll give you a perfect example right here in Silicon Valley is an investment we made, Plethy, okay, which is an orthopedic surgery, physical therapy solution that had developed a device, a sensor, which could monitor range of motion, force of motion, could be used post-operatively from orthopedic surgery. It could be used for any kind of musculoskeletal condition. And a great concept in itself, but there weren't any clinicians on the team. And when we started looking at it, I brought in like 4 or 5 orthopedic surgeons, a bunch of physical therapists, some chiropractors. And I could almost predict as a clinician how the first meeting was going to go, because we had already done quite a bit of due diligence. And, when you look at a digital health company that has to integrate into an electronic healthcare record, has to integrate into the workflow of the clinicians who are seeing 30 patients a day using an EHR that they really don't want to be using to begin with, and then adding in a sensor now that's delivering them data which they've never used before. And again, we're not talking about critical care doctors, we're talking about orthopedic surgeons. And it was predictable that they got on the call, and the feedback that they gave to the CEO of that company early on was so valuable as part of the due diligence process that we initially were not going to make the investment, and then we ultimately did because of taking the feedback that we gave them. They were able to, basically pivot a bit on their platform. So that's the real value of, and that's when it became grossly apparent to me that from an accelerator standpoint, getting that feedback very early on, as opposed to later when you've spent now $4 million on a product and it's not marketable because the clinicians will say, I'm not going to use this. That's where the real value is. And that's why I think from an accelerator standpoint, getting that feedback very early on is integral to a successful investment.
Yeah,
absolutely. And I think the road is paved with many failed startups that really struggled to get that physician adoption feedback. So that's one of the things that you all have put together with MedLabs. And not only do they get it from the GHIN physician clinical mentors, but they also get it from the China medical community and all the the different players in the healthcare system in China as well. And getting that connection is really important. So that's a terrific differentiation. I think that Ella, you had some questions for me on accelerators that maybe we should shift to in the interest of time. Mm-hmm. So I think you had asked me about what startups should expect from joining an accelerator.
Exactly. Since you're also a really experienced and also expert in the sector, I think it's also very valuable for you to share also from your insight as a startup. What do they really expect to get from joining accelerator, and also whether the standard is, hey, I want to look at some ranking to choose the #1 best accelerator in the area. Is that really to choose the best accelerator, or should they choose the right accelerator? So love to also hear your insight.
Sure, great question. So my sort of feeling about the purpose of a startup accelerator is, and how, if you're running an accelerator program, how you evaluate yourself is that The startups that you select that are in your cohort for your accelerator program, the work that you do with them and how you guide them and the support and mentoring that you put around them, ultimately the goal is to increase their ability to get their next funding. Now, so that's a general statement. There are variations of accelerators. There are accelerators at different stages. So one of those variations, for example, could be a later stage startup where they may have paying customers and users, but they've just started to do that, particularly like if it's a B2B business model where maybe they're okay near term on funding, but they need help in getting enterprise customers or corporate customers for their company, and getting new, whether it's a hospital system, for example, or an healthcare insurance provider, to get those sorts of customers. So again, it depends on the flavor and the stage of the particular accelerator. But at the end of the day, it's that increasing the potential and ability for that startup to get their next funding and to continue to sort of, or whatever that next critical milestone might be for to continue to build value and reduce risk for that startup.
Right. I think the only thing I'll chime into also, which again, I believe market differentiates what we're creating here, is that most accelerators are, to coin a term, one and done. So they get you to that point, they run you through, and then it's like, you're on your own now. Good luck. You've graduated the accelerator, you've got the diploma, but now you got to go out and get a job, right? So you got to go out and raise the capital, and you have to be able to go out and take that capital and, as you say, use it effectively. What our plan is here with this accelerator is it's just the beginning, okay? The idea is we're creating this ecosystem where now that the accelerator's done, what we're going to do is plug these companies into Global Health Impact Network, give them their own community, give them exposure to the network, promote them in the network, give them access to resources within our network, with InnovatorMD, with our partners, in a way where we don't say goodbye at the end. We're just starting to say hello, because if we've done our due diligence and accepted them into the accelerator, we believe they have the chance to have an earlier exit in commercialization, leveraging our network. So I think that's a very important marketing point for us as a group.
It really is, and I think a lot of startups don't realize that the majority of accelerator programs, once you're done with that particular program, there's not a lot of support as an alumnus of that accelerator program. And with healthcare companies, as we know, they take a little bit longer. And so you do need that longer term relationship, and to have a way, and like you spoke to, Gary, a community. And I think to be able, a company may not be ready to really have a serious conversation with to explore opportunities in China by the end of the first 90 days. But my guess is that they probably, within maybe 3 to 9 months after the program, they still could have the opportunity to circle back and say, okay, we reached this milestone, we've proved this, and we sort of have more, it makes more sense now to engage in this. And I imagine they'll be able to do that. So I'm sorry to interrupt, Ella. Go ahead.
I just want to say one other thing, and one other part that I didn't mention is that beyond the acceleration and leveraging the ecosystem of the network, let's not forget that we're Global Health Impact Network and Fund, right? And we have a finance and investment part of our network. So we will work with those companies moving forward in terms of getting access to not just money, but strategic money, because our members are investors through syndicated investment vehicles. Our members are investors in our venture fund, and our members want to participate as active advisors and consultants moving forward as investors with these companies. So all of a sudden you're plugged into this network, and you're not just getting the resources, but you're also getting the funding strategically from those resources.
Yeah, I'll just add one more thing. That's why we're always very, very cautious regarding how we can really help the company, or whether we can help the company. So actually, always one question during our interview to all these companies, always, what do you really expect to gather from our accelerator? And we will also make our decision whether we want to include this company based on how much we can really help them. And each company, of course, they all have very, very different need. A lot of them want to find, for instance, want to make a team. They have a really strong relief, for instance, for the biotech company. This is very often you see they have a great, scientific team. However, they really have no idea how to really commercialize this tech into a real product. And some of them just really want to also get some connection with, for instance, some manufacturer or some like big corporate. And some of them just want to also find hospital resources. And some of them want this funding support. So we always really just also weigh that as a really important part. If we don't really think we're eligible, if we don't think we can help, then we will just tell them, hey, at this stage, we don't think we are really the best one for you. So we do really value this a lot. Yeah. So Sandra, actually, I do have another question for you. So we discussed about, for instance, from startups' perspective, how do they really choose the right accelerator, and also what do they really expect from us? So I would like to also hear your insight from a different angle. Let's say, as an accelerator, how do you make yourself very unique? And also differentiate yourself from others, and also to be able to attract really the best startup company. So would like to hear your thought about it.
Sure. So from the startup perspective, and in approaching how to choose the right accelerator, I think that you have to be really clear about your motivations and your ability and willingness to engage in the accelerator program. Because we all know that, running and building a startup, it takes tons of energy and time. So I've actually had an accelerator program where I had to kick somebody out because they literally, there were some basic requirements for participation, and they just felt like they could, dip in and take what they wanted and then leave. And it's just like, no, that's not what we're doing here. And we didn't, we really cared a lot about, that longer term relationship. And we just felt like they weren't going to be a good representative going forward. So I think it's important to be clear about what you want out of that accelerator experience. And, I think you should expect, one of the most important things is the access to mentors, and if you're looking for connections to investors or potential customers for your business, be very clear about what your expectations are, and I think understand how those things will happen. But I think, again, sort of knowing why you're doing this, because, you can also choose not to do it, and do it and build your company without an accelerator. A lot of people do that. But, startups need a lot of help throughout their life. So you're probably in better shape if you do find a good accelerator for you. I think that, in some ways, the thing that you were speaking to in terms of from an accelerator perspective, to sort of how to succeed and be competitive in the market. Number one, I think your ability to support your startups and be able to tell the story of how the ways that your accelerator has provided differentiated value. I mean, just like we want startups to do, right, and get testimonials, I think it's important to get testimonials from the entrepreneurs themselves, because that really makes the case better than almost anything. And I do think that being very clear about your differentiation, which MedLabs certainly is, has a very specific areas of differentiation that are being brought together with this partnership. I think that is for any accelerator, your ability to articulate your differentiation and the value that you bring is one of the most critical things. That plus, being able to over time speak to a track record is really helpful. And I think that it's not, a lot of the high quality accelerators that are out there. One of the things that some don't do a very good job of, which with the impact network that address, is that building that community beyond, because a 3-month program is just 90 days, right? And so your company may not, may need resources, beyond that program, right? And so you'd want to still be able to tap into those resources. I think the other thing, another area just to identify, and it's something that Ella and Gary, you both have spoken to. So, and I'm sure you both get this as well. One of the things, a lot of startups who go through some of the big name accelerators, they go through those programs. They've given up 6-7% equity. They've gotten funding and so forth. And those are very good quality programs. But a lot of those companies still need help raising funding. Mm-hmm. Despite everything that they're already part of, they already went through, they still need a lot of help. And so the ability to be connected to various, a whole mix of different networks and relationships that are being brought to bear with this partnership with MedLabs, that's very powerful, and that is differentiated. And again, thinking beyond just the program is really important for a startup. And so, I think the good news is that I know the startups will hold you accountable, and you'll want that, right? Because that way everyone's successful. MedLabs is incentivized for all of these startups to be successful, and I know you'll make that happen. You'll help to make that happen.
Exactly, and I also totally agree with you. So in let's say Bay Area, we do have also a lot of accelerator program out there, and each program or accelerator have their different unique style. So MyLabs, we have a very, very strong and also clear focus. One is this clinical focus, the other is a China focus. And actually, two founders, Gary and I, also have a very relevant background. So Gary, he is an anesthesiologist turned entrepreneur, serial entrepreneur, and myself is a PhD trained scientist turned venture capitalist. So we all have like interest in all this vertical, but also I'm more interested in biotech, but also I look at the deals in medtech and also medical device. And also Gary is fascinated to all this like med tech, digital tech companies, a set of in addition to medical device and also biotech. So this is also make our program very different from others out there.
Right, and I also think, from my standpoint, from a serial entrepreneur, it's really interesting having done it before, and then working with a lot of the clinicians that we work with who are innovators who really have not done this before. You bring up a very valid point. It's not like you just go out there and throw a pitch deck together and raise money. It's just, especially now, it's very, very, very difficult. And from a mentor perspective, what I try to impart, through an accelerator or just as a mentor to a new startup, is that the single
most distracting thing that a CEO and a management team has to do that doesn't benefit development of their product is going out and raising money. And for the number of times that you have to go out and pitch to get that dollar is not insignificant because it is distracting. And a lot of times the entrepreneurs will look at the accelerator a bit in a way like that. Well, I got to raise money and I got to get my tech platform and I got to build a management team and I got to do all those things. And absolutely, but that's why we're here. We're here to help you do that and guide you to try to avoid or make as few mistakes as possible. We all make mistakes, of course. But that's the real value of the accelerator. And if you can add to that, as you point out, making those introductions in a way where, wow, you've gone through this network, which is the good housekeeping seal of approval by clinicians that we think this is a good idea and we would use this, it makes it a lot easier to raise that capital, having that behind you. And that's why I really, truly believe this is a market differentiated model.
Perfect. I think probably time is up.
We have some startups, right?
We do actually. Yeah, we're gonna have two companies, right? Two of our portfolio companies pitching, followed up after this section. So it's really fun actually today chatting with Sandy, also Gary, to share also a lot of great insight. And also I hope our audience find this also helpful and also valuable as well.
And I'll throw out there, even with I haven't really discussed this with Sandy much, but, as part of the whole network concept, we create communities around this entire ecosystem of innovation. So what we are creating is a community around accelerators, not just our accelerator, but the concept of accelerators. And I'm looking to partner with other accelerators as well. And, this group right here are at least the beginnings of a group of knowledge leaders in this area. And I encourage everyone on this call in this meeting at Uli's InnovatorMD conference, if you want to learn more about accelerators, the story doesn't stop here. That's the whole idea of the network, is that come to the community, join the network, get involved in the community. You can pose questions to these knowledge leaders there and continue the conversation. So
one question. I know you're wrapping up, but one question just to respond to in the chat. Someone asked, how much equity will MedLab Accelerator take?
Great question. So do you want to take this? Should I take this?
You can take it.
Yeah. So, every accelerator has to have something to kind of keep it running. So pretty standard is a 1 to 2% equity stake, because our accelerator is all over the map. We have very, very early companies, but we also do have some later stage companies. We've kind of capped it with the idea, as being entrepreneurs ourselves, we're not looking to take a huge amount of equity to make you successful, but it is important for the network and for ZGC. So the number is 2% with a cap on it, so that if you are a later stage company wanting to be still involved in an accelerator, we're not looking, if you have a $15 million valuation, to take 2% of your company. Does that answer it, Sandy?
Yeah, that's great.
Yeah. So great. Thank you, Sandy. Thank you for joining us. And
thank you. It was fun.
And I think what we'll do is we'll try to see if we can enter into this next stage here. We have a couple of the cohort companies in our cohort that are going to just give their pitch for about 10 minutes and have an opportunity for some questions and answers. So we'll wait for Nicholas to see if we can get that up and running. And Ian, there we go. Hey, Ian. Ian Madam is part of Mocingbird, one of our accelerator companies, and Ian's going to tell us a bit about it as if he was. And there's Stacy. Hi, Stacy. They're going to just do a little 10-minute pitch for us about Mocingbird. Let me give a little background, just because I almost cannot, given what you guys do. So just so you all, my last company not my company, but I was a co-founder of, led by Kirk Keith, was a company, Modio Health, and it was a provider data management and credentialing platform. We were lucky enough to do this without an accelerator, and 4 years later have an exit. Our company was acquired by a very large staffing company in the cloud-based credentialing space. And when I came across their team, I was so impressed with what they've done in this space, and the approach that they're taking, that and having such a great knowledge base about credentialing from my previous life there with my last company, that we brought them into the accelerator, and we're very excited about working with them moving forward.
Amazing. Thank you for having us today.
Yes, thank you.
All right, everyone. Well, we're really excited to be here. Special thank you, Gary. We've loved every bit of today. I have, as usual with anything that InnovatorMD and GHIN puts out there, it's incredible. So to be here, a part of this network, is very, very special to us, and we are grateful. I'm going to share my screen and dive right on in to what Mocingbird is all about. So give me a moment, please. Hold on. I'm getting a lot of tips on how to share my screen. Literally in the directions. Okay. Can everyone see me all right? Yes. Ian, I'm up?
Yeah.
Okay. So Stacey Harris, Director of Sales for Mocingbird. I'm joined here today with Dr. Ian Madam, co-founder and Chief Strategy Officer. Mocingbird, you can see our tagline here, you take care of patients, we take care of you. We're going to start off because a lot of the audience from most of the sessions that I've gone to are clinicians, and particularly physicians. I can't see anybody in the audience right now, not even myself, but I did wear this white shirt thinking it was a little bit kind of clinical. I'm going to fake a doctor. I am not a physician, but I did wear it, and I would like to put out a diagnosis before we start out to many of you physicians. And Ella, you just touched on it. You're a tricky group. You don't really like change very much. And Mocingbird is essentially changing a process, albeit a broken process, but we are changing a process. So I want to start off with a little question to Ian and hear a little bit more about the background and why you think it is that change is so difficult in the healthcare space.
Yeah, thank you, Stacey. I think that change is hard for people in healthcare, physicians, but all clinicians alike. One of the things that we're trying to control, we don't like the loss of control. And part of that comes from what we do on a regular basis. We're taking care of patients, we're following literature, but it's not a truly controlled process, right? We are going with the best information we have possible, taking care of people, and then, we kind of see what happens, and hopefully we get good outcomes on things. So we like to control what we can control. And when new processes come out, we automatically discount it, saying that's not going to work. A little bit out of fear of losing some control, and a lot out of fear of somebody is just trying to add more to my plate because nobody's in my corner. And that's a lot of what we feel as clinicians out there. And that's true based on history. What George Fernane, our co-founder, and I set out to do is, let's put it through the lens of us as the people who take care of people, and work on a process through our lens, and hopefully lend some credibility there and say, we're trying to make this better. I'm trying to make this better for myself. George is trying to make it better for himself. So hopefully this all works out for everybody.
I love it. Thank you so much for sharing that. So let's go. Mocingbird is a platform and an app I'd like to put out there for administrators and clinicians to automate the process of managing medical licenses and certifications. Our mission is to improve medicine, patient care, and clinician wellness by eliminating the chaos in continuous education management and delivering high impact learning. I love to show this. We are not credentialing. So what we like to say is here at Mocingbird, we love our friends in credentialing. We have many partners who have actually given us their blessing and are partnering with us because we essentially take over where they end. We are the middle puzzle piece in a large picture that we have found was where there was a huge and enormous amount of burden on the physicians stress, inefficiencies, and also on the administrators tasked with managing it. What do? We tell you what you need to do, how to do it, when it's due, and then we connect you with relevant learning materials to get it done so that everything else that you learn, since you're continually learning, is exactly what you want to be learning to benefit your careers, your interests, and essentially your patients, which is what you're all in it to take care of the most. The challenges and risks in this space, there's numerous, but as telehealth is on the rise, where our value proposition is extremely recognized, there are even more. Each license has a different date that it's due. Every state is different. All the boards are different. You have expirables, some on your birthdays, some on, when you actually were licensed. Tons of documentation, oftentimes duplicated. I need it from here and there, stored in all different places. Not a full amount of oversight. The risks on that are becoming out of compliance. Recently, there was an example in Delaware where 2 nurses were with lapsed licenses for just 7 months, $180,000 in a settlement to Medicare, and that doesn't even take into all that it was. So it's a really big problem. And if you really put the lens in on it, it doesn't need to be so difficult. And that's what Mocingbird is here to fix. So mitigate risks with Mocingbird. We track it, provide tracking and updated license requirements and regulations. We have a rules engine, a proprietary rules engine that is built knowing all of the rules, what they say, putting them in layman's terms, and then applying it to every single cocktail of licenses on your own personalized dashboard. As I say all of this, to anyone out there listening to me right now, if you're not personally challenged with this, maybe you're retired, maybe you have the most fabulous support in the world, you don't even have to touch this. I doubt it, because even still, you have to take the continuing medical education required. What I would say to you is ask around, ask your peers, ask another doctor, ask a nurse. Most importantly, hop down to your med staff office. See how they think about it. Do they go to bed not worrying? I guarantee you the answer is yes, and Mocingbird is here to help. So for you and your organization, you have a credential dashboard. Again, personalized to you, looks super easy, but the back-end engine and our rules engine that supports this with all the algorithms built in is phenomenal, led by an incredibly talented development team. You will have all of your tasks listed step by step. Again, different for each. Each state is different. Automatic notifications coming both on email and on app. And then our CME marketplace, which we're very proud of, because for this, and this is what's super fabulous, is we tag courses with relevant keywords and state relevant metadata. So what's happening is if there is a course and it's needed for Connecticut, it's going to say Connecticut requirement taken. And we do that for all the courses we have. So we're thrilled to partner with many different content providers. We do not create content, we host content. We partner with various groups who have the state requirements, other requirements, very highly vetted, qualified courses. And then also we have wonderful partners like AdaptTrack. They are actually making it possible to get CME credit for just conversations in your normal day workflow. And Inflow, who's also putting an audible ear on everything in a really, really wonderful way. It's not sounding like a robot, it's sounding like an audiobook. So we're really happy to be working with some of these partners. And then the admin dashboard. So this is the bird's eye view across your entire organization, showing you at a glance. You can drill down to log in as the user, to see exactly what's due, to print their files, to upload, one-click upload, and also reporting features. And what we're really pleased to say is we take user feedback very seriously. So most of the reporting and everything that you see within development is we have focus groups with these admins, and they're telling us exactly what they need to make their jobs easier. Growth. Really pleased to say that we're finding a lot of traction within our health systems, innovative companies, disruptors. Telehealth is exploding. The concierge services, channel partners, basically anyone who works with clinicians has identified this as a problem area with Mocingbird as a clear benefit. And we're really happy to say that the marketing and the word is out. So we are having increased visitors on our website, and an ask for this entire network and anyone watching today is check us out and spread the word, because it helps. Customers and partners, so you can see here, growing. We have many paid pilots going on, many already onboarded, ready customers, and plenty of channel partnerships. CME partners, like I mentioned, wonderful content providers that are working with us and enhancing our categories every single day. And then our team. There's a fabulous book that I love. And if anyone is so inclined, please read it. It's called Rare Breed. And they speak of audacity. Audacity is a cocktail of nerve, radical vision, and unshakable self-confidence. It's having the guts and vision to see possibilities where others see boundaries. And I would say that's every one of the members on our team. And just as importantly are our advisors. They are purposefully diverse from a broad range of industry. And we host monthly product boards where they see it, they put their feedback in, they're testing it, they're trying it, and they're letting us know everything that needs to be from the vantage point, and it is very valuable to have this wonderful team. I am right on 10 minutes, which I have to say is not so easy to do. I'd love to open it up for Q&A, and just a special shout out for anyone listening. I will be at HIMSS in Las Vegas all next week with Sanji Silva, our Chief Product Officer. So if you'd like to learn more or speak with us one-to-one, please reach out and we will make some time to be together.
I couldn't have said it any better.
Oh, well, that's a good thing I said it then. I'm trying to stop sharing.
Oh, there we go. Well, thank you. Let's take a look on our chat to see if there were any questions. You know, we're running way over, so the goal here for this session was to just get an idea of some of the companies that we're working with to give them an opportunity to pitch. But just so you know, Ian and Stacy, what we're going to be doing with this is it's recorded. It's going to be posted on MedLabs and be posted on the network, and we'll be promoting Mocingbird as we move forward. So this was just kind of an end of the day. So thank you for giving us a feel for Mocingbird and what you're doing. And we're really looking forward to having you guys be part of the Accelerator moving forward.
Thank you, Gary. Really appreciate it.
Sure, of course. Have a great evening.
Thank you.
So Nicholas, were there any? Yeah, so we'll do a little closing statement. Okay, great. We'll just do it here. So I would like to take this opportunity. We just gave you a little flavor of one of the companies that we have in our Accelerator cohort. But now I'm going to go into closing mode. Global Health Network, Impact Network, and our team would like to thank you for attending the session. Again, I would like to thank Uli Chetapalli and InnovatorMD, as a sponsor for their conference. This was the first year of the 3 years that we sponsored so far that we had our own half-day session, and our plan is to continue this moving forward with InnovatorMD. I hope this gave the audience a flavor of what we're trying to create from a clinician perspective. We do really encourage all clinicians to join our network, get actively involved, participate as investors, as advisors, as mentors, actively get involved in the evolving digital health revolution. And again, this is just the beginning. This is the idea is that this is supposed to foster your interest so that once you join, that you continue to be involved, continue to educate yourself, collaborate, communicate, and actively participate. So thank you. Thank you for sticking with us throughout the day. And we look forward to continuing the collaboration with all our clinician colleagues and startup colleagues. Thank you.